Good morning, everyone. I am Rhonda Hudson. I'm the president of the Jamaica Emergency Medicine Association. We are happy to welcome you this morning to our annual conference. Last year was a rough year for everyone, and it turned the world upside down, including the conference for JEMA. And for the first time in our 22 years, we were unable to host and produce our conference. We are happy that we are. I am Rhonda Hudson. I'm the president of the Jamaica Emergency Medicine Association. Excuse me one moment, please. Years we were unable to host and produce our conference. I do apologize, ladies and gentlemen. We had some technical issues as we seem to have these days. So thank you for your patience. And as I was saying that I'm happy that we are able to restart our annual conference, which over the years we believe have produced educational fare suitable for everyone who practices in Jamaica, whether you're doing emergency medicine or not. And this year is no different. We are happy that we've been able to iron out the bugs and be able to come to you in this way. We thank you for being willing to spend your Sunday with us. And I know that today there are a few competing events. So thank you so much for being here with us. And we are going to have a guest speaker, Dr. Aaron Sayal from Toronto, Canada, and he has been a gem with us and Jamaica Emergency Medicine Association. Yesterday, he conducted an orthopedic workshop with our residents, and this went down very, very well. And we're happy that he has agreed to be with us today to talk on two very important topics. And whether or not you work in an emergency room, we hope that you will find that very relevant to the practice of medicine. And we have with us, as usual, Dr. Glegg later on, who will be talking to us on de-escalating care. And especially in this time of COVID, It is so important we understand what that means and what perhaps that has been looking like in this past year. We're happy to have from Trinidad our colleague, Dr. Joanne Paul, who will be talking to us about pediatric poisoning. And we will start this morning's fair in the usual way with prayer as we ask God's guidance on these proceedings. So I'll invite Dr. Michael Pierre, from a resident of the Emergency Medicine Program, to lead us in prayer. Dr. Pierre?
Thank you, Dr. Hudson. Good morning, everyone. I invite you now to choose your preferred mode of reverence.
We can't hear you, Doc.
Can you hear me now? Okay, good. I see someone say I can be heard. Thank you. All right, so just choose your preferred mode of reverence and we will open up these proceedings in prayer. Dear God, most merciful and powerful Lord, most loving and kind, ever faithful, ever true, giver of all that is good, our protector, our savior, our provider. We thank you for this new day. O giver of life, we thank you that you have blessed us with this new day, that we can meet and share in your glory as we discuss and learn about some hot topics in the tropics. Lord, we know that some of these topics, some of these situations are things that we encounter on a regular and even daily basis. So we thank you for providing us with some of the best minds you've created to impart their knowledge on these subject matters with us. We ask you to bless them, O Lord, as they speak, and even now, Father, as they prepare, that they may bring across their points as they intend. That we, Lord, the audience, may our minds be open to receiving these words of wisdom. Lord God, we ask that you bless these proceedings, that they may go on without any major issues. We pray for strong internet connections and stability. We pray, God, for good mics and clear video quality. We ask you, Lord, for blessings and guidance for the organizers working behind the scenes. Be with them as we go along. Show them, O Lord, answers to situations that may arise. Father, we know that there are many who could not be with us here today. We pray for their health. And, oh Lord, we pray for our dearly departed. We pray for their souls, that we may join them in glory with you in heaven when you call for us. And, oh Lord, even now we pray for our program residents who have fast approaching exams. We pray and claim from now, Lord, passing grades all around, and we thank you for them. Jesus, in your word, you said, whatever we ask for in your name, you will do it to glorify the Father. So all of these we ask for and claim and thank you for in your most holy and precious name. Amen.
Thank you, Dr. Pierre, for your prayers and your blessings and asking for the blessings on our proceedings. Just a few, what we may call a little bit of housekeeping. There will be questions throughout the presentations, so you will see them coming up in the chat with a link to answer those questions, kind of like a polling on your stream. So we're going to ask that when you see that link come up, to please press the link and answer the questions, and we will then discuss the answers at the end, or the presenters will do that. as well as to remind those persons that in order for you to receive your CMEs, apart from paying your fee, you will please be required to fill out our evaluation form, which you will get at the end of the the day's proceedings. That will also be a link, and we ask that you do that so that we can ensure we give you your due. All right, so at this time, we'd like to ask that you prepare your hearts and minds to receive a presentation from our own Dr. Simone French. Dr. French is a graduate of St. Andrew High School for Girls. So sorry, Dr. French, and a member of the St. Andrew Hockey Club. She completed her MBBS training at UWI Mona and did her internship at the Spanish Town Hospital. Soon after, she completed her Master of Science and Doctor of Medicine degrees in Emergency Medicine at UWI Mona. She's the current Medical Director of the Emergency Medicine Division at the University Hospital of the West Indies and a lecturer in Emergency Medicine at UWI. As a current Medical Director of the Emergency Medicine Division, Dr. French sits on the task force convened in February 2019 to respond to the COVID-19 pandemic. Perhaps that should say February 2020. Dr. French is one of the first physicians trained in emergency medicine in Jamaica. She's the first emergency room physician locally to acquire ultrasound training by the Missioner Institute in Canada School of Medical Radiation Technology, UWI. And she's a passionate advocate for the use of ultrasound at the bedside in the emergency department. And anyone who knows Dr. French knows that that is true. This to enhance clinical decision-making and diagnosis of acute pathology. She is a lecturer in emergency medicine at the University of the West Indies Mona campus. It gives me great pleasure to present to you, my boss, and our director, Dr. Simone French, to speak to you about emergency department overcrowding, the pandemic edition. Welcome her.
Okay. Good morning, Dr. Hudson. Thank you for that robust introduction. I know that, you know, I don't think I've ever considered myself your boss, as classmates, both prior to and during the DM Emergency Medicine program. Thank you for that welcome. And thank you very much to the Jamaica Emergency Medicine Association for inviting me to present this morning. I would also like to point out that this is the first time that I'm opening a conference. So I am new to the headlining role, and I do hope that I will do you guys justice. So this morning we're going to talk a bit about emergency department overcrowding, which is an important topic for us, and how the pandemic has affected that. And in order to do so, we will have to step back a bit to look at what has happened pre-pandemic. So the story really starts before the pandemic. Not sure why this is not changing. Okay. My slides are not changing. Okay, my slides are not advancing. I'm not sure why. Okay. Okay, there we go. So this is where I work and where Dr. Hudson works. This is the entrance, the ambulance entrance to the Scotiabank, well, what was the Scotiabank Accident and Emergency Unit, now referred to officially as the Emergency Medicine Division of the University Hospital of the West Indies. And this is where I'm now presently medical director, having taken over from Dr. Jean Williams Johnson, who gave sterling leadership for over a decade. The pandemic, as Dr. Hudson pointed out, or the task force that managed the pandemic was convened actually at the end of January of 2019. We all know that the emergency area that relies heavily on input from other areas in order to be able to deliver short waiting times and a high degree of patient satisfaction, which everyone wants, both patients and staff alike. And so rely on these areas and others, areas such as radiology, labs, the wards, subspecialties, and the critical care areas to allow us to achieve that mandate. When we speak about emergency department overcrowding, it's always in the context of a model that is really a process flow model, which sees persons entering the department, going through several processes or sub-processes that impact their transit to the department and ultimately affect our ability to deliver that high level of care. And some of these processes are shown here. This was actually done at the time prior to the pandemic. And at that time, all the major processes that we were concerned with was staffing and bed occupancy within the hospital. And those areas are therefore highlighted in red, and also significant issues with getting medical tests. And we were very focused on reducing waiting times by attacking as best we could those areas or those issues. So as I said, the model of emergency department overcrowding speaks to a process flow model. And as it relates to the flow from the emergency department, in the same way that the input, throughput, and output affects your transit in the department, it also affects your transit through the system. So if you look at the emergency department as a segment of the system, there are factors related to the input into the system: demographics, health status, insurance status, availability of alternative sites for care, and perceptions of quality. And that speaks to what comes into us. Not mentioned here specifically, but of importance, is the availability of organized ambulance services that feed into the emergency department in a controlled manner, as opposed to the absence of same, where patients arrive haphazardly in an uncontrolled fashion. And this also affects the flow through the system. Within the system, within the department, there are factors related to the registration process, triage, care processes, most significantly staffing and specialist availability, diagnostic services, etc. And then once one leaves it, in order to leave the to be somewhere for you to go. So there must be bed availability, and to facilitate bed management, there should be tracking of beds. There should be capacity within the critical care areas, and where necessary, if there is transfer that is needed to facilitate patient care, transport services should be available. And there is the consideration of community discharge as a way of relieving and decompressing beds, making beds available for incoming patients. So I'm going to posit to you this morning that we can look at the past year in 3 phases, and I'm going to posit as we go along a 4th phase. So for the purposes of this discussion, I've chosen to look at it as a pre-pandemic, the early pandemic, and the actual pandemic phase. So this is how the pre-pandemic phase started, and it may surprise some of you to note that in the pre-pandemic phase, we were in fact burdened significantly by overcrowding. This slide is taken from a presentation actually done at the beginning of January 2020, before we actually contended with any pandemic patients. And this was a presentation done for the senior directors of the hospital. And as you can see, all was not well. This is the actual main area, the level 1 and 2 area. And this was the kind of overcrowding that we were experiencing. And it was at a critical crisis level. This was compounded by this second most important problem at the time, which was low staff numbers over all categories, but most importantly, across the nursing category. I think that cadre is the most severely affected where staffing is concerned. At the time, we had what I refer to as inversion of physician staffing, meaning that we had more junior doctors or SHOs than persons at the medical officer level. And this overcrowding was chronic. At the time, we actually had our isolation unit existed. It was there, but it had actually been, the staff clinic of the hospital had been relocated there at the direction of the administration. And so functionally, we did not have an isolation unit. We had a newly introduced electronic data system, which was causing slower entry and of the usual problems with central lab investigations and access to radiology investigations in a timely manner with portering issues and so. So the pre-pandemic period was not a healthy, vibrant period. This is what the department looked like at that time. And I would just want you to ignore these red lines for the moment. So these areas here, we have the main level. The department is divided into 3 distinct areas: level 1 and 2, along the lines of the emergency severity index triad system, where we treat our sickest patients, is not displayed here. We have a level 3 area for middle acuity patients according to the ESI. And then this area, pre-pandemic, I wanted to show you because this underwent the greatest change. So this is the level 4 and 5 area. And pre-pandemic here, I hope you can see the pointer. Let me just bring it up again. I hope you can see the arrow. There we go. All right. So pre-pandemic, these rooms here were all used for seeing patients. All right. This was our fast track area, room 1 to room 7. We had patient bathrooms, etc. We had a procedure room, a treatment area, etc. And here in this corner, you can see our isolation unit. Okay. And the nursing station that relates to that isolation unit. And pre-pandemic, room 1 housed the pediatric or child health services, and they would see children presenting between 8 and 4. And in room 2, we'd have gynecological services. And then these other rooms were used by the emergency room team to see fast track patients. I'm having, come on, change. Not sure why this is sticking. Okay. All right. So this would have been towards the end of December 2019. And at that time, we began to hear news of a virus in China that was rearing its head. There was some talk about it at the end of December into the early January. And the WHO designated this situation a public health emergency of international concern. And by the end of January, the UHWI had convened a task force to prepare for what was coming. So the task force deliberations led to some initial modifications of that level 4 and 5 area to be able to accommodate isolated patients. We only had 1 isolation room, and this was thought to be inadequate. And so rooms 5 to 7 here were taken out. This area in blue was taken out and enclosed in order to facilitate the creation of doffing areas, adequate patient entrance and exit, and in order to house an additional 3 patients to increase our isolation room capacity to 4. The floor was not ideal because the area was not purpose-built for same, but it was felt to be the best we could do under the circumstances, and it would mean that room 1 and 2 patients would still be treated in this area while the pandemic was in progress. I'm just giving you an impression here for our main isolation room that you saw in the corner. So just to orient you, staff enter from this corridor here into this little anteroom. The ambulance area is on this side, here to the left. And so a patient arriving by ambulance would be taken, or from outside would be taken through this anteroom into the isolation room, secured there, and then the staff see the patient on direct visualization. There's also a camera in and an intercom system, and the patient has their own bathroom. So this is how the isolation area was set up. The main isolation room was set up. The other rooms did not have their own bathroom. They were simply enclosed rooms with 4 walls that we pulled everything out, pushed the stretcher in, oxygen cylinders, monitors, and used the rooms for patient isolation. Those first 3 rooms that we had were actually retrofitted for negative pressure, and the main isolation room had negative pressure. Now, despite all of this, I entered 2020 in a happy mood. I'm actually born in December. It had been my birthday. I had the opportunity to interact with friends and family. It was a good end of the year for me personally. And as I always do at that time of year, I made my goals for 2020. And among those goals were the pursuit of leadership. Be careful what you wish for. Can anyone recall the date that the first COVID-19 patient was isolated in Jamaica? If anybody can recall that date and put it in the chat, Dr. Hudson, you can let me know if anybody got that right. I certainly remember that day very clearly. The day was March 9th, right? And on March 9th, I got a call while driving to an appointment to say that a female patient from the UK had arrived and was in a car waiting to be isolated with symptoms suspicious of COVID-19. I immediately canceled my appointment, turned my car on and headed back to the hospital. And in short order, having completed the installation of the intercom, which was still going in, we had to hold her for over an hour to get that done. But then we isolated the patient in that nice main isolation unit. By March 10, it was breaking news. This lady had been confirmed as being positive for COVID-19. And that's where our real pandemic experience began. So this slide shows you the actual admissions to the university hospital in the preceding year of the pandemic, starting here with our index case that arrived on March 9. And you can see that our early pandemic experience, the numbers were relatively low. At that time, there were tight border controls. We were actually on lockdown initially with no one being allowed to enter the island. And so the focus was on preventing imported cases, picking up imported cases at the port, and admitting all suspected cases to hospital as a strategy for the early pandemic management. The mantra was flatten the curve. And this meant keep our numbers from getting out of control and becoming unmanageable. And certainly this strategy was beneficial to us because it allowed us to make the necessary adjustments that we needed to do to prepare for the pandemic that was to come. At this time, our focus was on staff education. We literally had daily staff meetings to orient the team, focused on operational changes and on guidelines and how to wear your PPE. We were supported extensively by the public health team and occupational health team in that regard. And so we did what we could to prepare the doctors for the changes in the physical structure and how they should operate. And in that period, I think we did very well. The country was getting a passing grade. We had succeeded in flattening the curve. And at that point, it was kudos all around in social media and everywhere else. As time progressed, the government in June announced reopening of the country, which was to be a limited reopening on June 1st, extending on June 15. And in this period, persons were allowed to come into the country. And the idea was that they would be the measures to be put in place would be a sensitization protocol, mandatory 14-day quarantine, and persons who were coming from outside of bubble countries, and bubble countries really were countries with very low incidence or no incidence of COVID-19. So pretty much the main countries that we received travelers from, the UK, the US, and Canada, would not have fallen within that group. Those persons were to be subject to mandatory testing. In short order, that was changed, and the revision really related in large part to the diaspora, where Jamaicans returning home were not required or mandated to do testing, but they were to comply with quarantine and to be tracked on the Jam COVID app and followed by the Ministry of Health personnel to be released to mix in general society. You can see that once we reopened in short order, our numbers started to climb. And this for me is when the real pandemic experience began. This period was marked by by community spread. Initially, we had imported cases, then we went to imported cases with clusters, but now it was clear that there was spread in the community, and the numbers rose quite precipitously by mid-September. Fortunately, by the end of September, there was a reduction, and by the end of October, things had improved significantly compared to the previous 2 months. Now, in this time, we were challenged in the emergency department. The 4 rooms that we had simply could not work, and we had to pull other rooms into use for isolation. So we had expanded our isolation capacity to 7. This was still not enough. And as such, patients spilled over into our level 3 area, which was part of the non-COVID corridor that we tried to maintain for usual care patients. But that area was now pretty much filled with patients who had or were suspected to have COVID, with no separations other than screens, very little social distancing, and staff operating in that area in PPE. But as I said, without the usual requirements for isolation. On the non-COVID side, with the low-risk patients, we also struggled with unacceptably high levels of overcrowding and inability to maintain distancing. For the first time, we began to see emergency department staff becoming infected with COVID-19. Now, up until this point, other care teams, ICU, internal medicine, had staff members, but we flew our flag proudly to say we had kept ourselves 100% COVID-free. All of that changed. Indeed, one of my young doctors was admitted to ICU, and this was a particularly challenging time for him and frankly for me. The implication was clear. The effect of the overcrowding was clear. Fortunately, the surge settled, all staff recovered, and we were able to push those patients back out of the department into isolation spaces as the numbers reduced, and we breathed a sigh of relief. In November and December, our numbers were more manageable. Then came Christmas and New Year's. At this point, not surprisingly, and I think we all anticipated because Jamaicans love Christmas, it's our favorite time of the year, and it's the order of the day is party. And at this point, the country was wide open. Our borders were open, schools had reopened, and with community spread firmly established, post-Christmas, we saw a surge. And that surge, as you see, has continued to go after Christmas, after New Year's. Unlike our previous pandemic spike, which spiked and came down, this surge that started at the end of December has just kept on going. And given the current situation with community spread, really widespread disregard for mask wearing, social distancing, and an insistence on gatherings, even in the face of stern admonitions by the Ministry of Health to do otherwise, the lack of enforcement by the security team as it relates to those gatherings, not surprisingly, this spike, having started, shows no signs of abating. Additionally, the positivity rate, which was formerly single digits, so in December, you'd have found a positivity rate of around 5%. At this point, the positivity rate was in the high 30s and at times has exceeded 40%. Staff became sick in large numbers. And when I say large numbers, I do mean large numbers. At the end of February of this year, we had over 150 staff members from the university hospital alone that were out sick with COVID-19. So we had a reduction in our capacity to offer care, but the patients still kept coming, and they kept coming in large numbers. It was clear we were overwhelmed. And at this point, I would like to posit that we have for some time been in infectious disease mass casualty mode, certainly in my department. The definition of a mass casualty is in fact that your resources are overwhelmed. And we have been overwhelmed both in terms of physical resources and manpower resources to manage patients in an efficient way for COVID-19. Faced at time with patient needing admission who we could not accommodate for long periods of time, we opted to offer them or to advise them to seek care elsewhere. That meant National Chest Hospital, which was just 10 minutes away, or the Kingston Public Hospital. Those hospitals are now full. So this is not an option. We have moved our fast track area from from room 1 and 2 into the orthopedic clinic area in order to free up additional isolation space, and now have increased our isolation capacity to 11, but we still have patients outside of those areas much of the time, awaiting a bed, awaiting a room. So this is our current situation. So this is the same fast track area I showed you. So now this entire block pretty much is given over to isolation. This entire block is given over to isolation. This is the main isolation unit and the nurses station. And the areas that used to function here, room 1 and room 2 treatment room, those have all been moved over to the orthopedic clinic to allow us to have this space. In reception, we have also used the triage room, is our overflow isolation space for very sick persons and for any person that needs resuscitation that cannot be accommodated in the main area. We also have an area outside of triage where patients are seated in a chair, where we can deliver oxygen in a chair. And we have these tent areas that were created earlier on. So the tent area, my staff refer to it as Tent City. This was an area that was created early on in the pandemic when we recognized that not everyone, at the point in time when we were able to send patients away who had mild symptoms, it was recognized that we needed somewhere to be able to evaluate those patients, swab them in PPE in a private manner, and allow them to go home with the relevant advice and prescriptions. And this area was created. So we have these sampling tents, a refrigerator to store samples, an area for the staff to don and doff. And this worked well for us initially. However, this process is very time consuming because for each patient, we'd have to don and doff and change PPE. It also meant we were burning PPE very fast, and PPE is very expensive. Fortunately, Mr. Metriciaga and his group donated to the hospital these swabbing booths. And this really meant that we could now swab walk-in patients and allow them to go home without the need for PPE. And it was a much quicker and more efficient process. And you can see one of my doctors here, Dr. Cousins, posing for us as she's swabbed by Dr. Metalor, one of the doctors from ICU. This booth was actually positioned in this particular way to allow us to swab stretcher patients. And this became necessary as at the end of last year, we were asked to begin to swab all admissions to the hospital. This meant our work rate for swabbing went up, but we were able to use a swab booth. So this at least allowed some efficiency in the process. I don't know if anybody knows the positivity rate for samples tested for COVID-19 in Jamaica at present. Over 40%, under 40%? All right, well, yesterday the positivity rate for samples tested for COVID-19 was 38.4%, which is just under 40%. But it has been in the last 2 weeks at times over 40%. And this is of concern because it speaks to the capacity for spread. We do a lot of sampling in the emergency department now, as you can see. If you compare, and you're going to look at this slide is a little backwards, it might feel, because this is August 2020 here to the right. If you compare August of last year to now, say February, we have doubled the number of swabs that we're doing. And it's partially because of admission swabbing, but also because the increased rate of persons walking in to be evaluated who require a swab. We also swab staff members who are suspected for COVID-19 at the discretion of and the guidance of the Occupational Health Department. The figures for March are incomplete, but we expect that is going to exceed the figures for February. Similarly, the number of positive cases has significantly increased compared to last year, where there were just over 150 positives in August of 2020. And here we have exceeded 300 positives from the A&E samples in 2021. Certainly in March, that number exceeded 500, and we expect that in February, that number exceeded 500, and we expect that the trend is going to continue for March. The other positive samples would have come from the swab booth that is used to swab asymptomatic patients for travel, ICU, where persons are re-swabbed, and the wards as well, where persons are re-swabbed at the discretion of the managing team. Our positivity rate in A&E, not surprisingly, is above the average positivity rate because we are testing symptomatic patients, and has gone as high as about 27%, 28% in February. And none of this is surprising to us because as physicians, what we see coming through the door bear this out. Our total patient number over the period has fallen, right? And it has fallen quite significantly. And this is the per day rate. It has fallen as low as 60. And in that period, it actually allowed us to manage the patients. For the first time, it felt like there was a right sizing of the patient population and our ability to see them quickly. And this has been referred to in the literature, where one of the pandemic effects has been that it has reduced the attendance of non-urgent cases, certainly at the beginning of the pandemic, and caused what is referred to as a right sizing, felt meaning that the numbers of patients attending versus the number of staff that we have the ratio was more rational, and it allowed better usual care. However, we still had overcrowding, and that was largely because our statistics in terms of seeing patients were excellent. We were getting to patients and seeing them quickly and referring them, but there were no inpatient beds for these patients to be transferred to. There were often delays in admission. And so despite all of that, that picture that I showed you before was our reality. So at this point, I just want to review the concept. So in the pre-pandemic stage, we've still had problems. We had overcrowding, we had staffing problems. We were focused on reducing waiting times and increasing patient satisfaction. As the pandemic began, the COVID numbers were manageable, largely because of the reduction in attendance of patients to the hospital. And the fact that at that stage, it was largely imported cases, which were few, heavily contact traced, all patients had to be admitted. It was a good practice for us, a good preparation for what was to come. As the pandemic progressed, the high number of patients overtook us. And in the context of reduced clinical space, we began to be overwhelmed. However, we recovered from that initial surge. And at this point, we're seeing our second surge. This is a more prolonged engagement in terms of the duration of this surge, and it is expected to be so based on the fact of what is happening in the society with persons just not complying. I suppose COVID-19 fatigue and mass fatigue. People need to get back to their regular lives, and this has meant that not only are we challenged for space, but as our doctors became sick, our staffing levels fell to critically low. Both physicians and nurses. At one point, we had 5 nurses reporting for work in a department that requires 17 nurses. And that those 5 nurses must be spread across level 1, 2, 3, and the isolation areas. And you can imagine the challenge that was, and the inadequacies in care that could arise from such a scenario. Fortunately, our staff is beginning to rebound from COVID and returning to work, and that situation is improving, and additional measures are being taken to procure staff, particularly nursing staff, which are important for monitoring. However, as indicated on the slide, it is our expectation that at this point, the numbers are going to continue to rise until we get to the point where there is a significant level of vaccination. The number in the population is 60%. And so we have to be prepared for a longer engagement as healthcare professionals. In the pandemic, this is the sort of patient flow that really accrues. And this affects overcrowding because it creates additional bottlenecks. So typically what we do is we apply a screening tool as the patients present and basically have a general separation into respiratory cases and non-respiratory cases. And those who are respiratory and obviously hypoxic are going to require isolation, rapid antigen testing, and admission. those that are normoxic with normal oxygen saturation levels still need to be evaluated in the tent and have their swabs done. Most of those patients will go home, although a few of them, we may find when we have them in the tent that we find additional issues with comorbidities or other non-COVID presentations that require them to be isolated. On the non-respiratory side, if the person screens positive, so they have a history of cough, even though that's not why they came for abdominal pain, suggestive of appendicitis, but they do have COVID symptoms, then those persons were going to be isolated and seen within an isolation space with rapid antigen testing and PCR and admission. Those patients who on initial screening are negative for COVID, and remember this is verbal screening, are allowed into the usual care corridor. And here we try our best to maintain, here the maintenance of social distancing is important because we recognize that there may be asymptomatic persons among that group. And certainly all of those patients now are tested, are swabbed, and because they're spending so much time in the emergency department, we have decided to test them not on admission as initially requested, but on referral. This allows us to get their PCRs back in short order, and not surprisingly, a few of them pop up positive and then have to be isolated, placing further pressure on our isolation space and our ability to receive patients from other areas of the society. Those who can are sent home. Those who have to be admitted are admitted if their PCR screens allow. One of the bottlenecks that occurs here is that patients who are within this usual care corridor, who have been swabbed, but who don't have a PCR result, there are 2 wards set aside to receive those patients until their results become available, Ward 2 and Ward 5. So if there are no beds on Ward 2 or Ward 5, the patients remain in A&E until the results come back. And in some instances, we do rapid antigen testing to try to push these patients along. Of course, the rapid antigen test is only useful if it is positive. And so if it is negative, it still holds up the patient's progress to the ward. So this is just one bottleneck that is created by the whole context of COVID-19 itself that didn't previously exist. So what are the challenges that we're facing? There are many. Spacing requirements, inefficiencies in bed management, staff issues. We've mentioned the low numbers, but of great significance is the low morale and fatigue. This has been a 1-year engagement. We have persons who have never had leave in that year, except when they are sick. The hospital inpatient teams have separated into COVID and non-COVID teams in an effort to protect care teams if persons pop up on one team. And it has been successful in the sense that entire teams have been taken out and it has protected other teams, but then it places a stress on staffing. And of course, all the staff are human beings and have their own COVID fears. Monitoring is a challenge for us at this point because of the low numbers of nurses in particular. Support services were also hit hard by COVID, especially over the past 2 months. And so porters were out sick, cleaners were out sick, and cleaning and portering are extremely important. We have to clean every isolation space before we repurpose it for use. Oxygen delivery, we rely heavily on oxygen cylinders. We do not have piped oxygen in the isolation spaces. This means that a heavy cylinder must be trucked in on a dolly, which is not as easy as one might think. I have tried it. And so those things add additional challenges. We've even had supply issues to the hospital because the supplier, IGL, is actually under pressure for the management to supply oxygen. They have run out on 1 or 2 occasions and had to scramble to fix that. And of course, the lack of the availability of inpatient beds, which is multifactorial. So what do we do about this? What are the solutions to emergency department overcrowding? Well, this article, as you can see, is a pre-pandemic article, and it posits several 10 solutions. One is to expand hospital capacity or inpatient capacity, stop regulating hospitals to the extreme. Now, this is a US article, and they are referring to external regulations. In our setting, what is a challenge is institutional policies that prevent us from admitting certain patients to the wards from the emergency department. One such category is the patients on inotropes and intubated patients who in our facility can only be managed so far in A&E or an ICU setting. And this means that when we are challenged with space, these patients remain with us for an extended time. We had one gentleman there for 14 days who eventually succumbed to his illness.
Sorry, Dr. French, we're going to ask you please to wrap up at this time.
Sure.
Thank you.
So there's several other strategies presented on the slide. Just wanted to, and these are all pre-pandemic. I wanted to just highlight some strategies that have been noted post in the pandemic era. This is an article here from Sweden, where one of their strategies was to reduce inflow by controlling their ambulance inflow. This is not an option for us. We don't have a very well organized ambulance system, or patients don't arrive in that way. In the UK, they have noted the use of same-day visits at clinics. Sorry, this is not the UK, apologies. This is an American article where same-day visits at clinics and health centers relieve the stress on the emergency departments, the use of telehealth, and what they refer to as reverse triage, which is where you basically go through your sick patients in the hospital and find the ones that are least ill and can somehow be managed at home and discharge them to make more beds. In the UK, they have noted a drop in ED visits, expanded bed capacity, appropriate staff levels, and efficiencies in discharge plans, better use of same-day healthcare, and NHS 111, which is a telehealth system. Here in Jamaica, the Ministry of Health has made it clear their policy on boarding, and that is that patients should not remain in the emergency department for over 24 hours. And where subspecialty teams have not made decisions 4 hours after referral, according to the Ministry of Health, the emergency room doctor has the right to send that patient to the ward. We're still not at the point where we can action this, but we're working towards it. There is a light in the darkness, and that is vaccination. In our department, the majority of our doctors have been vaccinated or have recently recovered from COVID. There's some poor uptake among some team members, but I think that will improve with time. And of course, we have now moved to start vaccinating the general population. So, in summary, basically, our pre-pandemic principles still apply. There's some additional things highlighted in recent times that seem to be very effective in the pandemic period: right sizing and how it will affect our concept of staffing going forward. Telehealth and reverse triage is something that we should really think about. Efficiencies in discharge processes. And I must pause here to mention strategies for staff recovery. This is a prolonged engagement and persons are tired mentally and otherwise. I want to just pause here to thank my team, my consultants, my medical officers, nurses, ERTs, porters, phlebotomists. They have been great. And I also want to thank those persons in the community, individuals and companies who have shown support for the team. It does, as Jamaicans say, encouragement sweetens labor, and we are grateful. The staff has always been grateful for your support. Thank you.
Thank you very much, Dr. French, for that. And we accept your compliments on behalf of all staff in emergency medicine at University Hospital. At this time, we will be like to introduce to you our next speaker, Dr. Winston Delahaye. He is the Deputy Dean in the Faculty of Medical Sciences at the University of the West Indies and a Consultant General and Addiction Psychiatrist at the University Hospital of the West Indies. He completed his MD at the University of Pécs in Hungary, his postgraduate degree in psychiatry at the University of the West Indies, his master's in public health and a Fulbright fellowship in substance abuse at the Johns Hopkins University. He is an internationally certified addiction professional and a global master trainer of trainers in the treatment of substance use disorders. Dr. Delahaye is past Chief Medical Officer in the Ministry of Health and Wellness in Jamaica, member of the Medical Council of Jamaica, member of the International Society for Substance Use Professionals, past President of the Medical Association of Jamaica, past President of the Jamaica Psychiatry Association, past president of the Jamaica Fulbright Alumni Association, and past chairman of the Bellevue Hospital Board of Management, and the past deputy chairman of the National Council on Drug Abuse in Jamaica. Dr. Delahaye is he established medicinal cannabis, he established the medicinal cannabis unit in the Ministry of Health and Wellness in July of 2017, supervising the registration of over 80 medicinal cannabis products in Jamaica. He's currently launching the first international psychedelic psychiatry center in Jamaica. Ooh. Dr. Delahaye is a former captain of the Jamaica Defense Force. He would like you to know. Ladies and gentlemen, please welcome Dr. Winston Delahaye, who will be speaking to us on all things mental health relating to COVID-19 and the healthcare worker. Welcome, Dr. Delahaye.
Hi, thank you very much, Rhonda. We certainly shouldn't stay so far apart working in the same hospital. I haven't spoken with you in a while. Let me first thank the organizers for inviting me. I've presented at a number of conferences. This is by far one of the better organized in terms of the lead up to today, including today. So really, I think that's a big thing, especially at a time like this, when challenges are there. So my topic is mental health impacts of COVID-19 on healthcare workers, just to establish the contribution from psychiatry. So we were invited, a couple of us, includes me, to serve on the staff welfare committee specifically to provide a wellness team which provides psychological/psychiatric support for colleagues. And that's anybody working in the hospital that I mean by colleagues. And just to outline the process real quickly, individuals reach out with a call or WhatsApp, preferably to one or two numbers. Dr. Mitchell, I must thank her for her contributions to what I'm presenting to you. She's our psychologist in the Department of Psychiatry. And myself. We usually respond, as you would anticipate, with a sensitive, user-friendly, supportive response. We recognize the challenge for individuals to reach a point where they determine they need help and let alone make the call. They don't know who they're calling. They just have two numbers. And so usually the response is, thank you very much for reaching out. We are happy to assist. I'll provide 2 times where we can talk. And then you do a quick assessment. If it's deemed to be an emergency, we recommend, and we've had those, we recommend that the person be seen in the emergency room by the psychiatrist on duty. There's always someone on duty. And then, of course, having agreed on a time for whether video, phone, Zoom interview, we go ahead with that. We internally, and there are numbers, a team approach, not just myself and Dr. Mitchell, but there are others on the team, including our residents. So we determine, depending on the caseload, because at times a number of calls come in. And so we determine who will do the follow-up. We then make that call and initial assessment and then make arrangements for continued follow-up. Invariably, in these times, the kind of cases that we've been getting require at the longest weekly follow-up. That's just the nature of things. And that follow-up may be psychological or psychiatric or invariably both. We also make recommendations. We work. We generally advise the supervisor of wherever the person works if time off is needed. I've never had resistance to that recommendation in all of the months that we've been doing this. It also helps that I have a very long and close relationship with Dr. Bruce, who certainly has been available at all times, night or day. The persons who have called, initially a number of residents and a couple of nurses, and then we started having consultants calling because we're all at the same risk. We all have limits, technicians, and in relatively recent times, administrative staff have also been a part of those calling. So let me just take a little time to outline to you the kind of presenting complaints. And it includes, and it's almost in order of prevalence actually. I made every effort to fill this out in that way. Feeling anxious, insomnia, whether difficulty going off to sleep, staying asleep, or early morning awakening with difficulty going back to sleep. Being worried, feelings of exhaustion, fears, fear for self, fear for family, taking the virus home, and we've had that. Fear for getting sick, and especially at this time, and this is a discussion I've had certainly with at least 2 or 3 consultants in my department, where we are unsure should we get ill, we working there, we're not so sure we have a bed, let alone if we need a ventilator. That's very significant. Sadness, crying, decreased concentration, irritability, both towards colleagues and family, guilt, and that guilt usually surrounds even the need to call, let alone when I'm recommending time off because others are also impacted and so on. That's a common theme across. And being unsure if they should seek help. So having outlined that, I have others to present, but let me just quickly remind you of the criteria for major depressive disorder. And you'll see very clearly, it's a 2-week period or more of a list of 9 things here where you must have number 1 or 2, depressed mood, loss of interest or pleasure in things you found pleasurable before. We call it anhedonia. Weight, appetite changes, insomnia, hypersomnia, psychomotor retardation or agitation in some cases, fatigue, anergia, worthlessness or guilt, decreased concentration, and of course, thoughts of suicide. Have we had that? Absolutely, yes. And so clearly you're seeing where, based on the previous list, a number of persons, certainly in my case, 90% of those I've managed, met the criteria for a major depressive disorder. Other complaints would include complaining or feeling overwhelmed with work, concern about time off, as I mentioned, large crowds in the ER, crowded wards, long ward rounds. Doesn't mean they don't want to do it, that's never come up, but it's just physically exhausting. Anger, frustration about working conditions, that's another common one. Limited resources, including PPEs, feeling unsupported by administration. Heavy is the head that wears a crown, so that's a Carl thing, and I think he manages that well. Loss of a loved one, because we have colleagues who have now lost loved ones, close relatives, and so on. And then a very interesting point I want to make, the announcements. And having worked in the Ministry of Health, I understand those, understand the need to be representing every effort being made. This is not an easy task. But when we hear things like, we have adequate beds in Sarah, and we know that we've expanded and we're above our limit. Let that sink in for a moment. And then, of course, the question of when do we make a decision to stop accepting patients across the board? People coming in tears, saying, we're going. The boss isn't suggesting that we need to stop accepting patients. Understandable concern. There are some areas more impacted than others, emergency room right there, internal medicine, and of course, the intensive care unit. I must point out that trauma, because this is a generalized traumatic setting in the whole country, trauma doesn't have to be specifically experienced by individuals. It can be vicarious. And so even those supposedly protected in terms of workload, the fact that they're exposed to the setting certainly leads to the risk of being impacted by that traumatic experience. Additionally, on top of all of those work-related issues and the issues emanating from that, we would include the general coronavirus issues of social isolation, altered daily routines. The colleagues have children at home doing online classes, supervision of that, the rising case positivity rates, the rising number of deaths, now including family, friends, colleagues, the unpredictability of the situation, because we don't determine how it works, or it wouldn't be like this. Misinformation out there. I personally spend a lot of time in various WhatsApp groups correcting that as it rises, because we can't afford for any Jamaican with the opportunity to take the vaccine to be misinformed and refuse. Colleagues getting sick, quarantines all over the place. My ward rounds, for example, I've had residents 3 different sets in 1 week because of quarantine. So it requires more flexibility, more focus, more concentration on keeping patients well. Colleagues being admitted to hospital themselves would be also one of the challenges. Just some brief tips for coping. Rotating responsibilities. Leadership in a situation like this is critical. However, the pressure is more for that person, generally speaking, who needs to coordinate all of this. We're fortunate if we have persons who have a higher threshold. Many of us do. However, all of us have a limit. And so if we can rotate the responsibilities, that allows for anticipation of a pressure week or 2. So come April 14th, I'm on for a week. you can afford to relax as best you can now, doing your routine work, albeit more than usual, but then prepare yourself for that crunch time. That's much better than staying in a position where, and I have colleagues like this who have reached out for 10 months on, you've been the lead of the team. Doesn't work. Schedule time away from the hospital. We love the hospital. It's why we do what we do, but you need to get some time outside of there in a non-hospital setting. Maintain a schedule of normalcy of life, regular physical activity, very important, outdoors if possible, in a safe setting. A balanced meal, and it doesn't only mean balance, but at the right time. So a balanced meal at 2 in the morning because you're hungry and couldn't sleep doesn't really cut it. Limit stimulants. So, and I use coffee, for example. I'll take another Red Bull and so on. Certainly recommending that we limit these in this kind of setting where anxiety is one of the features of your presentation. Anyway, quiet time alone, just checking in, really focusing on yourself, how you are doing. I can't do that for you. And so individuals need to be able to sit alone, find a space. It could be the car. In fact, quite often, that's what's suggested by persons who come in. Reaching out to friends and relatives, doing your best to not be alone and be isolated. Continuing those tips, safety always, so you can't have any lapse in your safety measures in terms of PPEs and approach to patients. Limit yourself with media exposure, and by that I mean the news, social media, etc. Doesn't serve you well. A hobby would be good at this time, or a new project, especially if you need to be in quarantine. Now is the time to organize that birdcage you always wanted to make. Positive affirmation certainly helps, and we assist with that once you engage with us. And for those who are spiritual, we recognize it's not everyone, but that works. Every religion is a protective factor. I must point out that in terms of coping, there are maladaptive coping mechanisms. And ATOD means alcohol, tobacco, and other drugs. Are we exempt as colleagues from that? Absolutely not. And so really want to highlight the importance of not going that route for your alleviating your anxiety. High risk activities, and it includes things like fast driving. I've had a few colleagues presenting, and that's the way they just really, leave work and press. Doesn't work because you may be pressing back in on a stretcher. And so really want to point that out because it has come up in the past couple of months. Here's a reality that we face. We're in a very high stress environment, healthcare workers generally across the board. Therefore, we're at high risk for depression. We all have some amount of coping, but we all have a limit. When those limits are maximized, then we move over into presenting and meeting the criteria for a major depressive disorder. I'll just quickly highlight some features of persons who cope exceptionally well. It's 3 C's. They see challenge in terms of what's happening, and not one which is insurmountable, but something that they recognize requires a little different approach and so on. That's the first C. They are committed to something, some activity. It can be family, it can be church. I don't know that it helps if your commitment is work, because the work is the issue that we're discussing here now, but it could be work. And then the third C would be feeling that you're in control. And that's one of the challenge, because we're not in control of this pandemic. So really, we recommend that you reach out, get assessed, comply with the management. Do we have resistance from colleagues? Absolutely. So I'll hasten to say, antidepressants are not addictive. If you need them, we can find the right one to work for you. We have sleep aids which are not addictive. So you need not make that concern deter you from coming in. And that management may be pharmaco and or psychotherapy. Take the time required to heal. You didn't get depressed if you are or stressed from one day to the next. And in the same way, you need time to facilitate that resolution of the symptoms you're experiencing. Very important for me to point out that someone else can do your job as well as you and must be allowed to do that. And so if you need to step back, then that should be okay. That's across the board a challenge I found with the persons I've interacted with. Fortunately, I've been able to convince them that that doesn't work. Stigma is a major issue. So it's why we recognize that for an individual to take up the phone to call not even knowing which number you're calling, it means you've really thought it through and you're at the point where you must reach out. Stigma doesn't help the practice we do. And so we want to put that out there so you're aware that it is okay to reach out to get assistance if it is that you think you're not coping. Just highlighting, as I come to a close, some risk factors and prognostic indicators. It would be a family history of depression, only you know that. A previous history of depression in the individual, only you know that. Exposure, again, that can be managed as best as possible, organized time off and so on, takes a little more effort, but certainly must be implemented in any regime, in any facility that we have individuals working in healthcare. Insight, and that comes with checking in with yourself. I kind of started to wake up early. I know I'm having difficulty sleeping off. My husband just told me, or my wife, that I'm a little short and irritable. My daughter probably mentioned the same thing, or son. I wonder what's going on. Maybe I need to reach out. That's insight. Stigma delays reaching out for assistance. And so it's why I've probably mentioned stigma deliberately so on 3 occasions throughout the presentation. And so just in closing, I really want to say that the high stress environment we're in is because of our choice of wanting to help. It's a helping profession. We love it. However, one, we are not gods, none of us, and neither do we have limitless coping mechanisms for stress. We're all at risk. All of us can present with anxiety, with other symptoms I pointed out, and certainly can also present with depression. And so I really want to point out and thank the team, includes my team, for the work we've been doing. We've been high stress for many months, a year. That's long. And it is only with identifying and reaching out, and in addition, rotating the responsibilities, that we can, at best, try to dilute, decrease that exposure to stress, which happens and obtains in our environment. In conclusion, therefore, for a high-risk situation, the lack of control, we're not in control of the pandemic and the spread of the virus, especially in a tough country like Jamaica. The challenges of the Caribbean, I always say, are multiplied tenfold as it relates to behavior in my country. Love it, wouldn't leave for anything. However, we're a tough people, and there are persons who just don't obey rules. Be aware of these risks I pointed out. Be aware of your feelings, your symptoms. Don't minimize them. Do all you can to stay healthy. Trauma exposure, again, doesn't have to be real. It can be perceived, doesn't have to be experienced by you. It can be vicarious. And last but not least, make the call. Seek help. There are 2 numbers there. One is Dr. Mitchell, one is myself. We happily respond. If we get too many calls coming in, then we spread the work out. It's never a problem. Happy to assist. And so on that note, I want to thank you very much again for the opportunity to have presented to you. Thanks again.
Thank you so very much, Dr. Delahaye. That was really, really very informative and comforting in some cases. We will go to the chat in a little while, but in this, because being in emergency room, we deal with this, as you know, and we have all been stressed. And there was a discussion with a colleague of mine recently, and the question, well, she said, perhaps when all of this is over, and I'm not sure when COVID is going to be over, but she said, you know, we think we should all be assessed for post-traumatic stress disorder. So the question is, do you think that perhaps we should have a sort of, I want to say, I don't like the word mandatory, but perhaps should we be assessing our colleagues and the healthcare workers more in a standardized, routine way, rather than wait until they manifest with something when they are forced to,
right,
to be taken off the work? Should that be something, somewhere we should be heading?
Rhonda, I couldn't support that thought more. And so in one, you're recognizing the challenges that we're exposed to, and the fact that we're all vulnerable. The prevalence of depression in Jamaica hovers around 20%. That's high. In the healthcare setting, I'll hasten to say, I haven't done the study. We may have something coming out from this experience, but it's probably around 30. That's 1 in 3. And so screening is the way to go. I do think there's need for a debrief, and a debrief doesn't have to be at the end. There's no end right now. But a debrief to allow persons to ventilate, express their feelings, and in the same setting, a short screen. We'll identify persons who may not be aware. Not all of us become aware. So yes.
Thank you very much. Dr. Guy, are there any questions from our participants in our chat?
Yes, Dr. French. We have one from Dr. Alicia Blackman. She wants to know, what tips would you give a healthcare worker who is also juggling the stress of having family members who have COVID and feeling guilty that they may have contributed?
Yeah, so I'd say a short answer, give us a call. We're happy to assist, because that's an individual specific setting, which will require a little more attention.
Thank you. Do we have any questions or any comments anyone would like to make before we go to our next presenter? Okay, thank you very much, Dr. Delahaye.
My pleasure.
I learned quite a bit. We will now be going on to our keynote speaker, Dr. Aaron Sayal. I hope I pronounced your last name correctly, sir. And Dr. Sayal has been an emergency physician for over 25 years at North York General Hospital in Toronto, Canada. This hospital is a busy community teaching hospital with the University of Toronto, where he is an associate professor. Over 15 years ago, he was asked to run a weekly minor fracture clinic where he follows up emergency patients with minor fractures and acute injuries. From this experience, he created CASTED, C-A-S-T-E-D, a hands-on ED orthopedic course that he has presented over 400 times, primarily in Canada, also to 7 countries around the world. And you would have heard me say earlier, he actually did this course with us, with our residents yesterday in Jamaica. He has won over 20 teaching awards at local, national, and international levels. So for the first of his 2 talks today, we please welcome Dr. Aaron Sayal to speak to us about when X-rays lie. Welcome, Dr. Sayal.
Thank you so much, Dr. Hudson. It truly is an honor and a pleasure to be here. Thank you for having me. And let me just share my screen so we can get things started here, and I'll share my sound as well, of course. Okay. Okay, so I hope you can hear me all. Thank you very much for having me. And I'm not sure if you're able to see my screen. I don't see it on the YouTube feed, but perhaps that's a little bit behind. Okay. Anyways, thank you all very much. It's truly an honor and a pleasure to be here and an honor to present. My special thanks to Dr. Hudson and Dr. Hugh for their kind invitation, and a very special thanks to Dr. French and Dr. Delahaye for those talks in the morning, which were fantastic. And I think it's really amazing to see how many people actually are how are involved in the actual support behind us, like the planning for COVID, and also in helping us deal with the after effects. So I think Dr. French and Delahaye, thanks from all of us. All of us in our own communities have our team that are helping us out, and I really want to appreciate all of your efforts for helping everybody and get through this. This is going to be a little more of a clinical talk. I'm going to chat about X-rays and MSK injuries. That's sort of what I like to talk about. This is Toronto, and I'm proud to represent the University of Toronto as we present today. In the background, you'll see the CN Tower, our iconic structure. This is downtown Toronto. Behind that is Lake Ontario. Clearly not as beautiful as the beaches that we see in Jamaica and in the Caribbean, but we are honored, and I am honored to represent North York General Hospital and the university. I am an emergency physician. I work in the hospital, as mentioned, for a number of years. And I've always had an interest in orthopedics. So the surgeons asked me to run a minor fracture clinic. So after 12 years of full-time emerge, after 2,000 shifts in the emergency department of a busy hospital, I started working in the fracture clinic. And I'll tell you, I learned more in 12 weeks of running the minor fracture clinic than I did in 12 years of working in the emergency department with regards to emergency orthopedics. So the pearls come from the surgeons. And in order to get more of the pearls, today is a Sunday, tomorrow on Monday in the afternoon, I'll go to the operating room. And when I go to the operating room in the afternoon, I'm the assistant. That's me on the right, and that's the staff surgeon in the middle, Dr. Dancer. And whoever the surgeon is on call, I will assist them for their emergency cases. I do it 1 day a week, and I do it so I can learn more about emergency orthopedics. So when we talk about emergency and orthopedics, a lot of these pearls are from the surgeons, and we're going to pass them along. But when we work in the emergency department, right, they're usually in an ambulatory care or a fast track part of the department. There's a whole stack of charts to see, and nobody wants to be the slow doctor, so we go pretty quick and go through them. If we take an x-ray, we see it needs a cast or maybe need a reduction. We look at the x-ray, we see a fracture, that's great, and then we shuffle them off and make a referral to the fracture clinic. This is a typical thing that happens when we make ortho decisions in the emergency department. It's all about diagnosis. It's about ED management. It's about disposition, getting the right patient to the right person at the right time. And this is actually no different for any other emerge decision that we do. We do this for patients with chest pain and headache and abdominal pain and fever. We try to make a diagnosis. We do ED management and then disposition. If we're talking about orthopedics, a typical ED ortho algorithm may look something like this. Someone comes in with some kind of an injury, ankle, wrist, elbow, shoulder. We'll take an x-ray, and if it's positive, they have a fracture or a dislocation, depending on what the x-ray shows. If it's negative, well, they must have a soft tissue injury, unless they have snuff box tenderness. And if they have snuff box tenderness, then we say, oh, okay, then I guess they've got a clinical scaphoid fracture. So the 34-year-old comes in, he has a sore wrist, he has a big fall. If you have a look at it, you probably will pick up there's a gap between his scaphoid and his lunate. That's reasonably obvious. The x-ray shows us that. He gets his expected operation. A 32-year-old lady, she slips, she injures her knee. You can see that she has a dislocated knee. And the x-rays show us what the problem is. We do the expected management. She gets reduced in the emergency department. She gets referred. She gets her angiogram as necessary. 55-year-old gentleman injures his ankle. X-rays clearly show he has a fracture dislocation, a trimalleolar fracture of his ankle. In the emergency department, it's important that we reduce these. So this gets reduced. It gets referred to our orthopedic surgeons, and our colleagues then will manage surgical treatment. But here's a 26-year-old. He fell. He injured his wrist. His x-rays were normal. He did not have snuff box tenderness. But he ended up with an operation. So sometimes the x-rays lie. 45-year-old twisted his ankle, having a difficult time walking, comes to the emergency department. X-rays are done, negative, followed up in the fracture clinic. And when he comes back to see me in the fracture clinic, realize, oh, he needs an operation. So sometimes the x-rays lie. It's a 42-year-old gentleman, a medical legal case I was asked to review, but he injured his knee. And his x-rays were normal, and he was sent home. And 11 days later, he actually had an amputation through his knee. So clearly, in this case, the x-rays lied. And with that sort of as a start, I think we should appreciate that this algorithm of letting the x-ray do all the work is not viable. This is not a solution to the problem because the x-ray is not nearly good enough to do it. It's a good test, but it's far from perfect. You can imagine if you saw a patient with chest pain. If you said, oh, I'll just do an ECG and a troponin. And if it's positive, well, they've got an acute coronary syndrome. And if it's negative, then, oh, they must have some benign cause of their chest pain. I can just send them home. Clearly, This is not an acceptable algorithm. What we need to make a diagnosis is a history, a physical, plus or minus a test. It's very basic stuff we learned very early in medical school. For emergency and orthopedics, orthopedic complaints are maybe 15%, about 10 to 20% of emerge visits. But when they look at lawsuits and complaints, they're disproportionately represented. 25 to 40% of ED lawsuits are related to MSK problems, but they're only 15% of visits. So we don't do that well with them. So that algorithm doesn't work. It clearly fails us. And when we look at these problems that patients have, 70% of the time, it's a misdiagnosis. So the challenge is for us to be better diagnostically. 20% of the time, it's an ED management issue, and 10% of the time, it has to do with disposition. So we need to be better about this. If you like emergency medicine, and I suspect you do because you work in it, then you need to embrace the diagnostic challenge. The diagnostic challenge of emergency medicine is finding the less common, finding the subtle cases, not the true unicorn, not the case of abdominal pain that's porphyria, which rare as it might be. That's going to be, I'm not saying go that far, but find the subtle cases. This is what we need to do. The diagnostic challenge, for all these patients that we see, if this pie is all the patients we see in emerge, most patients who come to emerge, they're pretty benign. They just have pain. They have some sort of anxiety. They have concern, but they don't actually have serious pathology. So they're clearly not a diagnostic challenge for us because they don't actually have anything serious. The remainder of the pie actually does have something serious. And the good news is most of them, it's reasonably obvious. If a patient comes in and injures their ankle, the x-ray usually shows it to us. If a patient is coming in and having chest pain, if they're having an MI, most of the time, the ECG is going to show us. Nobody's going to miss it. This person's clearly having a STEMI. But the diagnostic challenge is finding that small sliver where the presentation is more subtle, where the ECG is normal, but they're having they're at risk of serious pathology, where the x-ray is normal, but they actually have serious injury. This is what the diagnostic challenge is in emerge, and we need to embrace this. And the way that we pick these up, because if somebody has an obvious diagnosis, it's the history and the physical and the test that tells you something's wrong. If your neighbor, calls you and says, please come over, I've hurt my ankle, you can easily look at his ankle and you can say, and if the test is normal, and all we do is we rely on the test. So if the test is normal and all we do is rely on the test, then we're more likely to miss the target. Excuse me for 1 minute. So this patient who's injured their wrist, they don't have snuff box tenderness, their x-rays are normal. What we need to do is a pre-test probability. You have to, every time you interpret a test, it has to be with a pre-test probability. The history and the physical exam is what determines the pre-test probability. You cannot interpret the test. You cannot interpret an x-ray without it. You can't interpret an ECG without it. You can't interpret a troponin without it. You can't interpret any test without knowing the pre-test probability, because this is what guides us. And if orthopedically, all we do is we look at the test, we miss these opportunities. Not to get too deep into the numbers, but if you take 100 patients with a negative x-ray after an injury in the emergency department, the likelihood is that probably 5% of them actually have a fracture. So how does this help us? This is what we do actually all the time, right? Everything we do in the emergency department is probabilities. So if you take a 25-year-old and he just turned the corner and he hit his wrist, he just whacked his wrist on a door frame, but he hurt his wrist. And 5 days later, he comes to the emergency department because his wrist hurts. His pre-test probability for a fracture is probably 10%. But he's there, he's 5 days later, he's got pain. You're probably going to take an x-ray. And when you take an x-ray, right, as you go and look, if it's negative, after the x-ray is done, his probability of a fracture is 0.6%. It's less because he has a negative x-ray. But if you take a 68-year-old lady and she's playing tennis and she falls, and when she falls, she's tender sore right over her distal radius. She's swollen. It hurts. Her pre-test probability before you send this 68-year-old lady for the x-ray, you say, oh, there's a 90% chance she has a fracture. She also has a negative x-ray. But after the x-ray is done, her post-test probability is 30%. There is a 50 times difference in both of these patients having a fracture. They both have a negative test. But based on your pre-test probability, right, there's a 50 times difference in their likelihood of actually having the fracture. And this x-ray, in fact, does belong to a 68-year-old lady who fell in tennis. And the emergency physician who saw her, one of my colleagues, before he sends her for x-ray, he's like, oh, she's got a broken wrist. The x-ray will either show it or not, we'll see. The x-rays were negative. When she came back to follow up in a week, she's still sore. We immobilized her, told her to come back 3 weeks later. And on week 4, we take the next set of x-rays. And if you look carefully, right where she's sore is her distal radius, you'll see the fracture healing. And this diagnosis is actually made before the x-ray is even done. So x-rays can lie. What matters is how worried you are about it. What matters is the history and physical. The keys to ortho management, oh, the x-ray is super helpful. 68-year-old lady with an x-ray, you can't even see the fracture. 22-year-old who has a fractured distal radius. 46-year-old who shattered his distal radius. All three have a distal radius fracture. The x-ray is super helpful in how to manage it. But from a diagnostic point of view, it can lie. We need to take a history. We need to know the forces involved. We need to know the mechanism. Did you fall on your outstretched hand or the back of your hand? Because if you fall on the back of your hand, it's more worrisome. What happened afterwards? I played tennis. I slipped. My wrist was fine. I continued playing for, a few more sets. And boy, the next day my wrist is sore. Well, the likelihood of a serious fracture is way smaller. I was playing tennis. I fell right away. My wrist hurt. I wasn't able to continue playing. The events after make a difference. You need to know the patient to whom all of this happened, because as we age, our bone gets thinner. So when you're a child, you've got weak bone. When you're a young adult, you've got strong bone. And then as you get to be 55 and older, right, you end up getting osteoporosis and you have weaker bone. So an 86-year-old falls from a standing height and just destroys their distal radius because it's brittle like glass. Past medical history, medications, previous injury, this is all important. If you have a little bit of, hip pain or knee pain in a 44-year-old, maybe a little meniscal tear, we're not overly concerned, right? No real injury, maybe it's something we don't know, who knows? But if you have the same history in a patient who has inflammatory bowel disease, who is HIV positive, for any reason they're immunocompromised, that mild hip pain, that mild knee pain could be a septic joint. So knowing the patient to whom those symptoms are attached is super important. We need to examine patients. 4-year-old girl with an open supracondylar fracture, it's easy to be distracted. The x-ray won't lie about this, but you got to make sure there's nothing life-threatening. You need to go past the x-ray though. You need to go past the elbow and make sure there's nothing limb-threatening. So while the x-ray can show you that there's a fracture of this child's elbow, the x-ray doesn't show you if there's anything life-threatening or limb-threatening. That's a clinical assessment. You've got to look to see if it's open or not, because the x-ray can tell you if there's a fracture, but it's your clinical assessment that tells you whether there's a break in the skin. Again, x-rays can lie. She also has a ring on her finger that needs to be removed. You need to feel, because you look at a normal x-ray of a wrist, and if there's snuff box tender, you can say, so soft tissue injury of the wrist. But the physical exam is what absolutely narrows what the pathology is. If they're sore here, that's palmar scaphoid, distal radius, hook of hamate. Each of these spots means something different. And if the only thing we touch is the snuff box, we can miss these less common, subtle diagnoses. Orthopedically, the physical exam is the path to narrow the diagnosis. We've got to move patients. Here's somebody who in their family practice office saw a patient who followed up a week after negative x-rays. So this 56-year-old patient was in the emergency department, had negative x-rays, was immobilized in a knee splint, followed up with his family doctor. And the family doctor is like, oh, I remember you talking about we got to move them. So the family doctor, instead of just leaving him in the splint and saying, come back in a few weeks, sits him over the bed.
You just straight leg your right leg, and then show me your other one. Good try.
And the patient can't extend his knee. And when you touch him, he's a little bit sore up here. He's got all this bruising. You compare to the opposite side, he has a quadriceps rupture. What he needs is a surgeon. But it's easy to miss it when the x-ray is negative. We all see patients with normal ECGs. We're not scared of a normal ECG. It's just a test, right? And what you need to do is put that in the context of the patient that you're seeing. It's no different for an x-ray. It's just a test. And now what happens is, how worried are you about the patient? That's what determines all of this stuff. You're not scared of a normal ECG. You see it all the time. You deal with it all the time. Don't be scared of a normal x-ray. So as a mnemonic, when you see patients with MSK complaints and their x-rays are normal, because we often will take x-rays, of course, right? Just think of this little mnemonic. And if you think of these diagnoses, you're less likely to miss it. This could be septic joint. Could it be compartment syndrome? Feel compartments, document compartments routinely. It's very hard to diagnose compartment syndrome if the only time you touch a compartment is when you think a patient has compartment syndrome. You have to recognize normal really well so that you can then recognize abnormal. Think of abuse all the time when you see an MSK injury. We're terrible at picking it up. RE has 2 letters. It has 2 things to think about. It could be referred pain. This patient with knee pain, perhaps the source of it is the hip. What's the clinical clue? When you touch their knee, it doesn't hurt because the pain's not actually coming from the knee. But if we never touch the patient, we totally miss that clue. It could be the report is false. Radiologists are excellent. They're not perfect. If there's an abnormality on an MSK film in the emergency department, there's a 20% chance radiology misses it. 20%. Right? So we should look at, we have a history, we have a physical, we have our eyes on the x-ray, our eyes on the patient. By all means, look at the films as well. Don't just look at the report if it's available to you. They could have a dislocation or a subluxation that's spontaneously reduced. Something slipped out and went back in. They could have an operative soft tissue injury, quads rupture, patellar tendon rupture if it's a knee, a distal biceps rupture, a distal triceps rupture if it's an elbow. Common? No. Commonly missed? Absolutely. Don't just rely on the x-ray. They could have a fracture, an occult fracture. Who's more likely to have a fracture? Children, older adults, because they have weaker bone. Think of this story. And when x-rays can lie is when the history and physical suggests something different. So this 26-year-old who injured his wrist, first x-ray is negative. He even had an ultrasound done by his family doctor that was negative. He was told to wait 6 weeks. And what happened to him? He didn't have snuff box tenderness. So he was told, fine, soft tissue injury of your wrist, go wait 6 weeks. And then 6 weeks later, he goes back to hockey. So the inciting injury was a big force in hockey. He fell hard into the boards, a really big force. He had to stop playing. When he goes back 6 weeks later, he just takes a routine slap shot, a very ordinary shot that he would take. And when he went back 6 weeks later, he got sudden wrist pain with that very minor force. And now what he's done, he's torn his scapholunate ligament. It's completely torn. It was partially torn by the original injury, but it just got misdiagnosed. It's a difficult diagnosis to make. I'm not being critical of the fact that the diagnosis was missed. But if we do a history and a physical, we say something is wrong. We follow them up and get serial assessments to make sure they're okay. Right? There's a big gap between his scaphoid and his lunate. He gets an operation. I assist in the operation, right? Just to what the surgeon talks about the fact that this often happens. Right? They have a partial tear. It isn't picked up. They go back to sport too soon. At 4 months, they go to remove the K wires and they broke. And his scapholunate space is still wide. This is still a bit wide. He failed the operation. There are complications of surgery. It's not just, now you get an operation. It's better to avoid it if you can. The x-rays lied, but the history and physical certainly suggested something was wrong. This 45-year-old, what happened to him? He twisted his ankle, But when he twisted his ankle, right, his x-rays were negative, diagnosis of sprain. When you ask him, how did he twist? He says, my foot turned out. He had external rotation. That's a big red flag mechanism. We'll talk about the autoankylals during the next talk, but the autoankylals don't ask you to touch the deltoid where he was sore. They don't ask you to touch the syndesmosis where he was sore. And where else was he sore? Up in his proximal fibula. You get two views. The first view doesn't show much, but there's his second view. Right? And what does he get? He gets an operation because he has this classic Maisonneuve fracture. But if we took, the x-ray lied, but what didn't lie was a history and a physical exam. And we do history and physical for everything except for MSK, where we just let the x-ray do the work. And this is why we get burned by it so much. This 42-year-old injured his knee. X-rays were negative. He was sent home. 11 days later, he had a through knee amputation. Why did that happen? We send lots of patients home with normal knee x-rays. His story, when he fell, he was getting out of a big truck, right? His foot slipped. His foot was in his groin, he says, with a hyperextension injury. Just take 2 seconds and think about this. Try to put your foot in your groin. It's not possible unless you break a bone or dislocate your knee. The EMS report, foot slipped off dozer, felt a snap in his leg, unable to move his toes, foot became mottled. This is all bruising behind the knee, all totally ignored because someone just looked at the x-ray. And guess what? The history and physical didn't lie. The x-ray might. So most surgical wrist cases, the x-ray is abnormal, but not always. Most miserable knee injuries, right? The x-ray shows it, but not always. Surgical ankle injuries, most of the time the x-ray shows it, but not always. There are times when the test will lie. And what you need is a history and a physical, because that history and physical is what provides your pre-test probability. And any test in emerge, a CBC, an ultrasound, a urine dip, whatever it happens to be, it all needs to be interpreted with a pre-test probability. So on your next shift, as we wrap up here, when you see this 21-year-old and she's injured her foot, the radiologist has read it. And he said, yeah, foot normal alignment, no fracture, soft tissue swelling identified. Excellent. Except for just put that aside and take a history. She's on a skateboard. She twisted her foot awkwardly, non-weight bearing. On exam, she's in a ton of pain in her medial midfoot. Medial midfoot pain is a red flag. The radiologist says what? No swelling. There's a ton of swelling in this foot. And unless you look at laterals normally, unless you're used to seeing it, the other thing you do, just look at her foot and it would be swollen. She's swollen on the medial side of her foot. And because you know where she's sore, the emerge doc who saw her, it wasn't me, it's one of my colleagues, said, no, there's something very subtle going on in here. That totally lines up with her symptoms. Called the orthopedic surgeon on call, and next day she gets her operation. This wasn't missed by emerge. This emerge doc, one of my colleagues, did a great job because what he did was a history and a physical before he looked at the test. This is why x-rays lie, because we think they can do the work by themselves and they're not. For an ortho diagnosis, you need to know what happened, you need to know who it happened to, and you need to know what it did. What's their exam? Somebody falls from 12 feet, 25-year-old guy's got a sore, swollen wrist, no snuff box tenderness, but his x-rays are normal. Something bad happened to his wrist. Even though the x-rays are normal, he's got no snuff box tenderness. Look at the fall, look at how much swelling he's got. Then you bring in the test. Right? And then you'll pick up these subtle cases. That's our job in emerge, is to pick up the subtle cases. That's our diagnostic challenge. If it's a subtle diagnosis, it's the history or the physical or the test that tells us. And if we rely on the test, we're going to miss the target because the test is not perfect. ECG normal is not a diagnosis. We know that. CT head normal is not a diagnosis. We know that. Ankle, x-ray normal is not a diagnosis. We should be aware of that. Remember the scared mnemonic. Every time you see a patient with a normal MSK x-ray, before you send them out, just pop this mnemonic in your head and just run through it. And in a few seconds, it won't take long. After 5, 10, shifts of doing this, This will be in your background. You will just know this. The same way you send patients home with chest pain and fever and abdominal pain. You go, let me just make sure it's not this, 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 or this. You cognitively force yourself to think of these things. And you won't be perfect, but I promise you, you'll be better. And I promise you, it'll help you pick up your needles in a haystack. So thank you very much for your attention on that. I will stop sharing. And I'll turn it back over to the organizers if there are any questions.
Thank you so much, Dr. Salat. That was rather informative. And I think perhaps the residents got a bit of that and more yesterday. So they are raring to go and very scared. All right. So we do have a question. Dr. French has asked. Dr. Guy, I think you have it up.
Yes, Dr. Hudson.
Right, go ahead, please.
Okay, the first one was from Dr. Rattry. If there is a high index of suspicion with negative X-rays, wouldn't a multi-detector CT be indicated?
Sure. So it's an excellent question. So if we're now getting at the management of these cases, then what we do is if we see a patient with an occult fracture, we have two options. Option one is you just need more time. So somebody has a suspected scaphoid fracture. You can treat them for the injury, immobilize them, and we do a follow-up x-ray 10, 12 days later and see how they are. We reassess them. If they're still sore, they can get repeat imaging and that can show it. The other option is you need, instead of more time, you move up. So one is to move out and get more time. The other is to move up and get better testing. So it all depends on what we're worried about. It all depends on what your resource availability is. If we're worried somebody has a suspected C-spine fracture, we're not going to send them home for a follow-up x-ray a week or 10 days later, of course. If they have a suspected hip fracture, right, you should probably keep them and try to get some sort of advanced imaging on those folks. Because if they even walk on a suspected hip fracture, something that's something that's going to be undisplaced may become displaced. And 5% of hip fractures don't show up on x-ray. So it really depends on where you are. It depends on what you're worried about. And certainly, you know, getting the answer right away isn't always necessary. If you're going to, you can easily immobilize them and have them followed up. It all depends on what you're concerned about. And if I could just make one point, you know, there was a comment there made about this is like kind of a little scary to hear about this. What I would suggest is this shouldn't be scary. You should not be paralyzed by this. You should actually be empowered by it. Because when you think about it this way, when you say the x-ray is negative and you think the pretest probability is negative, you're going to feel more confident. And so much of what we do in emergency medicine is orthopedics. And if we get clinical confidence with orthopedics, right, this is what's going to help us, I think, give us better disposition. This will help us enjoy our work more because it's a big part of it. So it's a little bit of a struggle as you roll through this first. There's no question you're going to struggle a little bit because you're going to think about a lot of stuff you didn't think about before. But once you get past the hurdle, I think it'll be smooth sailing for the rest of your career. You're going to feel a lot more comfortable with these MSK cases.
Thank you. The next question is from Dr. French. Can you comment on loaded views for patients with wrist pain where scapholunate dislocation is a consideration?
It's a brilliant, absolutely, a loaded view or something called a clenched fist view. Absolutely. So if you're worried about it, it's a great thing. So that's exactly what that 26-year-old should have had done. First, he has a history that he's sore, physical exam tenderness. There is a tender spot over the scapholunate ligament. And if that's a consideration, once you do a history and a physical, you know he's injured his scapholunate ligament. Now the x-ray is going to help us. If it's wide open on a plain film, that's a complete tear. But if it's normal, that loaded view or so-called a clenched fist view where the patient actively has to make a fist. And then what happens is the tendons are contracted. They're pulling down. They're kind of compressing. And when the capitate comes down, it can open up. So that's a fantastic thought. Absolutely. And it's what we recommend. So good. So just because the x-ray is normal doesn't mean they haven't injured it. There are partial tears and that would absolutely unmask it. If the x-ray showed it didn't widen at all, then we call that a grade 1 injury. They need 3 to 6 months to heal. It takes a while. If it shows it widens a bit, but it's not more than 4 or 5 millimeters, that space, then that's a grade 2 injury. And if it's more than 4 to 6 millimeters, and sometimes it looks normal on plain film and it really widens out on the stress view. on that loaded view. And if that's the case, then that should probably get a surgical opinion. But these take months to heal, not just a few weeks. And this 26-year-old gentleman that we showed, the diagnosis was missed. I'm not critical of the family doctor. We in Emerge don't know how to make this diagnosis. I wouldn't expect a family doctor to. But the point being is that it got missed because of the history and physical. So it's an excellent point, Dr. French. Thank you.
Okay, thank you. There's another question from Dr. Williams Johnson. Which is more useful once both are available, CT or MRI for occult hip fracture?
So excellent. If you have them available, CT is only about 95% sensitive. MR is better. So MR is the better test. The issue is availability. Now, plain film is 95% sensitive for hip fractures. So you say, is plain film the same as CT? Well, not at all. Like the reason is we do the X-ray on patients who have, we think have hip fractures. And if we see a hip fracture, they don't get a CT. The CT we're talking about, if you have an occult hip fracture, CT is 95% sensitive. So it still potentially can miss a hip fracture. MR is the better test for sure. But it's availability. So in our hospital, if we think a patient has an occult hip fracture, they're going to go for CT. It's very difficult in our hospital to get an MRI.
Okay, thank you. Those are the questions for now. Any other questions I'll ask in the next question that you have?
I think we have the poll questions, Dr.
Yes.
Dr. Thomas. Do we have those? We can just deal with them now.
Hi, good morning, everyone. So we sent a short poll for you guys to respond to. So far, we have 69 responses. So the question was, compared to other common emergency complaints such as chest pain, abdominal pain, headaches, etc., my confidence level with acutely injured orthopedic patient is, and the options were much higher, a little higher, neutral, a little lower, and way lower. And based on the responses, we have 36% of persons selected neutral as their top answer. Then a little higher was second with 33%. Then we have a tie between a little lower and much higher at 14.5% and 1.5% at way lower. So neutral has won that poll.
Oh, so that's great, actually, because there is evidence. So clearly you must see a lot of MSK and be quite comfortable with it, because there's evidence for sure that in primary for primary care and for Emerge that MSK is an area where most of us feel less clinical confidence. So anyway, I'm glad to hear that you do have as much, or looks like probably a bit more than average, and that's fantastic. Just remember the value of the test, and just don't forget a history of physical. It's what we do for everything else. And if you keep that in mind, I'm sure you'll look after patients even better than you do now, which I'm sure is great right now.
Thank you very much, Dr. Sal, for the reminder that history and physical is really the way to go first and foremost. Thank you so much, and we'll see you again a little later.
Absolutely.
Good. So coming up, we have Dr. Ho. We're going to switch things a little bit. And Dr. Ho is a graduate of our university, and he received his MBBS in 2010. He completed his specialty training in dermatology at Boston University School of Medicine and the Boston Medical Center, receiving his doctorate in dermatology in 2017. He also completed a fellowship in dermatology at the Skin Pathology Laboratory at Boston University. Dr. Ho is a consultant dermatologist and dermatopathologist at the University Hospital of the West Indies, a lecturer in the Department of Medicine and Pathology, and co-director of the Doctor of Medicine residency program in dermatology. He is a current president of the Dermatology Association of Jamaica and treasurer of the Caribbean Dermatology Association. His clinical interests include complex medical dermatology, rheumatologic dermatology, and inpatient dermatology. Ladies and gentlemen, please help me to welcome Dr. Ho to talk to us on deadly rashes. Dr. Ho, welcome.
Hi, thank you, Dr. Hudson. Yes, I don't think you would want me to be the head of the emergency medicine program. They may not know very much about emergency medicine thereafter. So today the topic that I was given is deadly rashes, but I'd like to add a subtitle, deadly rashes, but hopefully not. Because the truth is that early recognition is important for prognosis and can often improve the outcome for the patients that we see. So, if you've been doing emergency medicine or dermatology for any period of time and you hear a deadly rash, the first thing that comes to mind, of course, is the Stevens-Johnson syndrome, toxic epidermal necrolysis, TEN spectrum. And so we have to touch on that. And we're going to look at what it is, a little bit of pathophysiology in terms of updates, clues to early diagnosis, and a little bit of focus on the fact that not everything that has epidermal detachment is SJS or TEN. And we're going to look at a prognostication score. And then towards the end of the talk, I want to introduce us to a morphologic diagnosis. So this is not a specific diagnosis, it's the ability to identify a particular skin lesion called a stellate or retiform purpura, because it's an important marker for systemic disease. So we're going to look at what retiform purpura is, what does it mean, and why is it important. So let's dive right in. So I think most of us know that SJST and, this is a drug-induced detachment syndrome, and almost always there's a drug at play. Some of the earlier literature where you have non-drug associated SJS, a lot of those were probably erythema multiforme major, which is no longer classified in this spectrum. And what I mean by detachment is that there is insecurity in the attachment of the epidermis to the underlying dermis. And if you lose the overlying epidermis, these patients lose their skin barrier, particularly as it relates to fluid balance and prevention of infection. All patients who have SJS or TEN have mucosa and cutaneous involvement. If you have a patient that you're thinking has TEN, but the mucosa is not involved, but there is cutaneous involvement, this is probably a mimical. By the time you have skin detachment, the mucosa, at least one mucosal surface should be involved, very often two mucosal surfaces or more. And how we determine SJS versus TEN is really a matter of, it's a little bit artificial, but it's a matter of percentage. So, if you have less than 10% body surface area skin detached or detachable, and by detachable, I mean maybe it hasn't sloughed off yet, but if you apply a little lateral pressure to the adjacent normal appearing skin, that skin moves. That's called the Nikolsky sign, and that's an indicator that the skin is insecure. The epidermal attachment is broken. And so if you're detachable or detached about 10% or less, you're SJS. If you are between 10 and 30%, we call you a Stevens-Johnson syndrome, TEN overlap. And if you're greater than 30%, well, you have full-blown toxic epidermal necrolysis. The reason we speak about this is that it is a mortal disease, potentially, with an average mortality rate of 30%. And the primary causes of mortality are infection, early Staph aureus, later more Pseudomonas. But time to treat, the time to treatment is very important. And while which treatment to use is still controversial and is center dependent, we do know that if we can stop the massive keratinocyte death that is occurring, we can potentially decrease mortality. And in our setting, one of the things we've noticed as a mortality predictor is time to involvement of a specialist. So patients coming from institutions as transfers who do not have a dedicated skin service, these patients tend to do a little bit more poorly, and this is not an indictment on the care, but having a specialist who deals with a lot of SJS and absolutely makes a huge difference in our setting. Late recognition of the offending agent is another problem, and particularly if you practice in a center that does not have a dermatologist inpatient unit, this responsibility often falls to a combination of the emergency medicine doctor or the internist. And so together, the likely drug cause is important. And so familiarity with the common drugs and sort of the timeline, which we'll speak about in a second, would be important. We know dehydration, comorbidities predict mortality. An important point here is the risk of internal organ involvement. By the time we come to see the patient in the emergency room, very often, bloods have been taken off, fluids have been started, and we're very grateful for that. CDC, UNA, etc., blood cultures. One thing that's often missing is a liver function panel, and I do encourage you all as emergency medicine physicians, whenever you're suspicious for a drug rash, regardless of the morphology of that drug rash, add an LFT panel to your investigations, because a number of these conditions have an associated visceral involvement in a subset, most commonly what we know as DRESS, drug rash with eosinophilia and systemic symptoms, but also in things like SJS and TEN, and they can have quite a severe drug hepatitis, which if we know early, we can institute management. Now, in terms of pathophysiology, we're not going to spend too much time here, but there are like 4 current thoughts. If you direct your attention to the left of the diagram, I want to point out that we often think of tablets as the etiology or the etiologic agent for SJS/TEN, but don't forget IV medications, subcutaneous medications. Are these patients taking a biologic for something else? And eye drops. We forget about asking for eye drop use very often in these patients. The first thought in terms of how this happens is that epidermal keratinocytes constitutively, whether they're sick or not, they express this receptor called FAS. And then somehow the drug comes along and induces the ligand for FAS. And when these interact, you end up with a big apoptosis of keratinocytes. The second thought is, okay, maybe it is that these drugs actually induce antigen-presenting cells to migrate to the lymph node and trigger a T cell response, usually cytotoxic. These cytotoxic T cells produce perforin as well as granzyme B, and these can make little holes in the keratinocyte membrane and cause apoptosis. More recently, though, we're thinking, okay, probably a combination of everything, and maybe monocytes are activated, producing something called annexin-1. It interacts with the keratinocyte membrane, causes death of keratinocytes. And then there definitely is a natural killer cell component to this in conjunction with cytotoxic T cell production of a substance called granulysin. And this causes massive keratinocyte apoptosis. I think regardless of which theory you believe or whether it's a combination of all these theories, the end product is that your keratinocytes are dying by the hundreds of thousands. And what's ending up happening is that you're losing that barrier very, very quickly. And if you don't stop that by stopping the offending agent or instituting appropriate management, these patients are going to be quite sick. Now, from a clinical perspective, I think most emergency medicine physicians as well as dermatologists have no problem identifying SJS/TEN when it's well developed. So we know the lips of SJS/TEN, that kind of crusted hemorrhagic appearance. You see the blisters, which are always a sign of detachment. All blistering patients should be referred, I think, before being sent home from the emergency room, because morphology of blisters gives us a good clue as to whether this is going to evolve very suddenly into autoimmune blistering, drug-induced blistering, etc. And sometimes we end up seeing these patients a few days later, when maybe we could have instituted management sort of, immediately. So I'm a big fan of receiving a referral, even if it seems like a soft referral to the derm service, because if it's blistering, we can prevent a potential, admission of this patient a few days later. The problem with TEN SJS in some patients is that this patient here, a few days prior to this appearance, looked like this. All you had was a little bit of erythema, and this is when it becomes important for us to sort of delve in what are some signs and symptoms in the history, our clinical clues in the history that can guide us to say this is a patient who has evolving SJS/TEN versus this is a patient who doesn't have something too significant. So in terms of our history, the first thing is pain. So skin pain it's not completely unique, but it's very suspicious in a patient who is on a medication for evolving SJS or TEN. Skin pain is not something that we see in a lot of the other drug rashes. Occasionally viral exanthems, patients can have very sensitive skin initially, but when your skin is very painful and red, be very concerned that this patient has an evolving TEN or SJS. Most of these patients also have prodromal symptoms, sore throat, fever, and the eyes. Many of our patients will say the eyes were burning me a few days before. Red skin, burning eyes. Of course, viral exanthems, but if the patient is on medication, have to think about an evolving SJS-TEN. And same thing if the patient has soreness of the mouth or redness of the gingiva, or the tongue or the lips, or pain passing urine or painful defecation. This is often a sign in a patient with red skin, even if there's no detachment, that there's impending mucosal involvement. Red skin and mucosal involvement, thing that you must be concerned about in a patient who is on medication is SJS-TEN. Now, in terms of medications, the heavy hitters are going to be your aromatic anticonvulsants like phenytoin, phenobarbital, carbamazepine. Sulfonamide is actually a big hitter in our hospital. Allopurinol, we call it Russiagenic. Like allopurinol is very bad. ARVs, aminopenicillins, these are all very, very common causes. And I think we're familiar with them. If the patient says they're not on medications, ask again. Particularly ask about eye drops. Ask about analgesics. They mightn't have a prescription for medication, but maybe they recently started taking diclofenac or naproxen over the counter for osteoarthritis. And so these patients, NSAIDs we know are a real cause for SJS-TEN, and they may not recall that they're taking these things periodically. We always tell people to ask about over-the-counter vitamins and supplements. The truth is that there are no documented case reports, as far as I am aware, of SJS or TN, in a patient who is taking a supplement. But there's a first time for everything, and if the clinical scenario fits, regardless of what the literature says in terms of causes, if there's a drug that could be causing it timeline-wise, that drug must be stopped, even if it seems benign. We've seen TEN to paracetamol, so it does exist. Medication timeline is also important. Remember, these are not type 1 immediate hypersensitivity reactions. These are delayed T-cell driven reactions. So you need time to develop the hypersensitivity, and any medication within 3 months of commencement is fair game for SJS-TEN. We've seen, particularly with allopurinol, up to 6 months, 9 months. Dose adjustment, came off the medication, restarted the medication, inducing SJS and TEN. In terms of the clinical exam, tenderness again, skin and mucosal tenderness, very uncommon in other conditions. Maybe vasculitis, certain viral exanthems, but when you have skin tenderness and mucosal tenderness, number one thought should be SJS-TEN. Conjunctival injection, the macules and patches are important because SJS and TEN, before it attaches, they have these sort of red, brown, dark colored macules and patches. They're not raised. We don't associate raised lesions classically with this set of diseases. They're flat, okay? But you see this and they're tender. Think, yes, vasculitis, but probably more importantly and more commonly in a patient on medication, SJS-TEN. And then if they have visible signs of detachment, we call it the Nikolsky sign, which is where you actually put lateral pressure on an area of skin that hasn't yet appeared to detach, but when you apply lateral pressure to the normal appearing skin beside it, the skin moves. That's a sign of dermal insecurity and should be counted as positive. So here we have the same patient I showed you in the intermediate phase developing these dusky macules. Still no detachment at this phase, but you see this, you know that this is impending SJS-TEN. This is a patient we saw with a little bit more advanced disease. You can see clear detachment. If you apply lateral pressure with your thumb, just kind of slide it on this normal appearing patch of skin, all of this would move. That's a positive Mikulski sign, and it's a sign of epidermal dermal insecurity. This is what we refer to as the lips of SJS-TEN, this crusted hemorrhagic appearance, but we know that we can see these lips in pemphigus, we can see them in erythema multiforme major, we can see them in a number of other conditions. And so this sort of leads me into our mimicus. Not everything that detaches is SJS-TEN, but I would say to you, anything that detaches, probably get a consult on this because sometimes we can arrest it before it becomes significant in terms of body surface area involvement. So morphology matters. So annular detachment, not very consistent with Stevens-Johnson or TEN. Patients who have blisters in an annular ring-like arrangement, like in this kid, often have linear IgA disease, which is what this young man had. Take, for example, this woman who does have dusky patches and blistering, so detachment, and she had a positive Mikulski's. But when we look more closely, lips aren't really involved, just a little bit of desquamation down here. And even more closely, we see this malar pattern with clear sparing of the nasolabial fold. This woman has what's now being called TEN-like acute cutaneous lupus. She had high titer double-stranded DNA. She was Rho positive, Lab positive. This patient is a sort of new category of cutaneous lupus that's being spoken about. This patient has detachment and had a drug history. Started to take an aminopenicillin 7 days ago and developed this rash. But if you look carefully, there are pustules here. Multiple pustules in the setting of detachment favors another type of drug rash called AGEP, acute generalized exanthematous pustulosis. Pustules are not super compatible with SJS-TEN. This young man has detachment on the forehead and the lips of SJS-TEN, but on his forearm, we can see papules raised, well-defined with a central necrotic area. These are targetoid lesions, and this patient actually had erythema multiforme major. He didn't need immunosuppression. He needed suppression of herpes with acyclovir and did very well. Now, can we predict mortality? The answer is perhaps. This is not new data. This was published in 2000, but it's what we most commonly use. It's a severity of illness score for TEN, so-called SCORTEN. It looks at 7 parameters: age greater than 40, patients who are tachycardic, patients who have underlying neoplasia, particularly hematologic malignancies, initial detachment. This is day 1 detachment of greater than 10%. Oftentimes, we are unable to assess this because patients are coming from outside where it wasn't documented. Patients who have a serum urea greater than 10, acidotic patients, and hyperglycemic patients, all of these get 1 point each. Now, if you have 0 to 1, your mortality rate is pretty low according to this criteria, about 3%. But if you are hitting mortality, if you're hitting 5 or more points, which is not that hard to do because some of these patients are quite ill, then your mortality jumps to about 90%. So, these are some of the things that we look at when we see the patient in the emergency room, and it certainly, is something that you can also calculate in order to assess, how sick is this patient? How much does this patient need intensive care, etc. Now, that's kind of what I wanted to share with us about TE and SJS, but now I want to delve a little bit into retiform or stellate purpura. And the first question is, well, what's that? And they are defined really by their shape. Now, purpura by definition are erythematous lesions. They do not blanch on pressure because the erythema is due to extravasation of red blood cells. So there are red blood cells there, so pressing on it isn't going to get rid of that redness, it's going to stay there. That's purpuric erythema. Now we all see purpura, right? So these are small purpura, so-called petechiae, in a patient who has, ITP or hemorrhagic dengue. And you'll notice that around the edges aren't particularly jagged. They do have a kind of red-brown appearance, but they're pretty uniform in appearance. Now contrast that with stellate or retiform purpura. And what you're having here are these little arms like a starfish or star coming off of the purpura, and the edge of the purpura is jagged. This is what retiform purpura is, and it means something. It's important. Now, what does it mean? Well, it means that there's significant cutaneous vascular compromise. And what happens is that how the cutaneous vasculature is set up is you have these arterioles at the apex of a cone, and as they progress through the dermis, they become more spread out right up until just below the epidermis. And then the oxygenated blood is taken away by veins. Now, within this cone is primarily oxygenated blood, and in between these cones, you have venous blood taking the deoxygenated blood away. Anything that causes compromise at this point to prevent inflow of blood, or if you have something on the back end preventing clearance of this deoxygenated blood, you end up with some sort of vascular patterning. Now, the most common type of vascular patterning is liver reticularis, and we're familiar with this. We see it in babies all the time. They have a little bit of sludging in their cutaneous veins, and they get this pattern, and it reverses on warming. However, if you have true blockage of that arteriolar cone and you're ending up with early ischemia, you get something called liver racemosa. And this looks like liver reticularis, except that the rings, instead of being completely net-like, are broken, they're broader, they're a little bit darker in color. And if this progresses to necrosis because of prolonged occlusion of the arteriolar cone, then you end up with necrosis in the center, but you still have the little arms of the vascular patterning coming off. And this is what is responsible for your retiform or stellate purpura. Now, why are they important? Well, to understand that, you have to know the morphology. There are two morphologies. There is bland retiform purpura, and there are inflammatory retiform purpura. A retiform purpura that has the classical, stellate appearance, but no surrounding erythema, this is bland retiform purpura, and it means one thing. Now, if you look at this retiform purpura, very nice star-shaped jagged edge, but around it, there's redness, there's erythema. This is inflammatory retiform purpura. But look, both are significant. If it's bland, patient has a prothrombotic state and needs anticoagulation by and large. There's one exception. I'll talk about it in a second. If it's inflammatory retiform purpura, this patient has a deep vasculitis. The problem is that when you have deep thrombosis of skin vessels or deep vasculitis of skin vessels, it's almost certain in the majority of cases that these patients have a systemic disease happening, and it can end up in catastrophic limb loss, can end up in hemorrhage if it's vasculitic, and death. So it's important to recognize this morphology. In our setting, the most common cause of prothrombotic bland purpura is APLS, antiphospholipid antibody syndrome. And we've seen patients, we refer to tinea cruris, and we notice the patient has retiform purpura and is there because of acute limb occlusion. And we realize, wait, this patient has APLS, they get anticoagulation, limb is saved, patient goes home, lifelong anticoagulation. Malignancy associated is a big hitter in our setting, followed by hereditary and then infection. We don't see a lot of meningococcemia out here, but certainly in the States, if we have somebody with bland retiform purpura, that's one of the things that comes to mind, and we should consider it, that it could be infectious. These are the patients who need antibiotics, sometimes with anticoagulation. They may not just require pure anticoagulation. For inflammatory or deep vasculitis, the most common thing we see here is autoimmune connective tissue disease associated vasculitis. So usually lupus with vasculitis or dermatomyositis with vasculitis. But we see a few polyarteritis nodosa and then infectious causes as well. So this patient that I showed you here initially, unfortunately, what she had was an occult GI carcinoma that was causing her to have a prothrombotic state and presented with retiform purpura. This case presented with inflammatory retiform purpura and turned out to have a systemic vasculitis. We thought it was going to be Short-Strauss because she had eosinophilia as well as asthma, but her P-ANCA was negative, and turns out she may have actually had Montelukast-induced Short-Strauss syndrome-like vasculitis. Stopped the Montelukast and she did quite well. If you were working the ER a week and a half ago at university, you might have encountered this patient who presented with numerous necrotic, really awful looking ulcers, but surrounding it, you can see a purpuric edge with erythema. And if we look at the arrow, a very subtle kind of dinosaur-shaped retiform purpura. This is an emergency. This patient wasn't febrile when we saw him, but we knew within a couple of hours he would be. So said, so done, 38A, 39. This patient has angioinvasive bacteria, so-called ecthyma gangrenosum, and usually Pseudomonas. In his case, it was a MRSA, and now has infective endocarditis. He's currently admitted on our ward. So in summary, SJS-TEN, early diagnosis matters. Not everything that detaches is SJS or TEN. And in terms of early diagnosis, think skin pain. Skin pain, skin pain, skin pain. Very, very suggestive of SJS TEN. And then if you calculate a score 10, it will help you to predict their outcome. In terms of retiform purpura, it is almost always a marker for deep skin pathology and systemic disease, not invariably, but in the vast majority of cases. And late recognition may lead to significant mortality or morbidity and mortality. And my references were in text. So that's what I wanted to share with you this morning.
Thank you very much, Dr. Ho. And I've learned that APLS now has another meaning for us. It's advanced pediatric life support, and now you've added something else. So
No, I
the
know.
reasons I tell people I don't like when they use abbreviations, because I have no idea what you mean by them. But thank you so much. And certainly for me in emergency room, my residents will know that when you say things, oh, this patient has a rash, my temptation is to say, call dermatology.
A good temptation.
I just, so thank you so much. I do believe we may have a question from the chat. Dr. Guy, are we ready with any questions? Or poll, Dr. Thomas, we have a poll.
Okay, we can start off with the poll.
Sure, go ahead, please.
Okay, so just a reminder to everyone as we continue throughout the day, the poll questions will be sent by Dr. Hudson in the YouTube chat, so you can look out for those. The answers are anonymous, so don't be afraid to answer. So we'll start off with question number 1. What is the name of the scoring system used to predict outcome in SJS-TEN? And the options were A, Regiscar, B, JSCAR, C, Score 10, D, Yamaguchi criteria, and E, Jones criteria. And so far, based on responses, Score 10 is at 90.9%. Then we have Jones criteria being 2%, 5%, and Regiscar 3%.
Yes. So, do you want us to comment on the questions? Shall we do that?
Yes.
Okay. So yeah. So the score 10 is correct. Score 10 is what we use, and it's been modified just last year into something called the ABCD of TEN, but that hasn't been validated yet. The Regiscar we use for calculating likelihood of dress. So that's also something that can be done. You just look for the automatic calculator on your phone, you Google it, and you can add parameters to see, does this patient have drug rash with eosinophilic and systemic symptoms versus another drug rash. Yamaguchi is for adult onset Still's disease, and Jones criteria is for rheumatic fever. So good job, score 10.
Okay, thank you. So next question that we have is select the correct statement related to epidermal detachment. So A, epidermal detachment is unique to SJS-TEN. B, Nikolsky's sign is negative in patients with epidermal detachment due to TEN. C, epidermal detachment mandates hospital admission. D, mucosal detachment is universally present in SJS-TEN. And E, DRESS, D-R-E-S-S, is the most commonly used, common cause of drug-induced epidermal detachment. So for our responses, we have 51% saying C, epidermal detachment mandates hospital admission. Then we have 38% saying mucosal detachment is universally present in SJS-TEN. Then we have 6% saying DRESS is the common cause of drug-induced epidermal detachment. And we have 1.9% with Nikolsky's sign being negative in epidermal detachment.
All right, great. So the correct answer here is that mucosal involvement is universally present in SJS-TEN, and I do want to leave that with us. Epidermal, in terms of option A, epidermal detachment is not unique to SJS-TEN. Lots of things can present with epidermal detachment. Nikolsky's sign is usually positive because it's a sign of epidermal insecurity. So C and D seem to have been the big hitters. So C, epidermal detachment mandates hospital admission. I would say no. Epidermal detachment probably is a good idea to get a derm consult. But if it's small percentage, like 5% or less, you may not need to have an admission, especially if the patient has like bullous pemphigoid or something like that causing detachment. So it doesn't mandate admission, but it's probably a good idea to get a derm consult. DRESS is actually a cause of detachment, but it's uncommon. Usually it's just papules and edema that DRESS patients present with. So in this case, mucosal detachment always present. It's always present in SJS-TEN.
Okay, thank you, Dr. Ho. So we have one final question. Select the correct statement relating to retiform purpura. So for A, the option was retiform purpura typically indicates uncomplicated ecchymosis. B, inflammatory retiform purpura typically indicates hypercoagulable state. C, antiphospholipid antibody syndrome often presents with retiform purpura. D, immune thrombocytopenia often presents with retiform purpura. And E, patients presenting with bland retiform purpura need urgent high-dose immunosuppression. So for our responses, we have the top response being C, which is antiphospholipid antibody syndrome often presents with retiform purpura. Then next in line, answer B, inflammatory retiform purpura typically indicates a hypercoagulable state. Followed by answer E, which is that patients presenting with bland retiform purpura need urgent high-dose immunosuppression. And then D, with 1.8% immune thrombocytopenia, often presents with retiform purpura.
All right, great job. So the correct answer is what most people chose. So antiphospholipid antibody syndrome very often presents with retiform purpura. In terms of option A, usually if you have retiform purpura, it's not uncomplicated, it's bad. It's something that needs to be evaluated. If you look on the right-hand screen, here you have your inflammatory retiform purpura. This usually means vasculitis. So it's the presence of the retiform purpura with surrounding redness. So it usually indicates vasculitis rather than a primary hypercoagulable state. The immune thrombocytopenia usually presents actually with just non-retiform purpura, so petechiae, ecchymosis, but not stellate in shape. And usually if you have bland retiform purpura, you don't need immunosuppression, you actually need anticoagulation because it's indicative of a hypercoagulable state, not usually a vasculitic state. Vasculitis, you usually have the erythema. All right, well, great job, and thank you for the opportunity to present.
Thank you very much, Dr. Ho. You have certainly enlightened quite a number of us, and we thank you so much for being part of this. And perhaps we'll see you in the near future.
Hopefully, in the ER.
Well, depends on how you come in the ER.
Okay.
All right.
Thank you.
Thank you. At this time, before we go off to lunch, we'd like to I'd like to introduce Dr. Shubhra Dasgupta. Dr. Dasgupta is a consultant and lecturer in emergency medicine at the University of the West Indies, Mona. Armed with her emergency medicine and public health degrees, Dr. Dasgupta has a special interest in emergency medical services and access to health care. She is the director of the Pre-Hospital Emergency Medical Services Program and hopes to eventually bring EMS to the forefront of Jamaica's health interventions through research and education. Ladies and gentlemen, please help me to welcome Dr. Shubhra Dasgupta, who will speak to us on medical emergency preparedness in the office practice. For those of us who do that, are we okay with that? Are we suited and well prepared for an emergency that may come to us? And Dr. Dasgupta will enlighten us. Welcome, Doc. You need to unmute, Doc.
Sorry. All right. Good morning, everyone. I just want to take a minute to thank JEMA for inviting me and giving me this opportunity to talk to you today on medical emergency preparedness in office practice. All right, so what is a medical emergency? A medical emergency is an injury or illness that is acute. It poses an immediate risk to a person's life or long-term health. The early identification of a medical emergency and subsequent management will usually prevent irreversible consequences. It's very important that the general practitioner understands their integral part, the role that they play in management of these emergencies, and having a provision for emergency care in their practice is extremely important. All right, so I'm going to start by providing maybe 3 examples of emergencies that could be encountered in the primary care office as a guide to emergency preparedness in this type of setting. We'll outline an approach to assessing the risk of emergencies in one's medical practice, determine the equipment and medications required for emergencies, and determine the necessary staff training to meet this important facet of patient care. As a PCP, a primary care physician, you can come across any type of emergency at any time. You have a very important role. The availability and accessibility at that community level makes you first contact point for most patients seeking care. But to provide this care, you also need to have knowledge and confidence, experience and trained supportive staff, and the appropriate equipment and medications to give this emergency care. In caring for patients of all ages, private practitioners will see older patients who have stroke all the way to infants who may have meningitis. A lot of times our adult patients may misinterpret what's happening with them and they don't present to the hospital in time, or a lot of them purposefully avoid going to the ED. We know these patients. On the other hand, on the other extreme, I should say, parents sometimes of critically ill children not sure of what's happening with their child, and they may not present to the emergency room. They may instead go to their private practitioner who they have a relationship with because their child is ill. Using the ABCD approach, airway, breathing, circulation, disability, exposure, which is a widely accepted in the emergency medicine field, is also applicable in all primary care settings, as well for immediate assessment and treatment of your critically ill patients. So what does the epidemiology say? Well, several surveys in the US have shown that emergency situations are to be expected in every active family practice office. A study of general practitioners in rural Australia found that these physicians saw a median of 8 emergencies per year, and that 95% of them had seen at least 1 to 3 in the year before. American Family Physician Journal published that the average family practice office has 3.8 childhood emergencies each year, and that 62% of family medicine and childcare offices saw 1 or more child who required hospitalization or urgent treatment that week. In these same studies describing the incidence of office emergencies, they also showed that the offices were inadequately prepared to manage emergencies. They cited factors such as the rarity of emergencies, time and financial constraints, and the proximity of a hospital as reasons to not prepare their office and to neglect this part. So, as we discuss the 3 cases that I've outlined here, I'd like you guys to think about, reflect on your own general practice and think about what would you do if this patient appeared in your office. Case 1, a 72-year-old man develops acute chest discomfort and associated intense diaphoresis in your office waiting room while waiting for a scheduled routine appointment. He is known to have hypertension and type 2 diabetes and has no previous history of coronary artery disease. Case 2, an 18-year-old man comes to your walk-in office for asthma that has been worse more than normal for the last few weeks. He smokes 15 cigarettes a day and has been trying to quit. He has been very short of breath for the last hour. When you go towards him, you're unable to hear breath sounds with auscultation of the left side of his chest. His trachea is shifted to the right side on clinical exam. Case 3. You are suturing a wound on a 52-year-old woman's hand. She begins to feel weak soon after you administer the local anesthetic. She then develops an urticarial rash, wheezing, and a feeling of impending doom. What will you do? All right, so the first thing that you're going to start doing is assessing your practice for the risk of an emergency. You want to ask yourself these questions. Are you and your staff prepared for emergencies? Have you considered approaches to training your staff members and ensuring that you can provide standard of care in such situations? What are the risks specific to your own practice? How will you determine these risks? You can start by looking at a couple of things. Your patient demographics. What type of patient do you see? What age range? Is it that you see patients that are mainly elderly or mainly pediatric? Your office location and makeup. What setting is your office located in? Is it in a rural area versus an urban versus an inner city? Who will staff your office? How many staff do you have? How many medically trained staff do you have? And of course, what's the distance of your office to the nearest hospital or nearest emergency room? What treatment and therapies will you offer? Are you going to be giving parenteral medication? Are you going to offer an asthma bay to treat asthma? What do you want to be prepared for with the population that you see? After you assess the risk, what do you do then? Well, there are three things that you want to do. You want to acquire supplies, depending on your patient demographics, your location, and the staff that you have. You want to train your staff. And then third, you want to develop an emergency plan and put it in writing. So the acquisition of supplies. Private care physicians should choose emergency medications and equipment that reflect the spectrum of offices of their anticipated emergencies. So what's the most commonly encountered office emergencies that you would see? Well, it's been published that for the adults in primary care, we mainly see asthma exacerbation, psychiatric illness, hypoglycemic seizures, anaphylaxis, impaired consciousness or altered mental status, septic shock, poisoning, drug overdose, and cardiac arrest. On the child side, asthma exacerbation, again, severe respiratory distress, which may be non-asthmatic, seizures, hypovolemic shock, apnea, anaphylaxis, obstructed airway, probable epiglottitis, and cardiac arrest. You will notice that common to both are your respiratory distress, asthma attacks, anaphylaxis, shock, seizures, and cardiac arrest. So when acquiring your supplies, there are a couple of things. So one, you're going to look at the type of illness that will present to your office. The next thing is that you want your equipment choice to also reflect your office's patient population. That's why you did your risk assessment. For example, offices that care for a large number of patients with heart problems may consider purchasing an AED or an automatic external defibrillator, because the likelihood of addressing a sudden cardiac arrest may be greater in your office. The choice of medications and equipment should also be based on the skill level of the staff using it. For medical and legal reasons, no office should stock equipment that cannot be used safely by their office staff. Where is your office located, whether rural or urban, and the distance from the nearest ED? For example, in the rural office, private care physicians may need to do more than just stabilize a critically ill patient. These offices might consider the need for prolonged resuscitation, depending on where they are and how far away the emergency room is. They also need to consider that additional time spent traveling to the hospital to the nearest ED. Physicians there may also want to provide longer treatment in office before and stabilizing that patient properly before the patient leaves with EMS. Your medications and equipment also, I cannot stop stressing this, must be based on how skilled your doctors and nurses are to use these supplies, right? So again, for medical and legal reasons, no office should stock equipment and medications that they can't use by the staff there. I put here an extra note on automatic external defibrillator because the movement is now around the world that you would have in the public setting availability, much more availability of AEDs in public settings so that it can be used. AED usage is taught in BLS, which is geared towards the layman. And because of its significant use and the significant advance in out-of-hospital resuscitation that it gives you for adults and children, it's something very, very important to have in your office. An AED is able to analyze your cardiac rhythm, recognize whether it's shockable or non-shockable, and then defibrillate the patient if necessary. And everything it talks you through. You don't have to do anything. You just use self-adhesive pads and it'll tell you what to do. So what's published out there is that the emergency equipment for primary care practice that you would want to have is listed here. I've put it in this slide. And again, after you've done your risk assessment and you look at the type of patients that you're seeing in your practice and you think about who comes and what kind of emergencies you'd see more primarily, things that you should have would be like your bag valve mask, obviously your blood pressure cups, everything to do your vital signs. You may want to have cord clamps and scissors if you provide antenatal care in your practice, especially if the nearest hospital is far away and you have patients coming in for antenatal care there. You want to have delivery kits ready as well as dressing kits. An ECG machine, a glucose monitor, of course, IV catheters and extension tubing and T-connectors, your face masks, both non-rebreather and oxygen masks, nasal airways, oral airways, nasogastric tubes, having a nebulizer for your asthmatics, and metered dose inhalers that you can use with spacers in your office is extremely important. Oxygen tank and a flow meter. Portable suction device and catheters, pulse oximetry both for the child and adult, depending on the population that you see, and of course your universal protection. And here again, I've bolded in your AED or a cardiac monitor with defibrillator if that is what you choose, but an AED. The medications that we try to look out for in our primary care practice: acetaminophen or Panadol, aspirin, activated charcoal, atropine, adenosine, ceftriaxone IV, clopidogrel, oral antiplatelets, corticosteroids, both parenteral and oral, dextrose, 25%, 50% as well if you would like to stock that, diazepam or parenteral Valium, diphenhydramine, DPH, epinephrine for your anaphylactic shock and your cardiac arrest, flumazenil, lorazepam, ibuprofen, morphine, magnesium sulfate IV, especially in the obstetric patients that come in with eclampsia, naloxone, nitroglycerin spray, oxygen tank, and saline, salbutamol for your asthmatics. So after you've acquired your supplies and equipment, the next thing is to up-to-date your training, physician and staff training. Remember, all the correct equipment in the world for dealing with emergencies in the office is only useful in the experienced hands. Ideally, all office employees should be trained and regularly retrained in BLS regardless of their office responsibilities. Remember, BLS is geared towards the lay person, so your administrative staff and so on should all be trained, especially if you have a tiny office with less hands. Medical staff should be encouraged to maintain their skills in either BLS, the nurses and medical assistants, or adult and pediatric advanced life support for your physicians, physician assistants, and nurse practitioners. The need for consistent re-education of life-saving skills despite adequate initial training has been well documented. And here's our little CPR room with our ACLS algorithm in the back. So the last thing that we want to do after we've got our equipment and supplies, our medication, we've got our trained staff, sit down, put pen to paper, and develop an emergency plan. Primary care offices should take time to create a written emergency protocol that outlines the steps to be followed in the event of an office emergency. The protocol should take into account the skill level of each employee and assign each employee specific responsibilities within the office during the resuscitation. Designating a room for the delivery of emergency care and for storing all emergency equipment is a good start to the planning process. If the office layout makes this difficult, office emergency equipment should be portable. Example, rolling cart with a carrying case and so on, or stored in a common location. And I think I have a picture here. As you can see, this is from Journal of Family Medicine, where they've outlined, given a little layout of an appropriate practice layout, where you have a waiting area. They have an emergency management room that's specifically for that. One consultation room, a separate area for wound dressing, a separate procedure room, maybe for suturing, and then an area for, of course, dispensary of pharmaceuticals. And maybe you have a lab, maybe you don't, and of course, a toilet area. This is a 3D image of what that would look like. And here we've added in our EMS, which I never leave out, and hopefully you would have access to in a timely fashion. So while you're developing your emergency plan, algorithms describing the treatment sequence for specific medical conditions are very, very helpful. That ACLS algorithm at the back of your room when you're doing ACLS would be very useful at that time. These protocols typically follow that ABC, airway, breathing, circulation model that we use in all the life support classes. Practicing for emergencies. This is the final thing. Doing your mock code, doing a drill, is an emergency drill in where you simulate a critically ill patient in the office is very, very important. Drills allow the office staff the opportunity to practice all the steps in the emergency protocol, as well as individual life-saving skills, and make them more mentally prepared for what may happen. All right, so let's do our case resolutions. Now that we are armed with our checklist, medication and equipment listed, considered, we've planned our office protocol for our emergencies, we now can revisit our cases. So in case 1, the 72-year-old man with acute chest discomfort, associated intense diaphoresis, known hypertension and diabetes type 2. What's the diagnosis? The man's likely having a heart attack, myocardial infarction. What should you do as the primary care physician? 1, call ambulance/call help wherever you can get it. Measure vital signs, oxygen saturation, your glucose level. You want to administer aspirin to chew. For the severe pain, you consider nitroglycerin now. Spray every 3 to 5 minutes under the tongue. Obviously monitoring the blood pressure because you can get hypotension with that. Give oxygen if the saturation is below 90%. Obtain an ECG, obtain an IV access, administer morphine if you have that, and if you're going to accompany the patient or if the paramedics provide subsequent monitoring, either way is good. And you can give oral antiplatelet agents like clopidogrel at this stage as well. Case number 2, 18-year-old man with asthma that has been worse than normal for a few weeks, has a smoking history, very short of breath over the last hour. And now you go to examine him, you are auscultating, no breath sounds on the left side, and the trachea is shifted to the right. Diagnosis, patient's having a tension pneumothorax. What are you going to do as the primary care physician? Call the ambulance, call for help. Measure vital signs and oxygen saturation, check if the trachea is in the midline position again, auscultate for breath sounds bilaterally again, and then perform life-saving needle thoracostomy on the side with no air entry with the largest gauge IV catheter available. The patient is in tension, not a lot of time. Administer after you've done this, you'll hear that lovely gush of air and things will start normalizing. You can now administer nebulized salbutamol, oxygen via nasal cannula. You can give them 50 milligrams of oral prednisone, obtain an IV access, and hopefully by then your help has arrived. Case number 3, you are suturing a wound on a 52-year-old woman's hand, and you give her her local anesthetics, and all of a sudden she starts having a rash, she starts wheezing, and she feels like she's going to pass out and die. Diagnosis, anaphylaxis or anaphylactic shock. What are you going to do as a primary care physician? Call an ambulance, call for help. Measure vital signs, glucose level, oxygen saturation, give epinephrine, 0.3 to 0.5 intramuscular, 1 in 1,000. Repeat this after 5 minutes if there is no response. Life-saving. Administer salbutamol nebulizations, administer oxygen. If stats are below 95, you go ahead and obtain an IV access, give 1 liter bolus of fluid, and administer prednisone. Hopefully, help has arrived by then, and the patient can go to hospital. All right. So in conclusion, physicians will encounter office emergencies at some time in their practice. Appropriate risk assessment, planning, and preparedness will allow the provision of high quality care, safety for staff members, best patient outcomes, and the reward of having managed a time-sensitive problem in an efficient and effective manner. All right, these are my references, and thank you for listening.
Thank you very much, Dr. Dasgupta, for that very concise and I hope timely discussion on how a private practice outside of an emergency setting can be prepared for an emergency. A question I might ask you, this is something that you know came across a few years ago. For somebody, for example, a surgeon has a private practice, and you've listed some of the things there, and the surgeon might say, why I need to stock up on Ventolin and all these wonderful things? I don't see those types of patients. So what would you think would be a sort of basic standard must-have for any private practice outside?
I mean, must-have for anyone doing any procedures inside an office space. You can and have to be, the patient doesn't have to be asthmatic. They can go into anaphylaxis and start wheezing. You have to be prepared for those emergencies, those respiratory and cardiac emergencies that are very, very time sensitive. And especially surgeons who will be giving patients local anesthetics in their office practice must have that in stock. They must have respiratory kit and cardiac kit available so that if the patient does go into shock, or they go into anaphylaxis, or they have a cardiac arrest because the drug gave them a bad reaction, they have something in place to help. So I think especially for the surgeons who are doing procedures in their office practice should have these things, and they should be trained in ACLS before doing those kind of procedures in their office space. Because a simple thing like suturing a wound, that's it. A very tiny wound, and you give them lignocaine, the patient can have a bad reaction, and you don't know. And you don't have time to get help. You don't have time for the ambulance to arrive, especially in a country where EMS is not functional the way you want it to be functional. You're not going to have the time. So it's very, very better to be safe than sorry. Very, very true.
Certainly for the patient. And what is your take on private offices having AEDs?
I think it's a very, very good thing. I think worldwide, the price of AEDs have been dropping because of the demand for it now to be in the public areas. So public places need to have AEDs. And because of that, the price has dropped. It's become something that you can afford to have in your practice. So one, if they're thinking about the financial problems, that's one thing that the market is helping with. And two, it's so user-friendly. It's so easy to use, and it is extremely life-saving. Your patient that comes in, you don't know what the rhythm is, you put it on, it will tell you whether or not you need to give a shock and save that patient's life. There are numerous research papers been done out there that the use of the AED outside of the hospital is life-saving for both the adult and the child. So I completely think that every single private practice should have access to an AED at minimum.
I'm going to say one thing else and play devil's advocate. When you use the AED, because we know you have to keep the things, the pads replaced and so on.
Yeah.
How do we then charge? You know, is it something we charge, and how you determine one shock is X amount, two shocks, you know? I'm just saying, because that is part of business that we as physicians don't really think of, but it's a cost. How is there anything out there that helps to speak to that, or is just one's own determination?
It is one's own determination, but the loss of a patient compared to the loss of your pads on your AED, you only need one patient that comes in and one bad experience to form your practice and to form what happens and your feelings towards treating patients. So you only need to be unprepared one time. So I think that you've got to wait, of course, and I'm sure that there is data out there to help you in terms of economic cost and so on. But I think that it's worth it. I really do think that it's worth it. So.
Thank you very much. Dr. Guy, I'm not sure if there are any questions of our participants in the chat.
Yes, Dr. Hudson. We have one question for you, Dr. Dasgupta.
Okay.
Can you comment on nebulization during COVID-19 pandemic and aerosolization?
Well, you can have a separate room. You can have a separate room specifically in your practice space. And if you do not have that room and you are unable to isolate your patient while you're waiting, then go ahead and give the metered dose inhaler. Do what you can with the aero chamber. And get help. Obviously, the first thing you do is always get help.
Okay, thank you.
Mm-hmm.
All right, if there are no more questions, thank you very much, Dr. Dasgupta. That was very enlightening.
Thank you for having me.
Thank you. At this time, it is our lunch break, and we are going to do that, just go and refresh ourselves, and we ask that you return at 12 o'clock, and we will continue the second half of our program. The link will remain up, so you don't have to worry that it will come down and then you won't get back up. It will remain up. So please, we'll see you in an hour's time. Thank you.
Hello, everyone, and welcome back to the second session in this our Jamaica Emergency Medicine Association conference. My name is Dr. Eiffel, and I am an emergency physician with the University Hospital of the West Indies. It is indeed an honor and privilege to have you join us on this your Sunday afternoon. Hello, everyone. One second. All right, for our conference entitled Hot Topics in the Tropics. I trust that everyone had a good lunch, a generous lunch. And yes, in order to stimulate our brains back from that lunch, I want to start this session off with a brief riddle. So if you know the answer, don't hesitate to put it in the chat. Let's go. So here's the first riddle. What occurs once in every minute, twice in every moment, yet never in 1,000 years? What occurs once in every minute, twice in every moment, but yet never in 1,000 years? If you know the answer to that, I'm going to monitor the chat. Just put your answer there. All right, we have a winner. Dr. Monique Guy was the first one out to say the letter M. So to make sure that everybody is awake and here with us, here's the second riddle. What 5-letter word becomes shorter when you add 2 letters to it? What 5-letter word becomes shorter when you add 2 letters to it? Let's see who's here. Wow, we have, yep, everybody got in the chat. The answer is short. That's a 5-letter word that becomes shorter when you add 2 letters to it. And lastly, and I'm sure everybody is back with us, we have 120 people online. And here's the last riddle, just to wake everybody up. The more it dries, the wetter it gets. What is it? The more it dries, the wetter it gets. What? And again, Phil T. He seems to be that person gets everyone right. So the answer is correct. The answer is towel. All right. I believe everybody's here. Everybody's awake and ready to go. Welcome back, everybody. As mentioned before, my name is Jason Eiffel, and this is our second session. And if you were here for the first session, you would have been thoroughly enjoyed each of those talks. Very informative, very excellent. And I want to thank those presenters once again. And we are in the second session, and we have in store for you 4 excellent presenters ready with their 4 talks. And we also have some sponsors at near to the very end. Now, all presenters have promised to do their best to stick to their allotted time. And if that be the case, we'll be saying our final goodbyes at around 3 p.m. So without further ado, let's introduce our very first presenter. And he really needs no further reintroduction, but I think I will go ahead to present to you Dr. Aaron Sayal. He is our keynote speaker this year, and he comes loaded with 25 years of experience as an emergency physician. He works at the New York General Hospital in Toronto, Canada. And Dr. Sayal's special interest is in emergency orthopedics. In fact, he runs a minor fracture clinic in his hospital where he works. And he also is an associate professor at the University of Toronto. And what's really impressive is that he founded and directed the casted workshop, or the casted courses. These courses travel around the world, internationally, as well as locally in Canada as well. And he's again here with us in Jamaica not physically, unfortunately, but but here with us nevertheless to present at our conference. So, Dr. Sayal, we want to thank you once again, and the floor is yours. Welcome once again, Dr. Aaron Sayal, to deliver a talk to us. Thank you.
Dr. Eiffel, thank you very much. And again, an honor to be here, an honor to present, and thank you all for coming back and joining after lunch. To continue the theme of riddles, why are the auto ankle rules bad to the bone? Well, it might take a half an hour to get the answer, but I will try to pass along some pearls to you that will help you with subtle ankle injuries. It's not really for the obvious ones. Kind of similar to the previous theme, our job is to try to pick up the subtle ones, and the auto ankle rules can sometimes harm us. In the chat box or in the poll are a couple of questions just about how often you use the auto ankle rules and how comfortable you are looking at the x-rays. If you have a couple of seconds to answer them now, that's great. Because what I'm going to try to do through this talk is to challenge how we currently do things. The auto ankle rules have been around for 25 years. They're very well studied. They've been very well documented. They actually are an excellent rule for who needs an ankle x-ray. We just use the rule wrong in Emerge generally. So if somebody comes in and has an ankle x-ray, our first step is, are you tender the posterior 6 centimeters of the lateral malleolus? Are you tender posterior 6 centimeters of the medial malleolus? And if you are, we get an x-ray. If you're not, we ask, were you unable to weight bear 4 steps immediately afterwards and unable to weight bear 4 steps in the emergency department? And if you have been unable to weight bear, then you get an x-ray. We then look at the x-ray, and we look at the x-ray as we normally do, and we pay a lot of attention to something called the ankle mortise. And we try to pick up our ankle abnormalities. And that's a pretty general routine of what we do. What I would suggest to you is that challenge number 1 is we're going to think differently about the auto ankle rules, because these auto ankle rules actually have absolutely nothing to do with an emergency department ankle exam. The rules are strictly, they're not who needs an x-ray, they're actually support for who does not need an x-ray. It's a little bit of a different way of thinking about it, right? But it's not enough to say if we do these rules and now you need an x-ray, good, I'll look at the x-ray. That's not nearly enough of a history. It's not nearly enough of a physical exam to do it. All it tells you, the rules tell you, is who does not need an x-ray. So you can exclude an x-ray from the workup of certain patients if these auto ankle rules apply. So they are a great tool, but think of them as a tool for who does not need an x-ray, who you can exclude. Because as we talked about in the earlier session, just taking an x-ray by itself is not nearly enough. If you want to interpret an x-ray, you need a history and a physical exam. And the auto ankle rules asking you, are you tender in these 2 spots? And what was your history? Could you walk or not? Is not nearly enough of a history. It doesn't help you identify the red flags. When we look at ankle x-rays, there are 3 x-rays that we get, 3 views. I'm sure you've heard of these. It's pretty easy to recognize which one is the lateral. That's the one that's off to the side. Got it? And then there's an AP, and everyone talks about this thing called the mortise view. The mortise view, just so if you wanted to reach down and feel your malleoli, your medial malleolus is a little bit in front of your lateral. When your lateral is a bit behind, the way to make them equal is you take your foot and you turn your foot in about 20 degrees. So the mortise view, the way the x-ray technologist takes the film, is they take the patient's foot and they actually turn the foot in about 20 degrees. And then what they're trying to do is get a better view of the mortise. The mortise is this channel that we'll spend a little bit of time talking about it because it's very important. This channel between the medial malleolus and the talus, and it gets compared to the talar dome and the tibial plafond, the ceiling of the tibia. So this is the channel that we're looking for. We're looking for the view that gives us the better view of the channel. This looks a little cloudier, a little murkier in here. This is the better view of the channel. This is the mortise view. And the last view then is the AP view, just shot forward. So this is what we look at. Just to review, And briefly, the reason it's called a mortise is actually a woodworking joint. If you want to take a leg of a table and then convert the weight or carry the weight at 90 degrees, one of the strongest joints in woodworking is called a mortise and tenon joint. And the mortise is this here, the part that receives this. So the mortise is the part of the distal tibia that receives the talus. When we look at it clinically, though, even though there are 3 sides to this mortise, right, the talus, if it shifts, it only ever shifts laterally. So this is the only, we have to wonder if this is wide compared to here. That's the only thing we need to compare. It never widens between the distal fibula and the talus. Therefore, when you look at the mortise, you really only need to compare two components of it. You don't have to worry about this last component of the mortise. Just ignore that. What we need to appreciate is the ankle is a very, very fussy joint. When patients walk, when we walk, 85 to 90% of our weight goes through our tibio-talar joint. 10 or 15% goes through the fibula. But if the talus shifts by 1 millimeter, there have been cadaver studies done in the 70s. They were repeated earlier in this century, right? In the 2000s, they repeated the studies, and they found that if the talus shifts by 1 millimeter, patients maldistribute their weight by 42%. If it's 2 millimeters, 4 millimeters, 6 millimeters, the number, of course, goes higher. But the greatest shift is from 0 to 1 millimeter. So we look very carefully at the mortise for good reason, because the ankle mortise demands perfection. Because if that mortise is not perfect, patients will get arthritis down the road. They will not be happy because so much weight goes through that joint. It's a very fussy joint. It's very particular. So it is, in fact, very important. We spend a lot of time looking at the talus, and that compared to the medial malleolus, we look to see if the mortise is widened. We'll show you on cases why it's important. But what's missed in the emergency department? See, typically what we do is we focus on the mortise, and we really don't pay too much attention to the other views. I'll tell you, there's a lot of valuable information on that lateral film. So challenge number 2 is to think differently about the 3 views. It's not to minimize the value of the mortise. It is super important. We will go through details. We'll show you subtle cases. We'll show you not subtle cases. What we want you to do is when you start looking at ankle x-rays, start at the lateral first. It's very important that you do this because this is where the most common mistakes are made, and subtle mistakes show up here. And the other person who tends to miss these sometimes is the radiologist as well. So we're going to pay a lot of attention to the lateral, and specifically what you're going to be challenged to do is each time you see it, trace out the tibia. Not in this case, but sometimes they have a very subtle posterior malleolus fracture. The 3 malleoli, we know the lateral malleolus, we know the medial malleolus. Those are the obvious ones. The 3rd malleolus is the posterior malleolus. This is not fractured, but we'll show you cases. And if you ever see a patient who has a lateral malleolus fracture and a posterior malleolus fracture, that is almost for sure an operative case. But if it's just a lateral malleolus, many of those are non-operative. So looking for that posterior mal is very important. The other thing that's really important to look for is you trace out the fibula. You have to look through the tibia. You almost have to, like, in your mind, digitally subtract it as if there's no tibia there and trace out the fibula, because sometimes the only view on which you can see a fibular fracture is on the lateral film. There are other important things on the lateral film, but in the interest of time, we won't be able to go through it today. But what I want you to do is make sure when you look at, because we ignore the lateral, because it's so important, train your eye to look at it first. By all means, then, look at the mortise. It's super important, as we talked about. 1 millimeter shift means 42% maldistribution of weight. We'll show you subtle cases. We'll show you less subtle cases. And then look at the AP. It's an extra view. Always, it's, whatever views you have, go take a look, and you may get some information about other injuries, other fractures on the AP. But look at the lateral first. When we look for patients with ankle injuries, we don't miss these. These are fairly obvious diagnostically. Procedurally, we have to appreciate that we need to reduce this to protect the cartilage, to reduce soft tissue swelling. There are a lot of reasons why we need to reduce this. But this is not, the auto anchor rules aren't for those. I'm going to show you with a whole bunch of cases. And in the top right, it says auto anchor rules. And when we introduce a case, you'll see the patient's age. Auto anchor rules just tell you how the rules help us. Oh, this patient's non-weight bearing, but tender over the lateral malleolus. So they deserve an ankle injury, an ankle x-ray. So because they're tender laterally on the posterior side, this person's ankle actually looks pretty good on x-ray. On the lateral, it looks fine. How did he injure it? Mechanism is important. If he's playing basketball, he inverts his ankle. We look at it, even look for swelling. There's not a lot of swelling. So if it's just mildly swollen on the lateral side, it's not so bad. Many of these can weight bear as tolerated. They can get into an air stirrup. Most of these ankle sprains, relatively mild ones, are better in a few weeks. A couple of the ones that are more swollen can sometimes take a couple of months to get back to sports. And there's a small subset, maybe 5 or 10% of acute ankle injuries that can take actually 6 months, 9 months later, the people still aren't happy with their ankle. So again, the degree of swelling is helpful. Examine patients as well. It's not all about the x-ray. Here's a 69-year-old lady, auto ankle rule. So she injures her ankle. She's non-weight bearing. She's tender over her lateral malleolus. Her medial malleolus is non-tender. When we challenge ourselves to look at these x-rays differently, the first thing we're going to do is go look at the lateral film. Trace out the fibula. And if you trace out the fibula, right, the radiologist has looked at this and it says there is a distal fibular fracture. Maybe a hint of it there, but you can see there's perhaps subtle, there's a lucency coming back here. So there is a distal fibular fracture, best seen on the lateral film, actually. The other thing there is that the radiologist has missed, what's that little sliver back here? This is a posterior malleolus fracture. Now, we're going to pay close attention to the mortise. The radiologist says the mortise is congruent. What you need to do is compare this distance from the talar dome to the tibial plafond, the ceiling of the tibia, and compare here. The arrowheads are the exact same, but look how much longer the gap is between them. 1 millimeter means it's shifted. This is subtle. This is not obvious, but this is subtle shift. In order for this to shift, for the medial side, for the talus to shift over, one of two things has to happen. There has to be either a medial mal fracture, which there is not, or there's a deltoid ligament injury. And the deltoid ligament is a very important clinical finding that's found below the medial malleolus. And the auto ankle rules never ask us to touch it. And if we miss it, it's a very important clinical finding to raise our index of suspicion, because a significant medial malleolar sprain, a significant deltoid injury, is an equivalent to a medial malleolus fracture. As a more subtle finding, the distal tibia, right, the plane of it should be absolutely parallel to the plane of the talar dome. This is called talar tilt. And again, if something on the medial side has given way and dropped down, it allows the talus to drop. So this patient, in fact, does not have a congruent mortise. This is very subtle, but he definitely has a posterior malfracture, has a lateral malfracture. This is a surgical case. What should happen in emerge? You should get a splint, and at a reasonable hour, you should talk to orthopedics. This is an operation. This requires operative treatment. What happened? The patient got a foam walker. This was missed by the emerge doctor, missed by the radiologist. The patient was allowed to walk on it. And when she followed up day 5, these are very unstable ankle injuries. They repeated the x-rays. Right? Radiologist, a different radiologist reads it now. It says bimalleolar fracture, distal fibula and posterior. Correct? Right? There's also a subluxed ankle. This ankle is not in a perfect position, but there's the distal fibular fracture that's now shifted off. There's the posterior malfracture. And the surgeon, the radiologist says there's a widened mortise, worse since December 28th, meaning it was present in December 28th, and now it's more obvious. So this patient got their expected surgery. But these are subtle cases. Here's a 53-year-old lady. Go look at her x-rays. Take a couple of seconds. Auto ankle rules, non-weight bearing, tender laterally. Her medial malleolus is non-tender. So she gets an x-ray. So we just look at the x-ray. The emerge doc sees the x-ray, and there's a little hint, is there a fibular fracture? And in fact, when you look on the lateral, there's the fibular fracture. So the emerge doc diagnoses the fibular fracture, foam walker, follow-up. The radiologist has confirmed it. There's an undisplaced oblique fracture of the fibula, and says the ankle mortise is congruent. So what's this lady's story? She actually was seen in Emerge, and then she returned to the emergency department 2 months later. She says that when she came, her initial visit, she was diagnosed as a fracture. She was given a foam walker, a boot to walk in, and a referral was made to orthopedics. She says the clinic never called her. So she wore the boot for a month. She took it off herself. She never really got follow-up. She was having pain, but she kind of had other issues where she didn't really want to come back to the hospital. So she sort of didn't come back, and her sister prompted her to come back. If we go back and look at her original x-ray, so I see her in the emergency department on the second month, 2 months after. She never came back for follow-up. If we go back and look carefully at her original films, what's the first view we should look at? Look at the lateral film. We're going to trace out two things. When we trace out the fibula, we see the fibular fracture, right? We know there's two other views. Okay, that's the mortise view. But when we look at the fibular fracture, there it is. The other thing, trace out her tibia. And what do you see in the back of her tibia? She has a very subtle posterior malleolus fracture. Missed by Emerge, missed by the radiologist. Look at her ankle mortise now. This is the better view of the mortise. Compare this gap from the medial mal to the talus to this gap from the talar dome to the distal tibia. It's subtle, but if you wanted to measure it, it's 1 millimeter. If you're like, I'm not sure if that's wide or not, you can x-ray her opposite side. The other thing, if you clinically examine her, her medial mal is non-tender, but her deltoid is tender. It's sore, it's swollen. This is how it could shift. But we miss the clue if we just do what the auto ankle rules tell us to do, which is what? Which is distal, posterior 6 centimeters of the medial mal, posterior 6 centimeters of the lateral mal. There's way more to an Emerge ankle exam than just that. This is why I say the auto ankle rules are bad to the bone. So what do we do then? Like, what should she have had done? She should have had a splint. She should have been non-weight bearing. She doesn't have to be admitted to hospital, but talk to a surgeon at a reasonable time because she needs an operation. This is an unstable ankle. What ends up happening? She walks on it. So we take an x-ray when she comes back, right? Again, the radiologist didn't call this as abnormal. This is very subtle. We're not asking you necessarily to diagnose this, but if you just touched her on the medial side and you saw her deltoid was sore, this would be a red flag. If you looked for this lateral mal and posterior mal, this is almost always operative. When she comes back 2 months later, now we repeat the x-ray. So when I see her in the Emerge at 2 months, I repeat her x-ray, and you can see she has destroyed her ankle. And when you compare it to how early, just 2 months earlier, look at all this arthrosis as the fracture is trying to heal. Her ankle is subluxed. The talus is definitely shifted. It's way wider now. And she's going to have a horrible outcome. What she needed was just a plate on it after the first one. And now she may need a new ankle, an ankle replacement. This is how subtle these ankle injuries, these bad ankle injuries can be. This 22-year-old, right, injured her ankle, non-weight bearing, tender lateral side. You can see how swollen she is laterally. She was seen by one of our senior Emerge residents, and the chart was written on by one of our staff, excellent staff doctors. The resident said, oh, I think she's got a lateral ankle sprain, recommended she get one of those U-shaped air stirrup braces. The staff doctor wrote, no, this is a severe sprain. Look how swollen it is. She should get a boot, a foam walker, and follow up in the minor fracture clinic to be seen. So this happened late one evening. The next morning, the radiologist looked at the x-rays and said, wait a second. I think she has a fractured talus on the x-ray. And it's not a common injury, but I'll tell you, it's commonly missed. If you look at her films, it's hard to know what normal is so again, unless you look at these regularly, normally the talus is not a jigsaw puzzle. It is all intact. On the lateral film, there's a normal talus in green. It's hard to see, but there are splits down here. It's certainly suggestive. Clinically, so when she comes back the next day, she never actually came to the minor fracture clinic to see me. She got recalled to the emergency department. They did a CT scan. This is the same lady. She's destroyed her talus. And she's so swollen, the surgeon can't even operate for 5 days. The patient's admitted to hospital, leg elevated to get the swelling down, and she gets operated on 5 days later. And it's a terrible operation because she has a terrible fracture, right, to a terrible bone with terrible healing capacity. It got missed for 7 hours, 8 hours. That didn't cause her any real harm, right? She just has a bad fracture to a bad bone. But when somebody actually then asked her story, she didn't just invert her ankle. She jumped off of a garage. She was 8 feet off the ground and landed down. She actually loaded. So mechanism is super important. She did something like this. It wasn't snowboarding, but the force is the same. She came right down on it. That's how you intercalcaneus, talus, distal tibia, knee, hip, thoracolumbar spine. When you hear the mechanism, you got to go looking for these things. The only thing she did was her talus, but she destroyed her talus. If we miss the history, right, the physical exam, auto ankle rolls just touch medial laterally. That's what the resident did. What he didn't do was touch where her broken bone was, where her talus is, which is the anterior joint line of the ankle. The auto ankle rolls have nothing to do with an ED ankle exam. She should have gotten a splint. She should have gotten a call to ortho. She should have gotten operated. Don't forget mechanism. The auto ankle rolls don't ask us about it, and this is how we risk stratify. If you hear axial load, be really worried. She came down on, you got to go all the way back up. Somebody can axial load a calcaneus, 12 feet, you should fall. But if you're 80 years of age, you can miss 2 steps and you can break a calcaneus because you have weaker bone. And just think of where the force can come out. Here, 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 and make your way up the chain. You don't have to x-ray everything, but you need to examine everything if you hear about axial load. This is the 45-year-old guy I showed you earlier, right? In the morning talk, his ankle x-ray was pretty normal. He twisted his ankle. He didn't invert in basketball, though, and he didn't axially load. What he said is he was walking on the sidewalk in Toronto. His left leg slipped forward. You're probably sitting in a chair. Put your right leg behind you. And if you fall backwards and you sit on your right leg, he clearly says his foot turned out. External rotation is a very big, worrisome mechanism. He wasn't playing basketball, right? But generally, we encourage our knee to point in the same direction as our foot. And when your foot points out and your knee points straight, that's a huge red flag. But if we miss it on history, guess what? We then also miss the subtle clues on physical exam. When he comes back to me in the fracture clinic, you notice his other sock is off. It's really important. It's hard to recognize subtle swelling unless you look at the opposite side. Where is he tender? He's tender below the medial malleolus. He's tender at the deltoid ligament. Where else is he tender? He's tender at the junction between the tibia anteriorly and the fibula. That's the anterolateral part just above the ankle joint. That's called the syndesmosis. This is where the ligaments are that connect them. Where else do you think he's tender? Proximal third of his fibula. But if you took a history first in emerge and he said his foot turned out, and you examined him and you found he was sore 1, 2, and 3, before you get the x-ray, you're predicting this guy needs an operation. First x-ray, boy, I don't even see it. That's why you need 2 views at 90 degrees. This is what he has, and he gets an operation. So what happens? The foot turns out. There's multiple pieces to this. Syndesmosis. On the inside, it disrupts, fracture medial mal, or you rupture the deltoid ligament. The force comes up the interosseous membrane, and it exits somewhere along the fibula. It could be where you see it in an ankle joint, in an ankle x-ray. That's called a Weber C. Classically, it's a proximal third of the fibula, so people order a knee series, right? But you shouldn't order a knee series, order a tib fib, because it can come out anywhere along the fibula. External rotation's a red flag. This guy's tender here and here. The auto ankle rules don't ever ask us to touch there. We miss the history. We miss the physical exam. He should have gotten a splint. He should have gotten a call to ortho at a reasonable hour. Look out for external rotation mechanisms. If somebody says they're playing, football, soccer, and they're wearing a cleat, they're connected to the ground. Their foot is way more likely to turn out because they don't just slip. They're connected to the ground. And where this fibular fracture comes out, see, if it comes out the middle third, if you order a knee x-ray, you can miss it. If you order an ankle x-ray, you can miss this. That's why for these patients, if you think they've got a higher fibular fracture, order a tib fib x-ray. Don't order a knee x-ray. But this is called a Weber C, right? This is a spiral fracture high up. A Maisonneuve is the proximal third. There's another name for this. Who cares the name? They call it a Dupuytren's fracture, but who cares the name? What you need to recognize is these spiral oblique fractures, when they're here, they're not in isolation. If it's transverse, that's direct trauma. But if it's spiral or oblique, it's a rotational force. And if the patient is tender over their deltoid ligament, even if you don't see a fracture, even if you don't see shift, if they're sore here, you have to connect them. And when you connect them, it goes through the syndesmosis. The patients will be tender here, but we never examine it. We miss the clinical clue. And therefore, this is one piece. This is another piece. It's called an ankle diastasis. It's like two separate pieces. And what is the fix? The fix is to, even if the fracture is high up, proximal third, the problem's the same. Because if this shifts by 1 millimeter, they maldistribute the weight by 42%. The talus isn't sitting under the tibia the way it should. So the fix isn't even to fix the fibula. They don't even operate the deltoid on the deltoid. The fix is to put some screws across, or there's other fancier ways of doing it, of just not letting the talus shift out. The problem is the syndesmosis, the junction between the distal tibia and the distal fibula. So yes, the auto ankle rules start at the proximal fibula, but you must examine its entire length. And if you ever see somebody tender on the medial side, and they're really hardly tender on the lateral, you should x-ray their ankle and x-ray their tib fib, because that fibular fracture can be quite subtle clinically. So the auto ankle rules will challenge you to think differently about them, right? Because they have nothing to do with an emerge ankle exam. They don't ask us about history. And as we talked about in the earlier talk, history and physical exam are so important. You can't shortchange it. It's not all about the x-ray. And your clinical concern goes way up if it's axial load, if it's external rotation. You think about different things. On physical exam, it's not nearly enough. The medial mal, if there's a deltoid ligament injury, that's a medial mal fracture equivalent injury. If it's a significant but if we don't touch it, we never recognize it. Distal tibia, talus, Achilles, calcaneus, none of this we're supposed to touch based on the auto ankle rules. But if you do an x-ray, you need a history and a physical. It doesn't take long, but it needs to be focused. It's a great tool for who does not need an x-ray. But once you decide somebody needs an x-ray, they absolutely need a history and a physical. It doesn't take a long time to do it, but that's what they need. The auto ankle rules are not nearly enough. And think about these three views differently. Because when you look here, you'll see, hey, there's a fibular fracture. You'll also see there's a posterior mal. And when you put these two together, this person's getting an operation. You look first at the lateral view, because we always ignore the lateral view. A lot of important misses are on the lateral film. Then by all means, look at the mortise. Of course, don't ignore it. Don't ignore the AP. Start on the lateral, because we never look at it. There's a fibular fracture. There's a subtle posterior mal fracture. This ankle is in joint. This ankle is perfect. You can look at the talus. You can look at the calcaneus. Ankles in joint. This is a fractured talus. Lateral mal, posterior mal. There's a lot of subtle clues on that lateral film that we ignore when we don't look at it. So challenge yourself to think differently about the auto ankle rules. Challenge yourself to think differently about these three views of the ankle. Pay attention. The main view orthopedically is the lateral view. Go look at it first. It'll show you lots of information. And I'm telling you, if you do this in the next couple of months, you will pick up a subtle ankle case. If you pay attention to this, you'll pick up a subtle ankle case. If you do a full-time emerge, I'm sure that you'll see it. It's that common. And I hope that helps you find your needles in a haystack. So look for those subtle cases. Thank you very much. I'm going to stop sharing. And while we take any questions, I will take this opportunity once again, honestly and sincerely, to say how much of a true blessing and honor it has been to meet with the residents yesterday during the course. It was really a lot of fun to engage with everybody and to have the opportunity today to talk about a couple of things that are a passion of mine. I'm truly blessed to have had the opportunity, and I thank you all very, very much.
No, thank you, Dr. Sayal. It is indeed our pleasure and our honor to host you here. And I'm sure everybody hearing that talk just now would have benefited. Me personally will never be looking at a lateral ankle x-ray the same again. So important, some of the subtle signs that you highlighted, and I'm sure that we are all the better for it. Now, before you sign off, Dr. Sayal, I'm sure we have questions. So at this point, I'm going to hand over to Dr. Guy to see if we have any questions from the chat.
Yes, Dr. Sayal. Dr. Rainford from the chat, she was asking for the patient that the posterior malleolus fracture and the talar tilt that was missed. Why wasn't the patient immobilized for the lateral malleolar fracture? And why was she allowed to wait there?
Right. So great. Exactly. So they thought they didn't recognize the medial side because they said medial malleolus non-tender. They missed the talar tilt, which is quite subtle. And therefore they were immobilized in a foam walker in a boot. The lateral malleolus fracture was recognized, and they thought it was a stable injury, but they missed the subtle clues to the fact that it was unstable, the fact that it was tender on the medial side, the fact there was a posterior malfracture, the fact there was talar tilt. So this is the difference between recognizing subtle and not. Now, she got follow-up. She walked on it. Did she get much harm? Probably not. But you see the patient that was just after that, who was 53 and didn't follow up, you can see the harm that can come. So it was missed. And this is what happens with misdiagnoses. And especially with ankles that are subtle, it doesn't take much to be unstable and to shift significantly. So that's why just, being a little, we see so many cases like they all get thrown in ambulatory, and it's such a fast paced shift that we need to slow down, have good habits, and then you can speed up again. You'll get back to the same efficiency as you are now, but you'll do it with more confidence. You just have to slow down first and go through it. So clearly our colleague who asked the question recognized it and would have managed it appropriately. But these slip through the cracks. They're tricky cases for sure.
Okay, thank you.
Thank you.
Thanks, Dr. Guy.
No more questions, but we do have the poll response that was sent out. Just a reminder, guys, the polls are anonymous and we have a few more upcoming, so answer those polls. So for Dr. Sayal's presentation, his poll questions were, when it applies, I use the Ottawa ankle rules, and the options were almost always, most times, sometimes, or hardly ever or never. So the most common answer at 38% was hardly ever or never. Then we have sometimes at 30%, most times at 18%, and almost always at 14%.
So I'm actually delighted to hear that people don't use them so much, because they're really just a guide, not a rule. And they sometimes will limit, like it's kind of like a ceiling. If you think that's where the bar is set, if you're just starting out, that might be helpful. Once you get some clinical experience and confidence, don't feel like the auto ankle rules are it. You can certainly go beyond them. And again, they miss a lot of important things. So, okay, thank you for that answer. And there's one other answer I think we asked about.
One other one, yes. So my confidence level in reading X-rays. So the options are very high, above average, average, below average, and very low. So most common answer at 67% is average, then 15.4% above average, then 7.7% average, very high, and very low and below are high.
So just go to the lateral and pay close attention to the mortise. Just those two things to scrutinize on an ankle X-ray. And before you do that, do your history and physical, and you'll pick up the subtle cases.
That's it for the poll questions. Thank you.
Awesome. Thank you so much, Dr. Thomas. And thank you, Dr. Sayal, for that very impressive and very thorough presentation. Thank you very much. All right. As we progress through this second session, I want to thank everybody for again joining us at our conference. Our second presenter is none other than Dr. Rajiv Venugopal. Dr. Venugopal did his medical school training at the University of the West Indies in 1992. He did his internship at the Princess Margaret Hospital in Nassau, Bahamas, and he did general surgical residency at the University Hospital of the West Indies in 2000. He did his fellowship training at the University of Miami School of Medicine and currently works as a consultant plastic surgeon at the University Hospital of the West Indies. And he is a lecturer in surgery at the University of the West Indies. Today, he has a very important talk for us on wounds and burn care. So without further ado, I welcome Dr. Rajiv Venugopal.
Thank you, Dr. Eiffel, and to the JEMA team for putting on such an excellent conference. And I've learned so much from these excellent talks. This area that we're going to cover is extensive, and it's obviously not realistic for us to really hit everything. So I've decided just to focus on certain areas in burns as well as in terms of wound management. Now, as we know, a burn injury is a type of trauma, and that is due to the transfer of energy of different types to affect tissue. When you look at adult admissions at the university, you realize that majority are due to flame burns. Now, if you compare that to the Bustamante Hospital for Children's admissions, you realize that majority of children injuries are due to scald injuries. Everything in medicine, improves due to some major disasters, and mass casualties, which happened in fires in theater as well as in nightclubs, led to the improvement of overall burn care. Now, surgeons realized that early on that patients who actually didn't make it to the hospital or who actually died early in their management died of inhalational injuries. And as Dr. Seil said, the history is so important. Being stuck in an enclosed space is important. And the key here is that enclosed space is not always a house that we think about, but it could actually be a motor vehicle as well. They may have symptoms suggestive of respiratory tract irritation, such as cough, dyspnea, and maybe even hoarseness. When you examine them, they will have signs: burns to the head and neck, singeing of nasal hairs and external hairs, hyperemia of the oropharynx area. And what you do not want to hear is stridor. They can have lower respiratory tract added sounds as well. This photograph illustrates why we teach you from early in medical school that it's so important to intubate early, because you can see how technically difficult, due to the edema, that intubation will occur. Because you don't want to end up in this state where you're going to end up having a failed actual intubation attempt and move on to a surgical airway. And when that surgical airway of a tracheostomy is combined with the actual wounds that the burn patients have on the head and neck, it's both of a nursing and a management nightmare. We spent time talking about the upper airway injury, and we're going to now focus on what happens to the lower airway. Now, once that hot air goes down below the glottis, there's, again, inflammatory process occurring, and the real problem will be in terms of diffusion of gases due to the alveoli filling up with inflammatory process. So there's the diffusion of gases, which is going to lead to potential hypoxemia. Diagnosis of this is not, again, with radiology, and we keep hearing about this. It's about looking, inspection, right? We don't actually get to feel, but inspection, and this is done with a flexible bronchoscope. To be objective, they've actually have a grading system on how extensive the lower tract injuries are, and they really look at carbonaceous material, how erythema the mucosa is, if there's frank ulceration, necrosis of the mucosa, as well as luminal obstruction. And this grading system goes from like 0 to 5. Once you have grade 2, this would be a grade 2 type injury. What you see I'm highlighting there. There's a significant amount of increase in morbidity and mortality based on literature. The other part of the inhalation injury, one has to think about the cellular level. And here we're talking about gases which are released due to combustion. The most common one is the biological, is carbon monoxide. We know this colorless, odorless gas unfortunately has close to 300 times more affinity to binding to the hemoglobin molecule, leading to obviously hypoxemia. And we know that that's clinically difficult to detect because that pulse ox you're going to put on is going to read 100% saturation, because it is 100% saturated, but with the carbon monoxide molecule. It can also affect at the mitochondrial level as well. But also remember, in industrial files, things like cyanide gas is also released. So it's not carbon monoxide alone, but carbon monoxide, unfortunately, affects the neurological symptoms. And it's not surprising that the symptoms are going to be neurological. And to be objective, we don't have it here locally, is to measure carboxyhemoglobin levels. Every one of us who live in a corporate area will have carboxyhemoglobin, but when the levels rise up close to 50%, mortality is almost 100%. Now, in terms of predicting survival, it's the box formula. And that's pretty simple. It's the age plus the burn surface area. Now, we also realize that if there's inhalation injury, that mortality goes up. So it was modified with an addition of a factor of 17 when the presence of inhalation is present. Now, just a clinical scenario, 50% burn a 50-year-old man, that gives you a box formula of, a Bu formula of close to 100. Now, once you get to 100, bad things are really happening. So it is really something that is simple and allows you to work out prognosis. The important thing here is that, big burn centers really salvage patients greater than 130 or more, or less, sorry. So, it is something that you can use as a simple rule of thumb to predict how bad a burn is. Now, if you look at the physiology of the burn, we all realize it's a massive inflammatory process which is happening, and that's a problem. And we all know that, histamines, bradykinin, the interleukins, all of those things lead to a leaky capillary, and that leaky capillary leads to big albumin molecules coming out, which pulls fluid out of the intravascular compartment into the interstitial compartment, leading to edema. Now, this is just to exaggerate or not accentuate, I should say, the problem with that inflammatory process. As the burn surface area greater than 20, you can see there's a steepward climb in the amount of inflammatory process. And that's probably why any burn greater than 20% should be managed in a special center. We talked about that vascular depletion which occurs with that inflammatory process. And we know early literature talked about reduced renal perfusion leading to renal failure and hence death. We also know about Curling's ulcers due to the reduced perfusion of the GI in the burn patient. But it can also affect all of the other major organs and hence leading to multiple organ failure. Now, surgeons realize that to do the resuscitation, there must be an objective way, and there are many different formulas. Most of the popular formulas actually comes out of Texas. We all know about the Parkland's, which talks about 4 times the weight in kilogram, and then guided by the rule of 9 to work out the burn surface area. And Parkland's is really talking about resuscitation in the first 24 hours, just to emphasize it's starting from the time of burn, not the time of admission. And you're using crystalloids, specifically lactated ringers. And you're going to give the first 8 hours, half of that calculated volume in the first 8 hours. The other formula I have on the slide is the Brooke Army Hospital formula. And interestingly, you can see that that factor there is used as 1.5. And they also administered colloids. Now, the reason Parkland said no crystalloids is to try to reduce that inflammatory process into the 48 hours and hence losing less of the colloids if given in the first 24 hours due to the leaky capillaries, right? One must always remember that children are not small adults, and you need a different formula. There's a Lund-Browder chart, which allows you for more accurate assessment because the head to body ratio is different. Now, with the aggressive resuscitation, we encountered a new problem, which is the creep phenomena. And that's that interstitial edema getting significantly. And the real two problem areas really are within the lungs and the intra-abdominal compartment, and leading to abdominal compartment syndrome, as you can see in the photograph, which will need a laparotomy for decompression. So large burns with large resuscitation, for example, if you use the Parkland's formula for that same 50% burn, you're going to be giving 14 liters of fluid in that first 24 hours. So you can understand how that a person could develop that significant edema. So due to this problem, the ATLS protocol in the last 3 years has reduced their constant in the formula from 4 down to 2, closer to the classical Brooke Army Hospital formula. Obviously, the urine output is the most dynamic method of assessing your resuscitation, and that is still the case. Even as an experienced clinician, it's sometimes hard to differentiate the deeper burns. I mean, we all know a scald injury, it's only affecting the outer papillary dermis. As you go, a deeper injury, such as a flash burn, such as seen in this patient, that's going to heal within 5 days. And it's still probably within the papillary dermis. But this deeper scald injury has gone into the reticular dermis. And you can see that in this patient, looking at their shoulder, you can see that white appearance. That's kind of giving you the idea. Once you have blisters, it's usually suggesting that there is still a good element of dermis around. But that deep superficial partial thickness can take up to 10 to 14 days to heal, as seen in this patient in the second week. Now, once we teach you about chemical burns, we always tell you that it's more likely you're going to get a full thickness burn, but they can have deep partial thickness injuries, and they can heal pretty well. As you can see, this has taken almost 3 months to regain back full epithelial elements here. But chemical burns, as classically described, gives you full thickness burns, especially with the concentration, the time attached to the burn will lead to all elements of epidermis and dermis being lost. And in these patients, you need to go to the operating theater and cover them with skin grafts. So a few minutes on special burns, and the electrical burns are going to be highlighted here. Think of electrical burns as gunshot wounds. There's an entry and an exit. Usually the entry is in the hand, exit on the feet. But if any other point makes contact, there will be exit points more proximal than the feet. Also, to think of it as an iceberg, because the skin has high resistance. So once there's entry of the current, it's going to go along the neurovascular bundles, which is encased inside the muscle compartments and running on the bone. And that heat generated there is really what is going to cause severe muscle injury. But acutely, we must always remember they may be running cardiac arrhythmias, and monitoring is important. And the real also acute problem one must remember is the myoglobin damage that it could be done to the renal system. So myoglobin, we all know, is managed with flushing. Flush the kidneys. You want to put out the urine twice what's expected, alkalinize it by adding bicarbonate to each liter of lactated ringers. And you can use mannitol for forced diuresis using the osmotic agent that mannitol is. This is a patient who suffered a high voltage injury within the university compound. And you can see the entry wound in his palm. He was actually taken within under an hour to the emergency operating theater, where he had, as you would know for electrical burns, that they will develop compartment syndrome quickly. And he had full decompression with a fasciotomy, carpal tunnel release. And despite this and good resuscitation management and burn management, he went on to losing the distal forearm and hand. So these can be quite devastating injuries. talking about wounds in an acute situation, I must mention distraction injuries. None of these wounds are going to lead to immediate death to the patients in the first couple of hours. However, internal injuries will. And these external wounds can be major distractions. So one must follow that protocol of adhering to that detailed secondary survey. So now I'm going to just quickly talk about from burns to wounds in general. You know, there are a lot of different wounds which will present to the emergency room as well as to the family physicians. Now, as Dr. Sayal had mentioned earlier, it actually accounts for a very small amount of visits to the emergency room, but leads to a lot of potential legal issues. And these legal issues are usually related to infections, foreign bodies, and missed injuries. Now, this is what we've learned from the first day of medical school and community medicine, that everything is linked, the host, the pathogen, as well as the environment. Now, as a surgeon, when we talk about infection, we try to classify wounds into clean, contaminated, and dirty. And as a clean wound, it's basically where there's no infection and we're not entering any luminal structures. It's got an infection rate under 4%. And unless you're opening the chest or into the CNS, you're not going to use antibiotics unless you're putting in foreign material. So in a class 2 or a clean contaminated wound, we're entering a luminal structure which is not infected. And the rates are usually of infection is 9, but these patients are managed with prophylactic single dose of antibiotics. But most of the wounds we're going to deal with in the emergency room are going to either fall into the contaminated or dirty. You know, the contaminated would be relatively wounds under 4 hours, and they will have infection rates over 10%. Dirty wounds are going to be when they're older and there's obvious devitalized tissue, as seen in this extensive degloving injury of this upper extremity. And obviously in this patients, as well as in the prior class, you know, an empiric course of antibiotics will be needed. So in reviewing for this, I just ran across this European opinion about how wounds should be assessed and managed. And I think it really looked at it the way most of us would look at it. It looked at the type of wound, and basically anything except a straightforward stab wound was considered to be high risk. Now, if you look at the actual location of wounds, we all know that the head and neck has much better blood supply. So, you know, that would be a relatively low risk. In terms of actual patient characteristics, you know, older patients who are immunocompromised, and presence of any vascular disease or the presence of diabetes would make it a high-risk wound. So their guidelines suggested that any single factor would suggest ideally may need the need for an antibiotic coverage. However, you have the right host with minimal gross contamination, then not using parenteral antibiotics should be definitely considered, because we all know what are the problems with antibiotics in terms of side effects, resistance, and potentially lethal allergic reactions and complications. Now, something I probably also need to practice is the documentation of when I'm not going to be providing parenteral antibiotic cover in your record keeping. So in terms of dog bites, we've gotten a lot of attention regarding a young child which was mauled. And most of these maulings occur in the head and extremity areas. Looking at bite literature, focused really on children, I was surprised that human as well as dog bites really almost share the percentage of incidence. Now, it does usually occur in summer months because the kids are out of school and outside, and it classically occurs between 3 and 7 because, you know, it's thought that they're probably less supervised because the parents are busy at that time. A majority of them are very familiar with the animal. Now, the pit bull, with no surprise because of its characteristics, is the main offender, and certain places in the States have actually outlawed pit bull due to these reasons. This is also interesting that looking at the anatomical sites, purple stands for head and neck, and you realize as the child is small and it's about the size of the dog, that most of the injuries occur on the face. And as you get older, it's on the extremity. So this is usually the only clinical situation on the face that I'm going to close a dog bite. But even with this, I ran into an infection process in the 5th day, requiring the wound being partially opened and irrigated daily. But we did end up with a fairly good outcome. The good news about is that even in the literature, majority of these bites do not have to go to major surgery, but it's still a significant reason for monies paid out by insurance companies. So we cannot talk about wounds and not mention tetanus. I'm not going to spend a lot of time here. We all know, you try to document the active status of their immunization. If there's any doubt in a high risk kind of wound, soil contamination in a high risk host, you must think about providing passive immunization along with starting on the active process. We're fortunate in Jamaica not to have rabies, but again, every emergency room theoretically should be able to manage 2 patients with potential exposure to rabies. And the general consensus is for the population, every 5 million persons, they should have stock for treatment for one of those patients. When you look at WHO and its data on dog bites in low-income areas, actually rabies is actually one of the reasons that there was increased mortality in this group. What was quite interesting for me is that with the return of the students back to clinical practice, we're talking about universal precautions in COVID, and I realized that the slide, I really didn't have to change it much. The only thing I have to tell them is that the masks need to be of a specific type, as you all know. The irrigation process must be done with local anesthetic on board. So before cleaning, I provide some form of local anesthetic. I usually use ice as a distracting agent. Another technical tip is don't inject into the skin, but inject into the wound area and inject extremely slowly. This is a commercial irrigation device, and this is going to have both pulse lavage as well as removed by suction. We know that if the high pressures are done, there might be problem with damaging tissue as well as seeding tissue. A simple 10 cc syringe can generate a fair amount of pressure as well. Most of us are very used to doing this in the emergency room. This is something we learned from the Ganga Hospital, which actually has a tray with a sieve on top, and then that way you do not flood the entire emergency room or the operating theater. And this is something that we should think of modifying. We've heard a lot about radiology today, and it's not the end all. Foreign bodies are not always seen. Glasses are radiolucent, but definitely it's something that can be used to image foreign bodies. But it's very careful, judicious searching for foreign bodies after local anesthetic is provided. That is important. And one of the tips I'm going to tell you is that anytime I'm doing where there's glass pieces, I'm also going to tell the patient, I'm going to advise them that there might be deeper tissues which has glass and it will make its way to the surface, and not to be alarmed if this happens. So in terms of suture technique, don't shave. Use simple interrupted sutures. In severe contaminations, avoid deep sutures. And if there's high risk wounds, delayed tertiary intention is definitely an option. In terms of what antibiotics to use, most of the times, we're dealing with staph and strep because we're dealing with skin. Penicillins cover that. In terms of bites of animals, Pastorella species are important. You definitely need a penicillin with some anaerobic coverage with the beta-lactam. If you have penicillin allergies, the combination of a quinolone or a cephalosporin with metronidazole would be your second choice. You know, just to also remember for the people who are penicillin allergies, for broad spectrum, Bactrim is definitely a good choice. For human bites, Echinella is the species which is problematic, and again, it needs to have anaerobic coverage. So I think Dr. Sile had mentioned about this in his first presentation about the high chance of missing injuries in the hand. And, you know, we're going to make an emphasis here. You know, the dorsal lacerations easily can damage tendons. Without careful inspection and examination, you might miss that. Nerve injuries, especially on the fingers, can be missed. Remember, prior to assessment, do not block up the patient. And again, emphasizing that sometimes you need to bring the patient back early or refer, you know, to get a second opinion early. You know, we're just making a known to the emergency room physicians with the expansion of the plastic surgery service. We're doing, you know, major and minor hand cases now. So who do you need to send to for surgical opinions? Obviously, extensive facial wounds, any wounds around the eyes, I think you should refer. Degloving injuries, obviously, I think no matter how severe, even though this is extreme case, any wound with involvement of a bone or joint or associated with an amputation should be referred. I'd like to just end with, you know, Jamaica made great strides last year with changing its law towards assault secondary to dog injuries. And we've had, unfortunately, great reference to it in the international literature because of our high incidence of chemical assaults. And we owe it to our victims that we need to think about really appealing for new legislation for these victims. So I'd like to thank you for your time. And any questions?
Thank you very much, Dr. Venugopal, for that very interesting and thorough presentation. You've covered quite a lot in such a short period of time. I knew we had some questions in the chat, but what I want to do is sort of head straight to the polls, because I think those questions were addressed. So Dr. Thomas, if you would just come on and take us through those poll questions. Thank you.
Okay, sure. Thank you. All right, so we have 3 poll questions. We start off with what is the most common burns in adults? The answers were A, scalds, B, chemicals, C, electrical, D, flame. And our most popular answer is flames at 67.5%. Then we have scalds at 20% and chemicals at 12%.
Flame would be,
Dr. Venugopal?
the flame would be correct. The trick question there was the adult population. So if it was the children, the scalds would definitely be the first choice.
Okay, and our next question, what is the new resuscitation formula? So our options are A, 4 times the weight in pounds times the body surface area of the burns, B, 4 times the weight in kilograms times the body surface area of the burns, C, 2 times the weight in kilograms times body surface area, and D, 2 times the height times the body surface area. And so far we've had 2 selections, with C being 2 times the weight in kilograms times the body surface at 64%, and B, 4 times the weight in kilograms times body surface at 36%.
So as I mentioned, the ATLS protocol has recently changed, moving it from the classical Parklands of 4 down closer to the Brook formula, which is 2. So the new resuscitations are 2 times the burn surface area plus rather multiplied by the weight in kilograms.
Okay, thank you. All right, and the final question, what is the most likely location for a dog bite in a child? So options are A, the face, B, torso, C, lower extremity, and D, upper extremity. So most popular answer at 70% is the face. Then we have lower extremity at 17% and upper extremity 12%.
Right. And again, it comes down to, the level of the height of the child in relation to the animal. So the smaller children definitely are in, the face is going to be the highest.
Okay, thank you so much. That's it for the polls.
Thanks so much, Dr. Thomas. Dr. Venugopal, we were just about to let you go, but the chat is lighting up with questions. So at this point, we're going to give a few more minutes. And Dr. Guy is going to just tell you some of those questions. Dr. Guy?
Yes, Dr. Venugopal. Okay, in terms of the question, the first one is from Michelle Beckford. She's asking, should we cover a superficial burn? And also, should we debride blisters or just apply topical cleaning?
Right. That's an excellent question and a very common question and a controversial question. So depending on which school you belong to. So the long and short of the answer is that the blister itself provides some form of a biological dressing. So I personally will aspirate the blister to try to have a controlled rupture. And if it's a small wound and the person has a very controlled environment, I'm going to go with an open dressing technique rather than a closed dressing technique.
Okay, thank you. Next question is from Garth Rattry. Do we have a functioning burn unit?
That's a very political question, Dr. Rattry. Thank you. The answer is that we don't really have, by medical definition, a burn unit, which is a location which is completely isolated and can provide significant operative interventions on the patients as a freestanding unit, which is probably something that is not realistically, from a financial point of view, achievable in a small nation like ours, right? Because the burn patients take up, as you might have read, a fair amount of resources. So one person can really use a fair amount of resources. And if you're thinking of having to provide for the country in general, it would be, I think, illogical for us to create a burn unit. And what we think we should have is that every major hospital have major areas that burn patients are isolated and can be managed. The patients who require extreme resuscitation will have to be managed in the general intensive care units, both for adults and children. I hope that answers that question.
Okay, thank you. We have a lot of other questions, but I'm just going to ask one more. If possible, if you can address them in the chat, that would be good. So I'm just asking one more. Dr. Rainford is asking, any special considerations for lightning injuries?
You have to think of it as an electrical burn. There's an entry and an exit wound. I've only managed two, and similar to a high voltage electrical injury, one of them actually had arc injury, where it means that there's ignition of clothing due to the passage of the current. The other significant, these high voltage electrical and lightning injuries, is the chronic problem with neurological symptoms, pain, obviously, being the biggest one.
Okay, thank you, Dr. Venugopal.
Thank you.
Thanks, Dr. Guy. Thank you so much, Dr. Venugopal. As mentioned, we have a few more questions. We'll appreciate.
I'll try to answer that in the chat.
Yes, thank you so much, Dr. Venugopal. All right, guys, we are swiftly moving on to our next presenter. Our next presenter is Dr. Joanne Paul. Dr. Joanne Paul is a lecturer in emergency medicine with the University of the West Indies, St. Augustine campus since 2012, and previous coordinator of the emergency medicine DM and diploma programs. She's also the medical chief of staff at the Eric Williams Medical Sciences Complex in North Central Regional Health Authority in Trinidad and Tobago. She has done her base general pediatric specialty in the UK, and then she went on to do fellowships in pediatric emergency medicine in Australia and the Hospital for Sick Children in Toronto, Canada. She is a coordinator of the Advanced Pediatric Life Support courses, in addition to being an ATLS Pediatric Basic as well as Advanced Burn Life Support instructor. She is a certified emergency department executive with the International Emergency Department Leadership Institute in association with Harvard University. She is a member of the Pediatric Emergency Medicine Special Interest Group with the International Federation of Emergency Medicine, and she is an executive member of the Trinidad and Tobago Emergency Medicine Association. Dr. Joanne Paul is a specialist as it relates to pediatric emergency medicine, as you just heard. So we are very privileged and honored to have her present today on a pill, one pill in a child can kill. Without further ado, let's welcome Dr. Joanne Paul.
Thank you very much, Dr. Eiffel. It's been great to be here with you guys for JEMA. And thanks very much to Dr. Rhonda Hudson for inviting me and stalking me down to make sure I was on time. It's been great. So I'll just go straight into it. Let's go here, right. So as we mentioned before about the topic, now we're going to discuss about the dangerous pills, but it's also a matter of swallows and teaspoons. So it's not just about one tablet. So it's really what pill or one tablet can kill. And we're also going to discuss some recommendations. The peak age group for this is 1 to 3 years old. Now notice for pediatrics, the age group can go to 0 to 18 years old. But for the adolescent population, it's usually where they have drug-seeking behavior and they have excitement behavior in terms of like experimentation, and that might cause its own morbidity and mortality. But in terms of one pill, obviously it wouldn't have the same effect in adolescent population. But the main thing is in that age group of 1 to 3, the toddler age group, it's a matter of size. In terms of the smaller size will have more effect with regards to one pill or one swallow. But it's also a matter of them being on the ground. They will see things that we wouldn't be able to see. They will see a little tablet or some liquid somewhere in a corner, some soda bottle filled with something that we as adults higher up mightn't be able to pick up. And that's an issue. But also, their hand-to-mouth behavior, they touch everything. So their way of interacting with the environment is to put it in the mouth to touch, to taste. So therefore, if they see anything, the first thing to satisfy that curiosity is put into the mouth, and therefore they're at risk. The other thing, I mean, look at this. If you have it hidden, it's so enticing to the child. All these bottles up there, and they will just try everything to climb up and get something to be taken via the mouth. The other aspect is that their body metabolism, it's not really that it's slower or that it's faster or anything. It's just that it's immature. So the kidneys are immature, the liver is immature, and so the entire metabolism is not able to handle a toxicity. And therefore, they do have multi-organ failure very quickly, and they go further. The other thing I would mention is the environment. It's a big deal. It's about a change of the environment. So I usually recommend, just like the defibrillator, I tell parents, keep your medications in one place, either in the cabinet above where it's hidden or in the child-proof area, not in between. So often when people are moving house, where they might change something, or if you have a new family member come to the home and they might leave their medication out, that's when you have the issue where they might find something. So it's just that in between when our gaze is just forgotten and we think, okay, this is new. And the child will just say, well, what's happening here? And that's when they want to investigate curiosity, and they will just put it in their mouth no matter what. And typically, even if it burns, they will swallow first. So it's not like they'll taste it. They'll put it in their mouth, swallow, and then say, that's burning, and then cough and splutter. But definitely initially, they will swallow anything that comes into their mouth. So if I were to spend the next few hours with you guys, Dr. Rhonda Hudson and Dr. Eiffel will shoot me, but also we can't go through all of them. So I really want you to think about the top three, the most important ones. And the biggest one is methyl salicylate. And that is really, in terms of mortality, it's about 70–80%. It's a factor of one of the other factors is that they take a while to bring the child to the hospital. So usually injections, if for instance, the child has taken it, they mightn't see the child for a while, only when they're symptomatic. But also if the child has taken some and shows no symptoms, they'll think, well, it's okay, I wouldn't bring the child. So usually we're behind time and the child is brought into maybe an hour, 2 or 3 or 4 afterwards. And therefore the mortality is larger. So with regards to methyl salicylate, the biggest thing is oil of wintergreen. Now you have it in aspirin, but you also have it in Pepto-Bismol, the entire salicylate range. But oil of wintergreen is almost concentrated salicylate. So it's so concentrated that we have it where 1 teaspoon, and that's the whole thing about one pill. 1 teaspoon can be 4 times the toxic dose in any child, not even like 2 years old, 8 years old, and therefore there's a high mortality with that. So it's a big deal. So if you think about it, I mean, we presume that it's only in oil of wintergreen, but in fact, it's present in Bengay. A few things like icy hot, things we have around the house where the child might strip off and start to suck, and therefore they will absorb that salicylate. And also easy things like Tiger Balm, which we have hiding around, they'll just open it and then of course just suck it in, and then you have it where they have salicylate poisoning. In terms of when they come in with that, presume you're behind time. And the main thing is that you want to alkalinize that serum, that blood, and the urine. The main thing is that once you have the material itself, the salicylate, if it's ionized, it would not be able to pass the blood-brain barrier. And you're trying to have reduced CNS toxicity. So of course, you're going to have some failure with regards to the liver failure and the kidney failure. You will have some pulmonary edema, but in terms of trying to prevent that flow, the main thing is cutting off there. So you start right away with your bicarb infusion. Your goal is to have your urine pH 7.8 or even 8.0. And your goal is also to have your serum pH, or blood pH, above 7.5. So they will have metabolic acidosis and they will have respiratory alkalosis. The key thing is that the respiratory alkalosis is the body's attempt to try to make sure it ionizes that same salicylate so it doesn't cross the blood-brain barrier. So if you have to, try not to intubate them, but if you find that they've been deteriorating and you have to intubate, the key thing is to try to have the respiratory rate after intubation to be the same as it was before. So if they were having like 40 or 50, try to mimic that to have that similar respiratory alkalosis. What you find is that as doctors, because we don't necessarily do that and have that cognitive leap, then they often die soon after intubation because we don't provide enough respiratory alkalosis. Then you don't have that optimization of the ionization of the salicylate itself, and you have the salicylate crossing the blood-brain barrier, then having the seizures, the unconsciousness, and eventually death. So salicylate, really the biggest deal here in terms of the oil of wintergreen. I personally have had a good few of them who have died. And even if we've tried everything, sometimes it comes too late and you try all you can. And of course, the last thing to use is hemodialysis and lipid emulsion therapy. A lot of us mightn't have hemo available, but if you do have it and you can get it done right away, send them off to hemo, but of course stabilize them fairly. But the key thing is to talk to your family, let them know what's the families or your patients, let them know what these drugs have, and also have them come immediately as soon as possible. In addition, as soon as they come, you go aggressively with them in terms of optimization. The second thing is the calcium channel blockers and the beta blockers. So we have on nifedipine, verapamil, propranolols, and of course you get arrhythmias, you get severe hypertension. You can get hyperglycemia or hypoglycemia. And the key thing about these though, they're usually long acting. So instead of having it where after 4 hours, you might think that's your peak of activity, it might go on 12, 24 afterwards. So therefore the patient keeps deteriorating and deteriorating. And because it's long acting and it's also an overdose of one pill, they might peak like about a day or two. So in fact, it might not be. So imagine, if you will, that the sustained release is over 24 hours. But obviously, if it's an overdose, it might actually peak for that child at 48 hours, and then they might now start to settle down after about 3 or 4 days. So you have to continue observing and watching. And the key thing is that after 4 hours, they might not show any symptoms. So they bring them in. Don't presume, no, you didn't really absorb it. Just say, you know what, I will take a very low threshold to observe and see what's happening and preempt this. Going back a bit, actually, I forgot to mention one thing about the succinate. Also, because you're giving it bicarb, just remember to keep your potassium infusion going. Typically, because the bicarb is running through, they will be prone to having hypokalemia. And then, of course, you have another issue. So make sure you have instant bicarb infusion, checking your pHs every half an hour, both serum and urine, given your potassium, checking your glucose because they're also prone to hypoglycemia, and looking intensely for that CNS transfer when you're going to have CNS effects. And of course, as I said, pulmonary edema. So with regards to these, they might also cause some seizures. So you have to be really careful. Now, of course, the usual regime, you can use have your glucagon, but also have your hyperinsulinemia, well, insulin ingestion, and also your euglycemia approach to this. So you start your insulin at 1 unit per kg per just straight bolus, and then afterwards, well, you'll start with kids. With children, it's usually zero point 0.5 units per kg per hour, and you go up as much as you can. And at the same time, you're giving your glucose to make sure your glucose level is euglycemic. So hyperinsulin and euglycemic with regards to that. So even if you have to go 10%, 12.5% glucose, you try to go as high as possible and try to get a central line in. So you keep the child euglycemic and trying to maintain that whole aspect with the calcium channel blocker and also the beta blocker. Again, hemodialysis and lipid emulsion therapy do work if you have the capacity in your island or in your ED nearby. The main aspect of this is to look out that it will be long acting and it will last for a good time. And usually, as I said, you can start with your glucagon. Atropine hasn't been that effective. Usually, as we mentioned, hyperinsulin and euglycemia are the approaches to use. And of course, normal things we know very commonly. The third thing that I want us to remember, three big ones. So salicylate, we have our beta blockers / calcium channel, and of course our sulfonylureas. The thing about those is that they also allow for production and not the production, but at least release of insulin in peripheries, as we know. But the problem with the pediatric patient is that release of insulin is uncontrolled, and so they have a whole tumultuous overload of insulin release. In addition, their glucose stores are very minimal, so they have a higher metabolic rate per kg, and they use up all their glucose stores, much more insulin, and it continues for a while, and it's usually severe, intractable hypoglycemia. It's really hard to reverse. So in your mind, have your protocol set up, and you know that the treatment is diazoxide, you have your steroids, you have your glucagon also, but the mainstay is octreotide. Now, often in Trinidad, we may not have octreotide IV, so what we do is get a tablet or two, and we have it, we keep it in the ED just in case, and then of course you crush it up and you give it orally if you have to, if you have no other choice, but always have that available for these cases, because often if you have nothing else, that's the only that will really work, and you have to have some backup in these cases where the glucose is going down. The second thing to note is that you must have a central line in, because you can actually go even up to 15% glucose infusion if you have to. So the 12.5 could last peripherally. If you're going higher, you have to go to the larger central line. So I will go straight to the jugular, and I have some leverage in terms of going up as high as 15. So I don't have to have that vein be totally corrosive. And at least it gives me some buffer for the intractable hypoglycemia that will happen. And again, the same thing as the previous ones with the calcium channel blocker and the beta blocker. It might last for a day or two or three because you're not sure about that insulin being released because it's uncontrolled. And so you're never sure when it will settle down. And so these ones could last for a longer time. So with the salicylate, they get sick right away. Like after a few hours, that's it, and they deteriorate right away. But with these two, it's a more occult. They start off slowly and then they stay down for a long time. And you have to really be having a low threshold just in case. And it's the common ones we know about as available. Ordinary tablets that the grandmother or grandfather will come with and have available just one pill and has a high mortality. The other things to think about, but less common, but still dangerous. But again, I don't want you guys to leave with an entire list in your brain and think I have to know everything. I want you to remember the top three, but think about the antimalarials, the TCAs, and the antipsychotics. A little note there, a little plug for the antipsychotics. So we know that Haldol, for instance, can have a dystonic reaction. But note that Gravol, the ordinary Gravol that we take as adults, in children can cause the same dystonic reaction. So I usually recommend that do not give children Gravol because they have a similar effect in terms of these. But in terms of having the dangerousness, all these three are pretty dangerous, but less common. Now, everybody thinks, well, yes, medication, we have to know about medication. But in fact, aside from the normal medication that you have in your cabinet, there's some ordinary stuff that we have that we don't realize that that one pill is so dangerous. And Lomotil is highly dangerous. You know, we go liming or we go hanging somewhere, eat some good fish and have a beer and come home and have some diarrhea and say, okay, let's pop some Lomotil. And then, of course, we forget that if we have that available to the child by chance, we don't have it where we take care of it. That can cause severe coma, death, etc., even if it's half a tablet. Talking about Imodium, things we commonly use, that is very dangerous in the one pill lineup. And of course, methanol. This is found in mentholated spirits. The same thing we'll have in our cupboard to use for wounds, etc., which we should not use, but we'll have it there traditionally in our house, and we would forget that that can be easily drunk. And a bush rum. So I'm not sure. I was asking Dr. Johnson Williams about this, but I'm not sure we call bush rum in Jamaica, but in Trinidad we call it babash. So lots of persons go into the forest and they make their own bush rum, and of course it's not made properly, so you get some ethanol and methanol, and they bring it home to their families, and it's a liming thing where they're liming and thinking, well, I have my own brewed rum, and of course it has methanol, and they might share it with their younger child just to get them to be accustomed to alcohol, and then suddenly they have methanol toxicity. Of course, for this, it used to be where alcohol was the antidote, but of course it's now famipizole. But still, I mean, the real thing is really for hemodialysis and trying to get rid of the methanol because it's fairly dangerous. And this is one of the bushram setups. Again, you can see how old and crappy it is, and you know it's going to have a not pure effect of ethanol at all. Things like the antifreeze, things you might find in your garage, and available there, thinking that this is, I'm just going to keep it there, but just one swallow of that can be has a lot of ethylene glycol, and again, the treatment for this is mainly having hemodialysis, nothing else really, in terms of clearing this out of the system. Paraquat. Unfortunately, a lot of things we get in the Caribbean, they still allow it to be too concentrated. There isn't a large standard for these things. So for instance, the paraquat and the organophosphates usually come very highly concentrated. So the child will go and have it available. And these are things we use to spray for our as herbicides. but we then dilute it, but we keep the concentrated version in our available in our garage and outside. And if that child gets it, you would think that it will taste horrible. It does, but it tastes only afterwards. They swallow first and then they taste. And so afterwards, you'll have the same effect happening with some of the organ failure. So keep those things if unavailable, please, to your child. Camphor. Camphor is used traditionally. I know we put it in sometimes in our cupboard space. We keep it in our shoes, not so just nearby. And also, I think, I'm not sure Jamaica has a similar thing called a blue bag, where you put it, attach a blue bag onto the child or baby just to just get rid of spirits or bad spirits. And camphor, once that child gets one bowl of camphor, they suck it and they swallow it, then it can't be metabolized by the liver very well. In fact, the active metabolites are even more dangerous. And so once they do that, they get some jaundice, they get some liver failure. And this one is a little bit slower in terms of effects, but definitely it can cause mortality. So it's a very common thing we have at home. You really don't want to have it at home. And if you do, no, actually, I'll just say don't have it at home. We can maybe pray and get rid of the spirits and then have the camphor balls around. Eucalyptus oil, a very common thing we use for our humidifiers and for our vaporizers. And even when we're having some congestion, we'll put it over and we'll put our head over just to get that fume and clear up our nostrils. If you're having it, have it separate from. It's really dangerous. And it's again 1 teaspoon, 1 swig, 1 swallow, and pennyroyal oil, 1 swallow can cause massive organ failure with the child at that age. Now look at this one carefully and you'll realize that if you take a quick look, you would not know which ones are the sweets and which ones are not. Obviously, I've earmarked the ones that have this that are not sweets, but it just looks so pretty. It looks the same color. And this was probably one of the dumbest inventions we have in terms of having our wash machine detergent pods. We put a very concentrated liquid in a very small pod that can be easily gotten by any child. We made it hyper colored, very exciting, very pretty, and we didn't expect any complications. So of course, when this came out, we had a lot of child deaths because of this, because of course they'll put it in their mouth, bite into it, suck it down, and totally corrodes their GI into their stomach because it's highly concentrated. Now they've made it a little bit more child-proof, but still the older ones are out there, and the washing machine detergent pods, although convenient for the adult, are really, really highly toxic for the child. And things like you'll have the pods in a sort of like a bag at the bottom by the washing machine, easily for the child to go there and pop that into their mouth. The other thing to think about is marijuana gummies. Now, they do have some that's a CBD, but a fair amount of them are THC. Now, I suspect with COVID, we're having less of them from USA, but a lot of, if your friends come down, just note that one gummy bear, which looks like this is really pretty. I would want to have this if I was a child. And having this one gummy bear can cause bradycardia, tachycardia, and having some arrhythmias. Now, significantly, although they might not die from the arrhythmia, they might die from the hallucination. So what they'll do is that totally not good know what's happening because of course they're high and they might sort of like go by a stair area, go to a site that's really not safe, and then they'll have secondary injury, secondary to being high from the THC in the gummies. And the gummies are made for it to be more palatable for adults, but again, it's made such that the child will see this and just be able to ingest and go further with it. So look out, keep your marijuana gummies to yourself and not have it available for your child. Other things that are not so bad, thankfully, household bleach is not something we keep concentrated. So it's fairly diluted. And so the bleach itself, even if they have a swig of it, it will cause mild GI symptoms, but that's about it. So those persons, if you watch for 4 hours, you think they're okay, that's fine. Of course, I take it as a time to really tell parents and give them a really good telling off, but note that it's mild. But having the child have access to bleach is a little warning sign that the safety in the home is not that high. So I use it as a conduit to advise parents what to do and how to have safety mechanisms. But by itself, it doesn't really cause any major morbidity or mortality. Same for calamine lotion and same for silica, very mild in comparison to the others you've had. So what can you do? I mean, do you go for an antidote? Do you do CPR at home? Do you let them drink some water? Do you add some toothpaste? Do you have some MSS? How about some peppermint tea or some rub down with the same eucalyptus oil that they just swallowed, and or do some back blows and maybe a Heimlich to get rid of that pod or that marijuana gummy? What do you do? And the thing is that you do nothing. In terms of at home, the first aid thing is just nothing. Just bring the child as soon as possible to the ED and let them know what you think the child may have swallowed. The chance of death is 50%. That's 1 in 2. And the ones who actually survive, it's not because you didn't do anything. Those are the ones where the ED team were very super aggressive. They knew their protocols and jumped on that child as soon as possible. So if you miss the boat and you wait too long, you have a higher chance of mortality with these 1 pills and 1 swallows. Be aware now, our responsibility as medical students and also family medicine practitioners and ED specialists is to know what to do. So what I usually say is at least the 3 I've had in the beginning, have your protocols for that in the ED. So you'll know if that happens, it's right there. But for the others, because you can't keep everything in memory or in a protocol book, because there's so many of them, I would say use Talkspace. Talkspace is a UK based toxicology network. And although a lot of us have our toxicology phone-in centers or networks in our own country, Talkspace is really good. It covers everything. And you can have an institutional payment for it. But the best thing is that it costs $6.99 US dollars. You can get your app on your phone, and you can get the basic ones. And so I tell most of the house services, get your Talkspace app, and once the child comes in, even if you can't remember, it doesn't really matter. Put it in, and it'll give you the entire thing right there. You can actually forward to your email, print it out, attach to the file, so everybody knows what to do. Even if their child has to go to ICU or the ward, they have a whole list of what to do in terms of what's the procedure. So I highly recommend Talkspace or some other toxicology base for these things, because at 3 o'clock in the morning, you can't really depend on remembering all the protocols for everything. And you really want to at least jump on and be super aggressive, because the whole thing is that the horse has already left the stable. The car is already going downhill. So you've lost a lot of chance, and you really have to get back and be extra aggressive to lose all the ground, to get back some ground that you've already lost. Now, this isn't meant for us to learn of this slide, just an example of some of the antidotes. And sometimes if it's less than 1 hour, you can use some charcoal, activated charcoal. Calcium, of course, maybe remember it's cardioprotective. Flumazenil, according to what's given, so you can actually have the antidote there. Glucagon for some things that we mentioned already. Hyperinsulinemia, and also NAC, N-acetylcysteine, according to what's given. So you have your coverage there. Naloxone, octreotide. So try to have it where you have, I usually say, you know how you might have your difficult airway kit? Have a kit with your antidotes. If you can have all of them, have the list of them. And so have someone check all the time, maybe once a week. And so if it's expired or it's run out or you don't have it, at least you know every time I have my antidote kit right away, just to check for all these things. And also my protocol list of my top 3 or top 5 or whatever you want to have. But you know that just in case, you have everything there for the possible toxins might come through for that child. So what's the real solution? What's the real treatment? Prevention. Seriously, you really want to prevent the pill, prevent the swallow, prevent the teaspoon from happening, than to be trying to save them to be having a 50% mortality. And in addition, you can do this thing called some more prevention, and of course, with some added prevention. So I think for us, the same thing as as Dr. Dasgupta was going through, is really to have some public health communication. where once we have where they come in with maybe they swallow one tablet of paracetamol or something, use that conduit to advise them about safety in the home. So therefore, before the actual major one pill comes through, and you have to have that patient come through and not make it. There's no room for moderation with a single pill, no room for fussing, no room for flapping around at all. So children, sneaky, sneaky, sneaky. You wouldn't even know. They're on that ground. They're seeing stuff you wouldn't even see. And if it's hidden and it's being seen, it's even more enticing. You have to assume the worst and get on top of that case right away. In summary, no gummies, no bushram, no oil of anything. Even if you have your nose congested, just use some salt water or something else. You don't want to bring things in that you might in moving or forget and have it available for something to happen to a child. And just as for emergency medicine practitioners, it's our responsibility have our antidote kit and have our top three or top five in terms of protocols, and we have some toxicology base so we know what's all backup. I think this was the questions we had. So I'll go on now to Dr. Eiffel. I know that you were liaising with Dr. Guy and the other doctor to go through the online poll.
Yes, thank you, Dr. Paul. You're very on track, and definitely thank you for that talk. We appreciate it. I'm going to hand over to Dr. Thomas now, who will take us through your poll questions. Dr. Thomas, are you ready?
Yes, I am. Okay, so we have 3 poll questions. The first one, which answer does not explain why children are so vulnerable to one pill, one swallow? So the options are A, they're smaller size, B, slower metabolism, C, oral fixation, and D, delay in presentation. So the most common answer with 69% is their slower metabolism. Next in line, we have both delayed presentation as well as smaller size for 10% each, and then oral fixation.
That's good. Definitely the answer is slower, B. Everything else is a factor, and the slower is not the reason. It's not slower or faster, it's just immature. That's really good. And I'll go on to the next one.
Okay. So the next question, which medications are the most dangerous for one pill, one swallow? Our options are A, iron tablets, B, paracetamol overdose, C, ibuprofen overdose, and D, calcium channel blockers. So the most common answer with 80%, calcium channel blockers. Second in line, we have paracetamol with 14%, and then we have ibuprofen overdose at 5%.
That's very good, actually. The trick here was that although ibuprofen and paracetamol and iron are highly toxic things, they don't have the one pill. So you have to have a toxic dose. So you might have to take a few more ibuprofen or paracetamol or iron, but with the calcium channel, it's one pill or half a pill that causes the massive deterioration and multi-organ failure.
Okay, thank you. And our final question, which of the following causes severe mortality and is in the category of one pill, one swallow? Our options are A, household bleach, B, Imodium, C, silica, and D, calamine lotion. And our most common answer with 57%, that's Imodium. With 23%, we have household bleach, 12% silica, and 6% calamine lotion.
That's interesting. I actually thought this was the easiest question, but I thought I was going to get more. So interestingly, I think most of us think bleach is really major. It actually isn't. I mean, I'm not saying it's great. I'm just saying that Imodium here, which is B, it should have been like 90% because that's way ahead. Bleach is fairly mild because it's meant to be diluted. It's diluted already, so it doesn't really come concentrated unless you actively go and get concentrated bleach, but it's B Imodium. So, all right.
Thank you for that. Yes, 4 questions are finished. Thanks for their participation, guys.
Thank you.
Thank you, Dr. Thomas. And thank you again, Dr. Paul, for those pearls. I saw a comment in the chat from Ms. Karen Mulling says, excellent presentation, very timely with the children being home, bored and curious. So I agree 100%. Dr. Paul, we have a few questions in the chat and I know we want to get those answered. So we'll encourage you to just, if you can, just log on to the chat and address those questions there. Thank you so much, Paul.
Thank you.
Guys, before we go on to our last presenter, I just want to remind you that we are in our second session of our emergency medicine conference, and we have a couple of sponsors without whom this whole conference will not be possible, and they come at the near to the end. So after this next presenter, I hope that everyone is still online to give them some support and show them some love as well. Okay, so here we go. Our last presenter is none other than Dr. Peter Glegg. Dr. Peter Glegg is a medical doctor, being a senior resident in general surgery at the St. Anne's Bay Regional Hospital. He is an attorney at law and is the senior legal officer at the University Hospital of the West Indies. He is a lecturer at the Norman Manley Law School, and he puts here, he's a proud Taylor Hall alumni, and he's an avid farmer. This gentleman is not a stranger to the emergency medicine conferences. Please join me in welcoming Dr. Peter Glegg.
Hello, good afternoon. I'm trying to share my screen. Okay.
Go ahead.
Okay, excellent. Good afternoon, friends. Let me just share my screen. Thank you to this evening's organizers for having me. I hope you're able to all see my screen. Kindly confirm.
Yes, we can see your screen, Dr. Glegg.
Okay, good. So I want to talk to you a little bit this afternoon about the issues regarding the de-escalation of care, but more specifically from the legal perspective. In the courts and in several cases that I've actually done with this forum before, there are a couple of things that have long been established in the courts. One of them is the fact that the courts have long accepted the fact that in the emergency room, the pace at which things occur, the pace at which decisions are made is a very rapid one. And a lot of times when cases are brought before the courts, the A&E doctors do not have the benefit of an expert who will sit for a month and research the circumstances of a particular case to give an opinion in the court. And the courts is quite mindful of that issue. Now, there are times when a critically ill patient may arrive in the emergency room and the doctors will have to make a decision, and they may have to do so very quickly. You want to know, do you need to manage this patient aggressively? When do you withdraw or do you reduce care? And how high to set the management ceiling regarding the management of these patients. Now, you must remember that in the emergency room setting, though the decisions involve the patients, we have to take into consideration the fact that the family may also be a part of the process, interacting with the medical practitioner. Now, because the result of your decision may end up with a life being lost, meaning it may end up with someone dying, this creates certain legal as well as ethical issues. And therefore, the weight of the decision that is made in the process, we have to look at the fact as to whether it is a doctor-centered process, is it a patient family-centered process, or is it based on policy, or all of the above. So the fact that you're making a decision that may lead to the death of a patient, I think I have to set a certain fundamental groundwork to establish some of the things that you may face going forward. Okay, so in terms of negligence, most of the court cases that are brought against doctors and hospitals, medical practitioners, nurses, is under the issue of negligence. And this is something that I've always been preaching that negligence falls under an area of civil law known as the law of tort. And of course, we know that tort is a non-criminal wrong or a civil wrong for which the courts may impose some liability. Of course, in the context of the law of torts, when we talk about injury, it can be any legal right, whereas a harm may describe a loss or a detriment, in fact, that an individual may suffer. Now, in order to prove a successful case of negligence before a court, usually you have to satisfy 3 limbs, and all 3 of them have to be satisfied. The first one is that you owe a duty of care to the patient. Now, that we never ever argue about whenever there's an issue between different legal teams regarding negligence, because that is a given. The second one is that there has been some breach of this duty of care by the medical practitioner, whether by an omission or by a commission, meaning that you should have given heparin and you didn't, and the patient end up with a DVT or a pulmonary embolism and dies, or you gave the wrong drug and the patient was allergic to the drug and the patient dies. And the third one, of course, is that as a result of your omission or commission, some harm has come to the patient. So if you give the patient the wrong drug, the patient should have gotten Augmentin but got Rocephin instead, but the patient did not die, then you have not satisfied the third limb. Just to say, however, ladies and gentlemen, that you must remember that for the court, for you to win a negligence case in the court, it's based only on a balance of probability. So that what that means is that the bar is set relatively low as compared to a criminal trial where you may have to prove beyond the shadow of a doubt or beyond reasonable doubt. In this case, it's just on a balance of probability. So what this is saying is that it is not very difficult to be successful in a negligence case because the bar is set so low. And when you think about it, the bar is set so low because many times the court always look out for the interest of the man on the street. Now, we've long established this issue of the duty of care, which is the second limb. And I think all residents in training, house officers and intern need to read Donahue and Stevenson, which is the locus classicus that establishes the whole concept of what is considered to be a neighbor in the duty of care, and that the neighbor is supposed to prevent a foreseeable injury. And this brings into play the fact that many times when you look towards a negligence, the whole issue of foreseeability comes into play. Should you have foreseen that this action or omission would have led to the patient being harmed? Okay, now when we talk about the duty of care as it relates to professionals, especially medical professionals, then we talk about the standard of care. And the Bolam test, Dr. Williams and I from A&E always talk about the Bolam test. And the Bolam test essentially is the test that is going to weigh apples against apples. Because what the case of Bolam established was that you have to judge a case based upon the circumstances. So therefore, if something happened at Chapelton Hospital, no disrespect to Chapelton, you cannot compare Chapelton Hospital to, say, the University Hospital, because the circumstances are different, the resources that they have are different, and therefore the comparison is not equal. In the same way, you cannot make a comparison to how, say, a junior resident managed a case to how a consultant with 20 years experience as a consultant would manage a case. So the Bolam test is a great equalizer, essentially, when you're making a determination as to the standard of care when it regards to medical negligence. Okay, now, of course, the Jamaican courts have accepted and applied the Bolam test in many medical negligence cases. And one of the Jamaican courts have said whether the doctor is negligent in the treatment of the patient must be based on what is acceptable by the standard of such a skilled specialist exercising the specialist's ordinary skill, meaning that is not the specialist doing something that only he or she alone knows how to do, but the ordinary standard practice by the specialist. Okay, now, what do we do about the medical professional training? How does the BOLEM apply to, say, a resident in training, a junior resident or a senior resident? We have to take this into consideration as well, ladies and gentlemen, because you cannot judge a resident in training in terms of if he had to make or she had to make a sudden and a very quick decision as compared to an experienced consultant. We do hope and anticipate that sometimes the resident may have enough time to call the consultant and get an opinion before moving forward in managing a case, but this may not always be so. Right, so sometimes if the circumstances are very severe, you may hear people talk about criminal negligence. Now, criminal negligence is a more serious issue, because where regular medical negligence fell under the law of tort, which is a civil issue, if you are charged with criminal negligence, then the doctor faces the possibility of not only being fined, but going to prison as well. Now, we'll look at a recent ruling of the DPP on a local matter, and we see how the DPP approached the issue of criminal negligence. Suffice it to say that unlike civil negligence, because it is a criminal matter, the bar is usually set very high. So it is very, very difficult to convict a person or even charge a person for criminal negligence. You really would have to go out of your way to harm a patient for criminal negligence to come into play. But let's just look at what the DPP said. So the law on medical negligence has been judicially decided in the seminal case of the Queen against Bateman in 1925 and was aptly summarized by Lord Hewart as follows. If a person holds himself out as possessing special skill and knowledge, and he or she is consulted as possessing such skill and knowledge by or on behalf of a patient, he owes a duty to the patient to use due caution in undertaking the treatment. And of course, we could even apply this to civil negligence as well. If he accepts the responsibility and undertakes the treatment and the patient submits to his direction and treatment accordingly, he owes a duty to the patient to use diligence, care, knowledge, skill, and caution in administering the treatment. No contractual relation is necessary, nor is it necessary that the service be rendered for reward. So what that means, guys, is you may decide to help out a situation or help somebody, and you're not getting any pay for it, and something happens, you can still go into trouble. This also establishes the fact that when a patient given consent, it need not be in writing as a written contract, because remember that consent, like any other contract, can be oral, it can be verbal, it can be expressed, or it can also be implied. So it is for the judge to direct the jury what standard to apply. Here we go back to the standard of care, and for the jury to say whether that standard has been reached. The jury should not exact the highest or a very high standard, nor should they be content with a very low standard. The law requires a fair and reasonable standard of care and competence. On this basis, in my opinion, the ordinary principles of the law of negligence apply to ascertain whether or not the defendant has been in breach of a duty of care towards the victim who has died. If such breach of duty is established, the next question is whether that breach of duty caused the death of the victim. If so, the jury must go on to consider whether that breach of duty should be characterized as gross negligence and therefore as a crime. So what this is establishing is that criminal negligence is where there is gross negligence. And as of such, it has therefore now moved from the realm of criminal negligence, of a civil negligence, to a crime. And this will depend on the seriousness of the breach of duty committed by the defendant in all the circumstances in which the defendant was placed when it occurred. And what I'm happy for about this is that if you see in the last line, it takes into consideration the circumstances. And this is always something that has to be taken into consideration where we have a patient that dies. We have to look at the circumstances surrounding the case because no two cases are alike. Okay, now the jury will have to consider whether the extent to which the defendant's conduct departed from the proper standard of care incumbent upon him, involving, as it must have done, a risk to the death of the patient, was such that it should be judged criminal, that the negligence or incompetence of the accused went beyond a mere matter of compensation and showed such disregard for the life and safety of others as to amount to a crime against the state and conduct deserving of punishment. Okay, so in the same context as we're speaking about the fact that you are making a decision that may lead to a death of the patient, I think we also need to understand another definition of what do we say when you cause murder and what is murder. So this would be the most strongest one. So according to Archbold, where a person of sound memory and discretion unlawfully killeth any reasonable creature in being, and under the king's peace, I guess in this case, they would mean the queen's peace, with malice and a forethought, either expressed or implied, the death following within a year and a day. So within this, the elements of murder you can see is not only must you cause the death of a person, but it must be done with some forethought, it must be done with malice, and also if you cause injury to a patient and the patient dies within a year and a day after, then it may be considered murder. Of course, if the patient dies a year and 2 days later, then that, my friends, is a different scenario. Now, having gone through all of these, I want us to take a look at how the Jamaican courts and the United Kingdom courts, to which is our highest appellate body, have dealt with circumstances in which issues were brought before the court dealing with when doctors had to make a decision that impacted upon the life of a patient. Because the reality is, ladies and gentlemen, when we decide to de-escalate care, the fact is that many times what is going to ultimately happen is that the patient may die or some similar outcome. Okay, now I'm going to give you a scenario that I personally faced recently and use this as the launching pad to go into the whole legal understanding of this scenario. So some time ago, I was faced with a pediatric patient who was on a ventilator. The patient had minimal brain function. The parents and the family, who were well-educated people and well-thinking people, realized the futility of the situation, and they realized that this baby would never, ever, ever, ever fully recover or lead a normal life in the future. They approached the medical team to ask that the baby be removed from the ventilator. As usual, my advice was sought, and immediately, understanding the three definitions that I gave you above to protect myself, at my age, I should be coming out of prison and not going to prison. I sought advice from the Office of the Children's Advocate, as well as from the Office of the Director of Public Prosecutions, to give me advice and some sort of support in making the decision regarding this case. Now, what I found quite interesting is that the learned Queen's Counsel from the DPP, who is also a Taylor Hall man, referred me to the following case that I'm going to discuss, and quite interestingly, avoided making a ruling because as far as he was concerned, we had not done anything yet. So they cannot make a ruling preemptively since no action was taken. And of course, they bluntly refused to grant any blanket immunity. In this case, however, while we were preparing to bring the matter before the court, and we were actually putting our case together to approach a judge for an urgent hearing, the child demised naturally. But I will still go on to say that this case was one of the cases that the DPP referred to me as a case that I should study, which is a case I was actually quite familiar with. And I want, especially the residents in training, just to take a picture of this title, because it's a case that I think you should read from beginning to end as a guidance. So what we're going to do essentially is an analysis of this case. And this case is called an NHS Trust and Others Against Y. And this is a recent case, it's 2018. So it's a very, very, very recent case. So the facts of the case is that patient Y suffered a cardiac arrest, which resulted in severe cerebral hypoxia and extensive brain damage. And I'm sure all A&E persons have seen sufficient cases of patients coming in with MI who are now unconscious and unable to speak for themselves and have had significant damage, and a decision had to be made as to what to do. Are we going to de-escalate and allow the patient to go peacefully? And I'm sure many times you've been faced with this critical decision. In this case, the patient never regained consciousness and required clinically assisted nutrition and hydration in order to keep him alive. So 4 months after this cardiac arrest, the physician concluded that he was suffering from prolonged disorder of consciousness, and that even if he were to regain consciousness, he would have profound cognitive and physical disability, remaining dependent on others to care for him for the rest of his life. So the family believed that he would not have wanted to be kept alive, given the doctor's view of his prognosis. So the family's perception was based upon the explanation of the case that was given to them by the doctor. And this is very important to note, ladies and gentlemen. So the clinical team and the family agreed that it would be in the patient's best interest for care to be withdrawn, which essentially would result in his death within days to weeks. Of course, the NHS, like I did, when you are faced with these situations and when you're faced with the life of a patient, you usually want the support of the court before you make a decision like this. And I say this to say, guys, that sometimes when you're making life and death decision, just remember that it should not be left to you alone, because there may be repercussions a year later, years later. So you should always seek advice, and we'll talk about that a little later on. So therefore, the NHS Trust brought it for a declaration to the court whether or not it was mandatory for such decisions be brought to the court. And therefore, the court came down, and what the court said essentially is that when you look at issues of this nature, you must have a recognition of the value of must be held. The court says no life is to be relinquished easily. The authorities are all agreed that the starting point is a strong presumption that it is in a person's best interest to stay alive. And many times you may be faced with a dilemma whereby one family member is saying, oh, you know, he never ever wanted to be on a ventilator. He never ever wanted to be strung up with any tubes. And the other family member is saying, no, he loved life and he always wanted to live no matter what. Money is not a problem. And you're now faced with that dilemma, right? So the starting point, the court said, is that the starting point of this, any determination, is the respect for life. But yet the court continued to say there may come a time when life has to be relinquished because that is in the best interest of the patient. And ultimately, in most decisions like this, the court will always instruct itself to say, what is in the best interest of the patient. It's not what's in the best interest of the doctor or the hospital, or what's in best interest of the wife or the ex-wife of the children. Many times the court will instruct itself as to what is in the best interest of the patient. So in this case, they refer to an older case from 1993, which is called Bland. And where Bland, it established that, listen, the question, before we get to the question of law, there lies certain moral, ethical, medical, and practical issues that are of fundamental importance to society. So you have moral issues, guys. You have ethical issues. The medical issues involve the decision of the doctors. The practical issues, say for instance, the patient is needed to have a certain drug that will keep him alive, and that drug is low, or we don't have any of those drugs. So there are a lot of things that go into making the final decision. And therefore, what the court is saying is that all of these things will be weighted or weighed in the balance whenever the court is going to make a decision: moral, ethical, medical, practical, and the whole importance to society as well. Now, back to NHS trust against why. So what the court said is that the process is a subject of proper professional guidance. And here they're talking about medical professional guidance, covering vitally important matters, such as the involvement in the decision-making process of a doctor with specialist knowledge of prolonged disorders of consciousness, and the obtaining, and you see me highlight here, a second opinion from a senior independent clinician with no prior involvement in the patient's care. I guess in our circumstance, whenever I'm consulted by my team about issues of this nature, I always say to them, listen, can we get a doctor from another firm, a consultant, an expert from another firm? So say you have 3 firms that manage the patient. Let us get the opinion of a doctor who works on another firm, because many times, guys, the reality is when you get involved in the management of a patient, you've been dealing with the family. Sometimes you may know the patient, you may grow close to the patient, your emotions may get involved, and this may cloud your decision making. So what the court is saying is that to remove this doubt, it's always good to get a fresh mind, a doctor who is not involved in this case, to looking at the matter, to help you and to guide you into coming to some consensus in making this decision. So the court goes on to say that the clinician who provides the second opinion must, so far as reasonably practical in the circumstances of the case, be external to the organization. We may not have that. And of course, guys, there's nothing wrong, and I've seen consultants of mine in the past do it, where they may call a consultant from another hospital on a matter to say, hey, what do you think about this? Nobody knows everything. And even if you're a big top consultant for 30 years, it's always good to bounce something off a consultant from a different hospital regarding patient management. And is expected to carry out his or her own examination of the patient and consider and evaluate the medical records, review information about the patient's best interests, and make his or her own judgment as to whether the decision to withdraw or not to start is in the best interest of the patient. Now, in this context, the court is speaking to a long-term patient who's going to be on a ventilator for weeks. Now, in the emergency room setting, we can transpose this to the emergency room setting to say there's nothing wrong to calling a consultant from another firm, or if A&E is just one firm, call another consultant who's not on duty that night. Nothing wrong with calling a consultant from another hospital. And I'm going to get to that a little later on. Thus, the interests of patients and their families are safeguarded as far as possible against errors in diagnosis and evaluation, premature decisions, and local variations in practice. If at the end of the medical process, it is apparent that the way forward is only balance, or there is a difference of medical opinion or a lack of agreement to a proposed course of action from those with an interest in the patient's welfare, a court application can and should be made. So essentially, what I'm gleaning from this case is that the court is saying, hey, the medical practitioners can, among themselves, if they get the best opinion available, an expert opinion, an independent opinion, they can, along with the family, make a decision whether or not they are going to escalate or de-escalate care. But what the court is saying, where the decision is not clear and where there may be a difference of opinion. So you may call one of your colleagues and your colleague said, Doc, boy, I've had 3 cases like this where the patient came around. Why don't you try that? Because, there's a 10% chance that the patient may survive if you ventilate him for a week. And, you still are insisting that no, it's futile. Then if it's a case like this, guys, where the scientists do not have an agreement, then what the court is saying is that let the court make that decision to protect yourself. Now, after that 2018 case, there was an even more recent case, which is the University Hospital, Bristol NHS Foundation Trust against ED. So this case actually occurred during the COVID-19 pandemic. And I like this case because this case is a more contemporary case in the circumstances and conditions under which we are currently working right now. And it had to deal with the same issue. And what the court said in this case is that all reasonable steps, right, which are in the person's best interests, should be taken to prolong their life. That's the first thing. So you do everything to save and prolong a life. That is possible. Everything that is reasonable. So all reasonable steps. There will be a limited number of cases where treatment is futile, overly burdensome to the patient, or where there is no prospect of recovery, as you may see in a patient who comes in with a massive MI or a massive stroke, and you realize that there is futility in this case, and you realize that there's no way that this patient can recover from the injury that whether his brain or heart or organs have sustained. In circumstances such as these, best interest, here it goes once more talking about the best interest of the patient. It may be that an assessment of best interest leads to the conclusion that it would be in the best interest of the patient to withdraw or withhold life-sustaining treatment, even if this may result in the person's death. Before deciding to withdraw or withhold life-sustaining treatment, the decision maker must consider the range of treatment options available. And I want you to highlight this because this was brought out in a case that I'm going to look at towards the end of my presentation, right? The range of treatment options available. I want you to remember this, to work out what would be in the person's best interest. And the fact that the court speaks about a checklist, what the court is trying to say is that when you look to the patient's best interest, this should be something that should be methodically considered by the doctor. And when they speak, the fact that they speak about even a checklist, what I'm seeing from this is that you should even document your thought process as to how you arrive at this decision, okay? The fact that they talk about a checklist, right? And in particular, the decision maker should consider any statements the person has previously made about their wishes and feelings about life-sustaining treatment. And this is where you talk about things like living will and DNRs, or maybe the young wife might come and say, oh, he said he never ever wanted to be on strings, he never ever wants to be in an ICU, but then another family member come and say something else. In a case like that, ladies and gentlemen, and in other cases that I've studied, the reality is you as a doctor have a duty to investigate. And the cases say that clearly, investigate. Pick up the phone, call several other family members, even if they're abroad, right? Talk to the pastor, call his best friend or her best friend, because many times there may be differences within the family. Hear what his best friend have to say. Many times the best friend will tell you the truth in terms of what the person really thought. And you have to take all of these into consideration when you're making the decision. Yes, the reality is in the emergency room, sometimes the decision has to be a rapid one. But the courts still say that within reason and to the best of your ability, you should really investigate before you make a decision. Talk to So in considering the best interests, and if you notice they keep on talking about best interest,
Okay, we seem to have lost Dr. Leg for a few minutes. For a while there, let me just touch base with him to see what the issue is. Just give us a couple seconds.
okay, I think I may have lost my connection a while ago. I feel, can you hear me?
Yes, you're back now, Dr. Gregg. Proceed.
I'm not quite sure what's going on down here in Ocho Rios. All right. Okay, so if you notice, the court is focusing on the issue of the best interest of the patient. And the court says, in considering the best interest of a particular patient at this particular time, decision makers must look at her welfare in the widest sense, not just medical. So you can't just look at the medical issues, but the social and the psychological. They must consider the nature of the medical treatment in question, what it involves, and its prospects of success, which is where the doctors come in.
Sorry to cut you, Dr. Glegg. Can you just share your PowerPoint one more time? We're not seeing it.
Okay, I am so sorry. Let me all right. All right. Can you see it now?
Yes. Just go into present the view and then you can resume. Thank you.
So sorry about that, guys. Okay, so what the court is saying is that so in considering the best interest, right? We don't just look at the medical issues, but the social and psychological issues. The doctors must.
Sorry, Dr. Gregg, can you put it in view?
Okay, better?
Here we go. Thank you.
All right. Oh, is that Jason?
That's perfect. That's perfect.
Okay, thanks. Okay, so you must consider the nature of the medical treatment in question, what it involves, and its prospects of success. They must consider what the outcome of that treatment for the patient is likely to be. Now, I found this very interesting. They must try and put themselves in the place of the individual patient. So you must ask yourself, if I were the patient, what would I want to be done? All right? And ask what her attitude to the treatment is or what it would likely to be. And of course, they must consider consult with others who are looking after her or interested in her welfare. Here we're now talking about the family members. So, ladies and gentlemen, the British Medical Journal, an article by Natasha Crampling, essentially she breaks down the escalation decisions where there's an acute deterioration into 4 possible trajectories. And this is usually, I suspect, the decision that the A&E doctors have to make. 1, do you just de-escalate early because of a catastrophic event and you just see the patient coming in gasping, no pulse, no nothing, and you realize that, okay, there's nothing we can do? Do you continue treatment with a curative intent? Do you give treatment with a curative intent until there comes a significant point in which you decide, okay, we have to de-escalate here? Or do you, from early in the procedure, set ceiling limits and determine that, hey, we're not going past this. If the patient has to be intubated, we're not going to ventilate this patient. We're going to try, but if ventilation is required, we don't think we should ventilate this patient because it is not a salvageable case. And sometimes we have to make decisions like this. And for us, we may think, oh, well, it's just a factual medical decision, but we have to think of the repercussions of this decision, because when a patient dies, it impacts the family, it impacts the community, sometimes it impacts the community and maybe even the greater world at large, okay, because it may be a VIP. Okay. Now, the Medical Protection Society in 2018, they acknowledged the ruling of the court cases, which basically had to do with the 2 cases that I previously discussed. The fact that, okay, legal permission is no longer required, but they still stated that when treating a patient who has reached the end of life, clear communication and collective decision-making are important. When a complaint might come in related to the end of life care, all right, you can, and this is so true, guys, you can often look back and see that the family had a very bad journey from the outset. They felt that no one communicated with them properly, and this is so true. I've seen so many times that families have come to me in cases both here and abroad, and when you dig deep into the case, you find that they felt that they were disrespected. You find that they felt that their opinion wasn't valued. You find that the doctors spoke down to them, never gave them any consideration. The doctors were not nice. And, I stole a phrase from Dr. Bruce when he said that people never sue doctors that they like. There have been cases that I know of in many institutions where there may have been a serious breach in the duty of care, and the relatives would come in and talk and say, we just want to know what's going on. We just want an understanding. We don't plan to take this to court. We think the doctors were good to us, and we just hope that you guys find the gap, fill it, and something like this doesn't happen again, right? Because the reality is how you deal with the patients and their families, and it is so important. Many times when patients go to the media and go before the courts, it is because, as Jamaica people say, you deal with them strong. Families, of course, may sometimes have unrealistic expectations of what can be achieved, and we've seen that so many times. I'm sure many of you have encountered that, where you realize that the pupils are fixed and dilated, and the patient is gone, and the family is saying, no, give him a chance. I saw a movie on Lifetime 5 years ago where a man was in a coma for 10 years and he woke up back speaking a different language. Give him a chance, right? And sometimes when you explain to the family and you think they're not hearing you. They're grieving. And this may be a way of their coping. They're blocking out. So it's important to be aware of this and to repeat the information and to ensure that the patients understand what you are saying to them. So from when I look at these court cases, when I look at all the definitions of negligence, of criminal negligence, and all of these things, I think everything boils down to a few key points, ladies and gentlemen. One, the fact that de-escalation of care may lead to the ultimate outcome which is the death of the patient. And therefore, firstly, as you saw, made reference to in the case, you must have a clear diagnosis. Your diagnosis must be clear. And if you don't understand, call your consultant, call the head of department. Make sure that you have all the results. Every test have been done to confirm what your diagnosis is before you say it is X, Y, or Z. First thing, you need to have a clear diagnosis. Secondly, especially for our juniors, you need to pass the responsibility to the most senior members of the team. Don't be a cowboy, don't be a maverick, right? Pass the responsibility up. Pass the responsibility up to someone who is more knowledgeable and more senior than you. I have seen cases where experienced consultants, eminent consultants, will see something that he or she has never encountered before, because nobody knows every single thing. And I've seen them take the phone up and call another colleague and say, hey, you know, I have this case before me. What do you think? Have you ever seen it before? Okay. And you'd be surprised. The other consultant may say, no, I've never seen it. Or they may say, yes, I've seen it twice or once. And this is what I did. And this was what the outcome. Always pass the decision up, guys. Don't leave any decision to yourself. If you leave the decision to yourself and exclude your senior in law, we call it going on a frolic of your own. It means that you are on your own. Of course, consultants, heads of departments, you must remember the concept of vicarious liability, and you must insist that your juniors inform you of everything that a serious case, because you will still, or you may still, be held vicariously liable for their actions, even though they went against the accepted protocol and they did not inform you of the case. So I've known of cases where something happened years later, and the consultant is called to court, and the consultant say, I don't know nothing of this. And when you look in the docket, the consultant wasn't called, but guess what? On the roster, that consultant's name was the name of the person in charge. That person has to answer. So therefore, in two directions also, seniors, you need to ensure that you hammer it in the heads of your juniors that they keep you in the loop, especially when they face difficult decisions. And my approach has always been, hey, everything I tell my boss about, I'm not leaving any decision on my own. All right? Of course, if the case is sensitive, political, or controversial, nothing wrong with consulting with an expert from another firm or another team. Nothing is wrong with that, guys. Okay? And of course, what is important is detailed documentation. If you notice in the judgment, what the judge said in the case is the judge spoke about a checklist. Detailed documentation is important, because remember, when a matter goes before the court, what we are going to rely on is what was documented, what is in the patient notes, what is in the docket. That is very, very important. Dates, times. You need to document the information that you gave to the patient. Document if the patient asks you a question, document the question. Document the answer that you gave to a patient. Because just as how we talk about informed consent, in the same way when you're making these decisions, the family must know and understand everything that you are explaining to them, because a lot of times they go before the court, guys, they go before the judge, and you know what they tell the judge? Oh, they didn't understand. Doctor never explained to them. They didn't know that, you know, this decision was so serious. They didn't know. Okay? And let me tell you something. In the absence of documentation, if it boils down to a he say, she say, the court will always be liable to listen to the version of the regular man, because the court is gonna say, listen, you as a professional should know better. You should have reduced it to writing. Documentation, documentation, documentation. It will save you or it may break you. All right. Now you need to explain in terms that the patient or the patient's family members understand. So don't go to the patient wife and say, well, I think he has myocardial infarction with an associated supraventricular tachycardia and a Wernicke type 2 block. And therefore, as a result of this, we think that, I mean, so many of us can remember cases where doctors have explained something to a patient, and when the doctor walk away, the patient turn to the nurse or to somebody else and say, "When just say?" You need to explain your decision. You need to explain the circumstance in a language that the patient understands, and try and confirm this by having the patient say back to you here at St. Anne's Bay Hospital, and I think I can call her name, the head of surgery, SMO at St. Anne's Bay, Dr. Hamilton. She always draw diagrams. So when you look at her consent form or look in the docket, she should draw 5, 6 diagrams. She should draw the whole biliary tree. And Dr. Eiffel, you hear me?
Yeah, you're coming in and out.
I lost connection again.
I can hear you now. You may have to. Can you hear us, Dr. Glegg? Okay. All right. Sincere apologies again for the technical glitches, guys.
Can you hear me?
Yes, we can hear you.
Okay. All right. Good. I'll say that my boss would actually draw diagrams. And you look in the docket and you see diagrams of the biliary tree and you know, diagrams. And I think this is her attempt, and quite rightfully so, that she used whatever means that she can to explain to the patient, to show to the patient. And by doing that also, she's creating a record of the fact that she has explained to the patient. All right? Of course, you have to select a comfortable environment. You have to speak to the patient in a calm tone and in a non-pressured way. Explain to the patient the decision and why you're making the decision. And where I learned this lesson quite interestingly is about 2 years ago, I went to Barcelona to do a course on organ transplant. And they actually had a whole module on how to talk to patients, and they talk about selecting the right room. The room must be comfortable. They talk about the lighting in the room, not too bright, not too dim. They talk about the color of the room. They talk about even the tone that you use to speak to the patient. And I never even thought about all these things before, but maybe this is where we'll have to go, guys. That when we're explaining these serious things, don't just draw the patient one side in a noisy emergency room and just rattle out everything and then leave the patient and say, sign this, right? Bring the patient somewhere so that they don't feel pressured in making a decision. I always try to say, involve other family members and our stakeholders. Try to get other persons involved in the discussion, you know. Get a brother, get a sister, get the best friend, get a parent, get a sibling, you know, get the pastor involved. The more witnesses you have to a process, the more covered you are. Document all the persons who are part of this discussion. And remember, guys, never leave out the nursing team as a part of this process. They are an important part, and I'll talk about that a little later on. Don't leave out the nurses. Okay, and if it even means, I know some people don't like to talk on telephone and so on, but in an urgent situation, what the court says is as best as you reasonably can. So if you're talking to the patient's wife, but maybe the child is in the States or the mother is in the States, I see no problem why you can't do a WhatsApp video call or something. Get as much people involved in the process. The last thing you want is a he say, she say thing. And also, I would also say, get other practitioners present. So if you're the consultant, try and get the senior resident beside you. Get another doctor or two, so that you will document all the persons who were present when you did this discussion. Now you want to discuss all possible options, even if it's not offered at the hospital in question. And this is a very famous case that involved the Spanish Town Hospital, which is Chambers Octavia, against the Southeast Regional Health Authority. I can't remember, I think it's a 2012 case, maybe 2014. I think it's a 2012 case. And this was a case where a lady came in with a septic abortion. The doctors got consent. I think even the senior resident or the consultant came and explained to the patient. And you know that in the case, the patient told the court that she don't remember talking to the consultant, because what had happened is, though the consultant, I think, may have had discussions with the patient, the consultant had not outlined the details of the discussion in the docket. You have to be careful, ladies and gentlemen. Remember that patients and/or their attorneys may skew the story to put the case in their interest. You have to be cautious, and this is where documenting every discussion, every conversation, all who are present. So if you discuss a case on a ward round, write down in the docket who was present, nurse, doctor, physiotherapist. Document everybody's name who was present, because this may save you. Now, in this case, what is also important is that, do you know what this case boiled down to? Two things. The judge in this case said that, boy, the consent was not proper, because though they have consent and it was a signed consent, it was not informed consent, because the patient, the doctor had not explained to the patient in a way that the patient understood or in detail. And the second thing that this case boiled down to, and was the fact that the doctors had not told the patient, here's a patient who comes with a septic abortion who you're trying to get into OT as quickly as possible. The doctors had not told the patient about another option, which is, I think is called a vacuum extraction, which, by the way, at that time was the only other hospital that was available was the University Hospital of the West Indies. So here you are at Spanish Town, patient comes in sick, septic abortion, really sick, you're trying to help the patient. And I think what happened in the case is that the patient couldn't stop bleeding. They eventually had to do a hysterectomy. When they went in, a whole part of the uterus was necrotic, and therefore they ended up having to do a hysterectomy because the patient was bleeding out, and they did the hysterectomy to save the patient's life. To save the patient's life. I can just imagine how those doctors feel, because you went and did everything to save the patient's life. And what it boils down to is that when you are getting the consent, you did not mention to the patient that there's another option available of a vacuum extraction. Now, the reality is, by the appearance of that uterus, whichever method you use, that uterus was already damaged. But it's important to note. So therefore, if you're at Spalding's Hospital, or you're at Alexandria or Anato Bay Hospital, and you're getting consent for a patient, what the court is saying is that you should say to the patient, listen, these are the 10 different ways that this thing can be managed. You should explain all possible options to the patient. Let the patient choose to say, okay, well, doc, I like how the vacuum thing sound. See if you can get me into UC. That's what the court is saying, right? Of course, if and when patients ask for second opinions, guys, or the family asks for a second opinion, don't block it, facilitate it. Do everything in your power to get the second opinion, all right? Let it never be said that the patients did not get a chance to explore another option. Always remember this case, and I advise every single doctor in Jamaica to Google. It's on the internet, you can read it. It's public property. Chambers Octavia against the Southeast Regional Health Authority. Take a picture of the screen, and I think every doctor in Jamaica should read this case. Now, the other thing is, when you're getting consent and certain documents being signed, guys, do not leave it to the juniors to sign it. This comes back down to informed consent, especially if the matter is complicated. In fact, my thing is, the person who's doing a procedure is the person who should get the consent, or someone of equal knowledge or training. So therefore, you cannot be doing a Whipple's procedure, or you cannot be doing an angioplasty or some procedure like this and ask the intern to gain consent, right? Because the reality is that the intern may not be able to answer every single question that the patient may ask. And this may boil down to the fact that you may not have given proper consent. This is one of the things that I'm pushing. I'd love to hear from those who agree or those who disagree. But I really think if it's an incision and drainage of an abscess that everybody can do, fine. But if and where it's a complicated, difficult, possibly political, sensitive issue, somebody senior should gain the consent. And of course, as the court say, we need to display empathy. There are times we as doctors, you get so used to patients dying. You've seen 5 MI a week, it's like whatever. But to every individual family, that family member is your heart and soul. And the court said that. What the court said was the doctor should put him or herself in the place of the patient. You need to display empathy. And of course, at the first sign of trouble, pass it up immediately. Head of department, SMO, call your legal officer. If you work at a government hospital, your legal people is usually there is in the office of the attorney general. Every hospital has an attorney that is assigned to that hospital. Talk to your lawyer, okay? Don't leave this on yourself, especially where you know this is something that can boil down. And many times we as doctors by now, we know the crisis case them. We know the crisis patient. We know the crisis relatives. And once you see them guys, start documenting. Start documenting. All right? And finally.
Can you, in a couple minutes? Thank you so much.
Okay, I'm pretty much done. Get the nurses involved in the process, guys. Get the nurses involved. So I want you to design a de-escalation pamphlet and form in your department. Have a well thought out de-escalation protocol or algorithm. And of course, what we need to do is to get the Ministry of Health to ratify protocols and encourage Parliament to pass legislation in these regards. And this is the end of my submission.
Always rich, always packed full of knowledge. And this is so, I know we have so much comments in the chat, but we're pressed for time. And we really would like, if you could address some of those questions on the YouTube chat for us. We really appreciate that. Thank you, Dr. Glegg. What an empowering presentation. Thank you, sir.
Thank you.
Okay, ladies and gentlemen, we have now reached coming to the end of our JEMA conference. And before we leave, we always want to acknowledge our sponsors, and we want to set aside some special time for them. So the first sponsor is a household name by now, AstraZeneca. And representing this group is Miss Danielle Tate. Now, Ms. Tate is the Northern Caribbean representative for AstraZeneca's gastrointestinal and respiratory portfolio, including such products such as Symbicort, Pulmicort, and Nexium. AstraZeneca is a research-based, science-led biopharmaceutical company focused on delivering life-changing medicines in the area of oncology, cardiovascular, renal, metabolism, respiratory, immunology, among others. Danielle has been with AstraZeneca now for 7 years, and she supports the company's efforts in Jamaica, Bahamas, Bermuda, and Cayman Islands. Lastly, AstraZeneca has partnered with the Global Airways and Allergy Patient Initiative to bring preventable asthma exacerbations and deaths to zero. With that said, I'm going to hand over the floor now to Ms. Danielle Tate.
Is Danielle Tate, and I'm grateful for the opportunity today to share with you, and firstly to thank you for all that you're doing to keep us and our families safe. Words are not enough, but we hope you do know that we care and will do our part to follow the protocols and otherwise support you in any way we can. I know from firsthand experience how harrowing it is to watch a loved one suffer and fight to breathe when having an asthma attack. Unfortunately, I also know how hard it is to get those same persons to understand that asthma is not just about symptom control, but there's an underlying danger with unchecked inflammation. Especially during the pandemic, while we're happy to hear that there are less patients going to the private office for nebulizations, perhaps due to less exposure to triggers with mask wearing and distancing, We also know that there is reduced compliance with maintenance or control of medication, which is so important in reducing inflammation so as to prevent or reduce the severity of asthma attacks. So today, while I have the time to share a message with you, I would like to share what we are doing here in the Caribbean, but also globally, to over time reduce the need for persons to go to the emergency room or to be hospitalized due to preventable asthma attacks. And this is through an educational program that emphasizes proper management of asthma through our partnership with the Global Airways and Allergy Patient Program. This is an educational program that targets both patients as well as healthcare professionals and focuses on the risk of over-reliance on SABA or short-acting beta agonists.
People just see the blue inhaler and think, oh, just take that and it's fine.
Tomorrow was 9 months old when she had her first asthma.
People don't realize how serious asthma can be.
It took 10 years until we found the right treatment for Reese and Riley.
There's a lot of
whether it's ragweed, pollen, dust, that's very hard to pinpoint.
It's a lot of
not being able to predict when you're going to have an attack, it's terrifying. It's sort of like having a boa constrictor wrapped around your lungs and it's squeezing and pressuring.
I had to take time off work to take care of them and watch them hour by hour.
A lot of people think that asthma is a mild disease. It doesn't cause any serious problems, and certainly that it can't kill you.
So many misconceptions about asthma.
People don't understand how bad the symptoms can be and how much patients suffer.
You go to the doctors, if you're bad with it, you have your steroids, and you're fine, and that's what you think asthma is about.
Somebody who is prescribed more than one reliever inhaler a month is at risk of dying from their asthma.
SABA is definitely important, but it is no magic cure. It is not a silver bullet.
Even other asthmatics who I know think it's okay to be reliant on your SABAs.
Tomorrow, do you hear the bill in hospital? 47 admissions. Nothing was flagged up about it at all.
The twins had over 25 overnight hospitalizations. They didn't always have treatment reviews after being hospitalized.
They will treat the attack, but not the condition.
I felt lost in the healthcare system.
Tomorrow was our nana's. She was struggling. Me and one of the paramedics put her in the chair. By this time, she was fighting to get the mask off. And then she lost consciousness and never woke up.
Beware the tale of Tiffany Taylor, a lady too attached to her blue reliever inhaler. She'd cycle through life, blue inhaler in purse, puffing away this comfort, her curse. She didn't know, but she used it too much. What was meant as relief became habitual crutch. 3 times or more in a single week could foretell a story quite bleak. Poor Tiffany wound up in a terrible spin, treating her symptoms, not the disease within. Her habitual puffing papered over the cracks. She was actually at increased risk of asthma attacks. If you have asthma, consider your blue. Rely on it too much, and this could be you.
So those are two of many videos and other resources that are being used to educate patients. For the Caribbean, healthcare professionals can use the Reliance test at www.rateyourreliance.com.tt to assess their patients' reliance on their short-acting beta agonists. Another useful resource is the GINA assessment of symptom control, which asks patients, among other things, how often they're using their reliever medication. More than 3 times per week is associated with increased risk of asthma attacks. Using 3 or more relievers per year is associated with increased risk of severe exacerbations leading to hospitalization. And needing 1 reliever a month, or 12, so that's 12 per year, is associated with asthma-related death, or an increased risk of asthma-related death. The key here, however, is the fact that GINA recognized that these patients are not using controller medication, and so the underlying disease is not being addressed. That's why in 2019, they updated their guidelines to recommend the use of low-dose inhaled corticosteroid, not just for maintenance, but also whenever reliever medication is used. Now, having patients use a 2-in-1 inhaler, so both reliever and maintenance, that's the simplest way to ensure that they not just get the quick relief they need if they have a sudden onset of symptoms, but that they also get the essential anti-inflammatory protection of a low-dose inhaled corticosteroid. So that way we know that patients are protected on a continuous basis, right? Now, Symbicort has budesonide. That's the same Pulmicort that's considered safe for pregnant women and children. And it also has the fast-acting formoterol. So that works within 1 to 3 minutes, as fast as salbutamol, but longer lasting because it lasts up to 12 hours. Now, together, budesonide, which also has a rapid onset, so within 6 minutes, and formoterol both help to get patients symptom control fast, while being the only inhaler that's indicated to be used as a reliever to get both the anti-inflammatory impact and the fast-acting relief. So patients only need 1 inhaler, both for maintenance and relief. And they never have to worry about buying 2 inhalers or 2 devices, learning how to use multiple devices, remembering which one to take when, which one can be taken on the road, or if there are any complex storage requirements. We have both a pressurized inhaler for Symbicort, PMDI, which is used with a spacer and mostly used by the kids. But we also have the Symbicort Turbihaler, which is easy to use and it does not require a spacer. Simply remove the cap, turn fully in one direction, and then turn in the opposite direction. The patient will hear a click, which indicates that the dose has been loaded. As with other inhalers, they can exhale before taking 1 long inhale to receive the medication and hold. So again, twist, click, inhale. It's simple. Symbicort is on tender, and it's available for free for patients at all government facilities once physicians prescribe it. Pulmicort is also on tender and available for both in-facility and home nebulizations. We know that is restricted a little bit in facility, but home nebulization is still being done, so feel free to recommend it there. Now, please take a look at the latest GINA recommendations for asthma management to see the data behind the changes and why it's so important to ensure that patients adhere to the anti-inflammatory component of their treatment. Again, this is so as to prevent or reduce the severity of asthma attacks. Now, lastly, before I go, I know that PPIs are very important to the emergency setting, so it would be remiss of me to leave without mentioning Nexium, the most flexible PPI available. Of course, we have the IV, for example, for patients with peptic ulcer bleeds. That's actually something we get a request for reminders on a lot. We also have the tablet, which is dispersible in liquid. So patients who don't want to swallow the tablet, they don't have to. And we have the sachets for the kids. But again, let's look beyond symptom control. While GERD can be diagnosed by symptoms, the severity of the underlying disease cannot be determined just by the severity of symptoms. So if you're not doing an endoscopy to confirm, it's important to manage all patients that you suspect have GERD, manage them with a PPI, and one that you are confident will provide the greatest likelihood of healing within the treatment period. Now, I'm confident that Nexium brand offers great efficacy as the only PPI that has the patented MOPS technology, which is actually used to promote the optimal environment for healing. And actually, it's also the most affordable brand PPI. We've done the pricing comparisons, and you can do it as well. But that ends my presentation. Please reach out to any AstraZeneca representative if you have questions, or if you feel any of our resources can support you as you manage your patients with these conditions. But thanks again to JEMA for allowing us the time, and please continue to enjoy the rest of the program. Take care.
Thanks so much, Ms. Tate, for that awesome presentation. And we're going into our last sponsor now, from the Bank of Nova Scotia. We have with us Mr. Peter Mohan. He's the branch manager for Constant Spring Financial Center. Been a banker now for 25 years, a graduate of UWI and Manchester Business School, and I'm told he's with a colleague, Mrs. Charlene Gordon. So after Mr. Mohan speaks, the next voice you'll hear is that of Dr. Fairclough to give the vote of thanks and closing remarks. Over to you, Mr. Mohan.
Okay, thank you very much. Really appreciate you taking the time to allow us to be a part of this session. Before we get started, just like the previous presenter spoke about an inhaler, we believe that right financial planning is very essential for everyone when you think about what's happening out there in the world now. So we are faced with a pandemic, but we also believe that you need to take necessary care to protect your financial position. So we also want to thank all the doctors who are caring for the wider public. We really appreciate what you're doing for us as a country. We're going to start now, as time is against us, and Ms. Charlene Gordon, one of our senior personal banking officer, will be sharing with you some exciting stuff that we know will benefit you and the wider public. Over to Charlene.
Good afternoon. I'm Charlene Gordon. To our doctors and surgeons, we salute you today. Thanks for being in the front line of duty daily. We know the decisions that you make are life-changing. This calls for a clear mind and steady hands. On a daily basis, you do medical checkups. However, today we'll be doing a financial checkup. Today we'll be focusing on financial goal planning. We'll be further examining what projects we could consider as short-term as opposed to long-term goals. Then I'll be sharing with you what products offerings we have at Scotiabank to assist you in realizing your short-term and long-term goals. Here at Scotiabank, we seek to help you realize your goals in the shortest possible time. In setting one's goal, it is important to establish what these goals are. And as financial advisors, we seek to make our clients financially better off, assisting them in making sound financial decisions and making banking convenient and hassle-free. In setting your goals, it would be prudent to write your goals down. What is it you'd like to achieve? This will serve as a solid reminder of what you are working towards. And in financial goal planning, we want to ensure that our goals are SMART. What does the acronym SMART stand for? Specific, measurable, achievable, realistic, and time-bound. Specific. What is it you'd like to achieve? What steps will you need to take to achieve those goals? Measurable. How will you know when you have reached this goal? A, for achievable. Is it in your power to achieve it? Ensure your goals is within reach. Giving yourself a serious reality check. Based on your resources, is it far-fetched? R, for realistic. Can this goal be realistically achieved? There should be a real benefit attached. Last but not least, timely or time-bound. When exactly do you want to accomplish these goals? Setting a timeline is critical for our projects. For financial goal planning, we will be further examining both short and long-term goals. What are some of the short-term loans that we have in mind? Short-term goals. Saving for a down payment on your home. You'd want to ensure you have accumulated at least 10% of your house deposit, as well as additional funding to assist with both legal fees as well as processing fees. Saving for your family vacation. That is also important. We need to take time away to relax and to unwind. Start investing. The earlier you start investing, the better. First, look at your debts, your cash flow, and your immediate obligations. Determine your investing timeline. What timeline you'd like to achieve, what amount. Develop a plan and do your research. Research. Please ensure that you do your research. Know exactly what investments you're getting in and how risky those can be. And for your long-term goals, saving for retirement. We start day one. We start saving today. Are you considering of acquiring your first home? Or are you considering acquiring a second property for investment purpose? These are some questions that we'd like to ask. Backtracking a bit based on short-term goals and paying down debt. How do we pay down debt? Through debt consolidation. At Scotiabank, we do offer opportunities for you to pay down your debts to ensure that you reduce your monthly payments. Especially when you're considering purchasing a new home, you want to ensure that your monthly payments are at a minimum and you're able to take on an additional monthly payment. And of course, you want to ensure that you'll be able to sustain your payments manageable. Because when we think of long-term goals, we think of extended monthly payments. So in essence, short-term goals, these are normally completed or achieved within a period of, say, 6 months to 1 year. We also take into account your need for auto financing. Do you desire to upgrade your vehicle? Thinking of getting a more spacious vehicle as your family size increased over the, say, last 5 years? Of course, we want to ensure that our vehicles are reliable. And as doctors, we work very long hours. And we have very important schedules. Okay? Improvement. How would you like to improve on your home? Would you like a bigger living space, a bigger kitchen, whatever it is? Would you like to do further studies for you as an individual? Or are your child about to leave home for college? Or you might have some personal expense that you'd want to take care of, whether medical expenses, or would you like to increase your earning power or spending power rather? We'll now examine our long-term goals. These are normally completed within a time period of, say, 1 to 3 years. What would we consider as long-term goals? Mortgages, home equity, investment property, or maybe a lot purchase. Are you tired of paying rent? Are you paying a rent of amount of, say, 150, 180 to 200,000? You'd be easily paying that amount for a mortgage. Here you can convert that setting into paying a mortgage, living a more comfortable lifestyle. Do you already own a home and wish to increase on your living space or improve on your living space? As your family increase and you'd like a more comfortable setting, you're able to do what is called an equity takeout based on the value of your property. You can use that an home equity loan to either consolidate your debts or to improve your home. Investment property. In a case where you already own a home and you wish to acquire a second home for investment purposes, whether for rental, in order to increase your earning power. Or are you thinking of a lot loan where you can buy land and build on same? These are some items of concerns that we want to address. And what is it that Scotiabank has in order to have you achieve your goals in the shortest possible time? We have the rates, rewards, offers, cashback. Yes, you got that correct. We do have cashback offerings to ensure that you benefit from your purchases. For your day-to-day needs, we have a suite of cards. First of all, we no longer use our Visa debit cards, but we use our MasterCard debit card, where you tap and go. And for our cards, where you're able to earn rewards. Of course, you make your purchases, but you'd like to benefit otherwise, yeah? We do have our Aero Platinum card, where you can accumulate travel points and convert into an airline ticket in the near future. We have a Gold card, or Gold MasterCard, where you're able to access 2, 3, and 4% cashback based on usage. 4% cashback would be for you using the cards at wholesale clubs. Those are Price Mart, Mega Mart, you name it. 3% at gas stations and 2% at pharmacies. And we also have our Magna MasterCard, where you can benefit from quarterly points rewarded. Doesn't this sound interesting? What else can we offer you for your short-term needs? Are you thinking of changing your vehicle anytime soon? We have some special offers just for you. Are you thinking of acquiring a brand new vehicle, a current year vehicle? For new vehicle financing, we're currently offering 7%, and this rate is negotiable. There's 50% discount on processing fees, and guess what? 2% cashback. Doesn't this sound good? That's cashback for money spent. And for your pre-owned vehicle, we'll be offering 8.5%, and the interest rate is also negotiable, and 50% discount on your processing fees. And we also offer cashback. We will make your experience as hassle-free as possible. We're in partnership with BCIC, so when you're in the process of purchasing your vehicle, we will also provide you with an insurance quotation, so you're able to have your vehicle covered. In processing your auto loan, we also give you the option of adding what is called life and health insurance. Mind you, this is optional, but it's a good thing to have based on what is happening just now. So then you'll ensure that your vehicle is covered as well as you're also covered. Okay, as it pertains to our long-term goals, accessing a mortgage. How will we go about accessing our mortgages? We'd want to increase our asset base. We spoke earlier of investing, and we also spoke of saving. So now that we have saved up our funds for acquiring our new home, we'd like to embark on saving. What is it that we have to offer at Scotiabank? We have the lowest rate in the market for mortgages. So our interest rate is currently at 6.99%. You're able to access 50% discount on processing fees and 3% cashback. You heard me correctly? 3% cashback. This is awesome news. Are you thinking of acquiring a mortgage? We're here, we're available, we're able to assess you on an individual basis and also prepare what is called a pre-qualification letter. So you're able to meet with your realtor and you're able to identify the price house or the value house that you actually qualify for. We will assess your situation, see what your financial position is, and what monthly payment based on what's happening currently you are able to take on. So at Scotiabank, we're here for you. We will ensure that you do not overextend yourselves and do not deplete all of your savings. So if you're thinking about acquiring a remortgage, please remember you will need to ensure that you have your 10% deposit. Worst case, we can have a look at a 5% deposit. And also, you need to ensure that you have sufficient savings to cover processing fees as well as legal fees. And, and depending on the condition of the property, you might want to do some changes to the living space, some improvement in order to make the area more livable. Is it that you already have a mortgage at another financial institution? Would you be interested in switching your mortgage to us? Our rate currently is at 6.5%. That is very interesting, isn't it? And in processing your switch mortgage, we'll give you 50% discount on your processing fees and 3% cashback. Yes, you heard me correctly. That's 3% cashback. In planning for your long-term goals, it's important that you look at what resources you have, what your monthly obligations are, and can we take on any additional payments? Do we need to consolidate existing credit facilities to take on additional obligations? Yes, we need to analyze your situation, right? So, in wanting to increase your asset base, we'll also need to ensure that your debts are at a minimum to ensure that you're able to pay your mortgage payments comfortable and to be able to sustain those payments. Because as we know for mortgages, those are normally over a longer time period, say 25 years into 30 years. And we want to maintain that lifestyle that we're used to. And in summing up and in closing, I'd like to leave this quote with you from Sus Orman. It says, a big part of financial freedom is having your heart and mind free from worry about the what ifs of life. I'll repeat that once more. It says, a big part of financial freedom is having your heart and mind free from worry about the what if of life. Let's not dwell on the what ifs, but let's be proactive and plan wisely for our future needs on our way to financial freedom. Please give us the opportunity to assist you in realizing your dreams. And here we have our contact from Peter Mohan, who's our team leader and branch manager at the Constant Spring Financial Center, and myself, Charlene Gordon, who's a personal banking officer at the Constant Spring branch. I provided my email address as well as my contact details. I can be contacted at 876-382-7251. Thanks for having me. Does anyone have any questions? Hello?
Thank you, Mrs. Gordon, for that informative presentation. So we'll go into the vote of thanks. So good afternoon again, all. And my name is Garrett Dijon Fairclough, and I'm a first-year emergency medicine program resident and also the public relations officer for the Jamaica Emergency Medicine Association. I deem it a great honor and privilege to propose the vote of thanks today for this memorable occasion, the completion of another scintillating JEMA conference. Allow me first of all to start by giving glory to the Almighty God for making today's conference a success amidst the ongoing health crises which have impacted even the mode of delivery of such events like these. Therefore, since modes like these are now new to us, and where there's a will, there's a way, special commendation must be given to the JEMA team, with past and present, helmed by Dr. Hudson and Dr. Hugh, for executing this virtual conference so seamlessly. Thanks to the Emergency Medicine Department at the University of the West Indies for their unstinted support to today's proceedings. This extends to include the Emergency Medicine Department and hospitals across the island and the Caribbean, and the brilliant representation of these entities by the distinguished panel of presenters, Doctors French, Delahaye, Ho, Dasgupta, Venugopal, Paul, and Glegg. And thank you also to our keynote speaker, Dr. Aaron Sayal, for contributions of wisdom and expertise, which will no doubt be useful in our everyday clinical practice. To our sponsors, AstraZeneca and Scotiabank, and their representatives, Ms. Danielle Tate, Mr. Peter Mohan, and Mrs. Charlene Gordon, who graciously accepted an invitation to assist with the execution of this conference. Your continued support to medicine and academia is noticed and appreciated. For the attendees, in an environment with multiple Zoom meetings and virtual events, we're honored you chose to spend your Sunday with us, and I do hope our Sunday offerings were ample food for thought. In closing, I wish for us all continued health and development in 2021, and that we all continue to dream, for it is Eleanor Roosevelt who said, "The future belongs to he who believes in the beauty of his dreams." So until next time, be safe, be motivated, and be blessed. Thank you, everybody.